अब ले रहे हो ना यूट्यूब
159 को आप लाइव कर रहे हो।
Hello. Good morning. Do you hear me?
Yes, good morning
Hello.
to everyone.
Good morning.
How is Visochi? How are you?
Fine, thank you. How are you doing? Great job. Great job.
No, it's all me and your combined effort. I told number of time.
Ciao Domenico, come stai?
Buongiorno, prof. Bene, lei?
This is the Italian day. Yesterday also was Italian day with the Franco Servadei, Corrado Iacavito e Davide Locatelli. And I'm so happy about that. And many outstanding Indian speaker, Congratulations. Very good. So the meeting is going to start in 15 minutes, right, Virendra?
Yes.
Yeah. And we will have a brief keynote of Basant Kumar Misra. Okay, that's okay. Come sta il professor Cappabianca?
Prof, bene. Sempre
Bene.
in pienissima attività. Non in piena, in pienissima attività.
Ma non partecipa mai a queste riunioni?
That is
Poco.
unfair conversation. Please talk in English or in German.
Genau.
It's a long time that we don't meet, and he is one of the pupils of Professor Paolo Cappabianca that for sure you know and remember, because he's one of the endoscopic transnasal neurosurgery founder in Italy, along with Professor
Giorgio Frank.
Come si chiamava il maestro di Cappabianca?
De Divitis.
Professor De Divitis. And now, at present, he's the president of the Italian Society of Neurosurgery. So he's so devoted to seminars, webinars, you know. And I wish he could attend this outstanding presentation and taste directly how high profile are the presentation, the organization, and the number of attending colleagues.
Well, Keith, we don't know exactly where this is likely to end up because, of course, it's a moving feast. And as the virus changes course, so do our responses to the virus. And we may do more, we may open up less. So it's hard to say exactly, but people are saying if you look at the current trajectory,
I think that the World Federation of Neurosurgical Societies is well represented in this meeting. Many high-profile officials, starting from the president up to the many others. So I enjoy so much this connecting spirit of these scientific occasions. Next Congress in presence, hopefully, should be in next year, right? Is it correct, Virendra?
Yes.
22. Which month?
22 March.
March, I see.
March, yeah.
And so also our committee will undergo to a new evaluation for assessment and possible confirmation of our political strategy. I think that we are doing an interesting job in both sides of the world by organizing monthly meetings and webinars, and I'm so happy that many outstanding neurosurgeons accept to participate. This is a good signal for us.
And I think we have 113 speakers involved for our webinar. Yeah, it's a very good number.
Yeah, very good. Yesterday it was 150 participants. Very high number. Very high.
And in all, 610 participants clicked. They come and joined and then left. So it was 610 and 100 on YouTube and then WeChat. So it was good number of participants.
Good number. Many questions. Questions. Many comments. So it's a very brilliant and sparkling meeting.
because we are broadcasting on WeChat, Zoom, and YouTube, and Neurosurgical TV also. We involved.
And also on LinkedIn,
Yeah.
there was a great deal of interest.
Yeah.
Yeah.
Henry Shuler guy, he cannot talk. Henry Shuler cannot talk.
No, it's okay. It's
It's
already,
okay,
it's already
Henry?
okay. Yeah, they
Okay,
already
okay,
unmuted
okay.
it.
Okay, okay.
Problem solved.
Solve. You
Yeah.
solved everything.
Who is the moderator of this session now?
You are Dr. Dudani because Suresh Dugani because Dr. Sanjay Bihari wife going for small surgery under GA, so he couldn't join, and Dr. Dev Pujari will join after some time.
Good.
So, yeah. So Henry, how is Germany scenario of COVID?
That's very good. We go to the restaurant tonight without
Oh,
any
good,
tests.
good.
Yeah.
Enjoying. And
Now we have a very low number. I think we have below 6 per 1 week per 1,000.
oh, good.
In my
Excellent.
area, we have 0.4, so it's very low.
And you
But-
start, okay, and you are doing all surgeries.
Yeah, we have now back our third theater. We had only 2 because of COVID. Now we have each day 3, so it becomes better and better. Fortunately, but we are afraid about the Indian, or now called Delta variant of the virus. It's really spreading very fast. Also in Germany, it was initially just 1 or 2%. Now we are up to 15% of all infection is a Delta variation.
But nothing
This
is
a
from India.
problem.
Nothing is from India.
Yeah, I know.
Hi, Henry. How are you doing?
Hi, good morning. Still good.
Good morning.
Still waiting for the Indian virus.
Yeah, you are always good. Why still? You are always good.
No, now it's good. Yeah, everybody's very happy. My boy, he can meet his friends. They have parties, and so. But you know, it's not over. It will come back again, and we have to be a little bit careful.
No, but right now in India also we are okay, but they are all gearing up for the third wave. They call it. I don't know how many waves. I mean, but it's a big apprehension that we'll have a big number because of the Delta variant, which is so we don't know. We keep our fingers crossed. But right now it's okay. It's okay.
It's very good. Yeah. It's really terrible, very terrible.
I don't know. I mean, it's going on for, I don't know how long. I mean, somebody said it takes 5 years. I think there is the British scientist said that for all the variants to be controlled, it will take 5 years.
Oh,
Maybe.
I don't know.
so it's a silent world war.
Yeah.
It's like iPhone 13, iPhone 13A, iPhone 13B. only probably only Xiping knows which model he's releasing.
Yes, but iPhone is a pleasure. This is a pain. That's the difference.
I know.
This is a nice example. Yeah,
that's what is happening. See, you said Delta A plus, Delta B plus. Earlier you said this variant, that variant. Every 3 months we are getting one variant. So we don't know what's actually happening, and every time it comes severe variety than the previous one. And as you said, maybe 5 years we have to meet like this.
That's a British scientist who is an epidemiologist. They have commented. I mean, I saw it somewhere in the
Right.
And we will get a yearly vaccination.
Yeah, I think you have to go for a booster every year, like flu.
Yeah, exactly. Yeah.
But the only problem comes, suppose the Delta or other variant it comes, will the vaccination what we are using at present, will it be beneficial, useful to prevent it?
God only knows.
Yeah.
That's the problem.
Because see, if it is changing its behavior, if it's changing its nature, then what we have now is for the first variant, first time when it started. What all it has undergone changes, we don't know, but we are taking it for the first wave, the vaccinations now.
How's the COVID situation in India with the variant? Is it so difficult to counteract, or what's your opinion about that?
Supposed to be more severe and much more infectious, so the numbers are small still, but they are very worried because there are numbers. It's not big numbers, Delta variant in India, but it is there. So the place where they have a lot of restrictions in that place. So from a national lockdown now they have kind of depending on where it is and what sort of numbers you have. So they have a kind of a graded lockdown depending on graded restriction. Different cities, different states have different restrictions now.
And what is your opinion about activity of the classic vax on the Indian variants? Is it effective or less effective?
No, it's not Indian variant. It is Delta variant. Yeah. It's Delta.
No, in Europe, we know it as Indian, probably.
Yeah, that's unfortunate.
Yeah, but for simplify, yeah.
So,
but they changed because of this discrimination. They changed it to Alpha, Beta, Delta.
Yeah.
Can we start our meeting?
No, we cannot start. We have now a more important topic.
Okay, so it is 2:14 hour as per Indian Standard Time. I think we should start it. And good afternoon from India, and welcome all on the second day of academic session. Yesterday, there were many people who could not join this meeting. So I will be showing first video of Professor Sir Graham Teasdale, who gave us blessing message for this meeting. Okay.
Hello, greetings from Scotland. Prof. Sina, Vivendra, colleagues and friends. I regret that I'm not able to be with you, but it's a great pleasure to send you my best wishes to all taking part in this historic Congress, the first joint meeting of the WFNS Neurorehabilitation and Reconstructive Neurosurgery Committee and the Neurotrauma Committee of the Asian Australasian Society. Especially congratulations on making it happen with all the current difficulties of the COVID epidemic. On a personal note, it's a special pleasure that the meeting is based in Jaipur because connections between our two units go back many years. To 1983, when Vivendra's predecessor, Dr. Subhash Darkar, came to Glasgow as a visiting fellow, and have continued over the years with exchanges between our departments. Back in the 1980s, neurotrauma was also referred to as an epidemic, but as a silent epidemic, because little was known about the scale of the problem or how victims were best managed. Rehabilitation was also an undeveloped field, and reconstruction barely thought of. Since then, much has changed, and the participants in this meeting and your parent societies have played an important part in drawing attention to the issues in these fields, both as to their scale and the opportunities for advancing the care of the many victims found in all societies. Your program is wide and varied. It will provide a fascinating picture of how advances over the years in neurotrauma, neurorehabilitation, and reconstruction are improving the outcome of patients in all parts of the world. I give you my best wishes again for a successful meeting.
Sir, thanks for your kind words. The world of neurosurgery Neurosurgery is grateful to you, sir, teaching us the way. We truly cherish your visit to our city of Jaipur in benign presence of our mentor, Professor S.R. Dharkar. Thank you, sir, for your kind words and message for this meeting.
Thank you, Professor.
I call upon Dr. Amit to coordinate the session. Thank you.
Thank you, Professor Sinha. Good afternoon to all. Today's first session is on neurorehabilitation and reconstructive surgery. The moderators for today's sessions are Professor Henry Schroeder, Professor Chandrasekhar Diopujari, Professor Suresh Dugani, and Professor Sanjay Bihari was supposed to join us as a moderator, but because of some personal commitments, he will not be able to make it. Professor Henry Schroeder is Chairman, Department of Neurosurgery, University Medicine in Greifswald, Germany. He is President, International Federation of Neuroendoscopy and ex-chairman of Neuroendoscopy Committee of the WFNS from 2014 to 2017. Professor Chandrasekhar Diopujari, he is heading the Neurosurgery Department at Bombay Hospital, Institute of Medical Sciences, Mumbai. Chairman, WFNS Neuroendoscopy and Neuroendocrine Committee, Founder President, Neuroendoscopy Society of India. He is the past president of NSI, ISPN, AASPN, ISNO. Our third moderator, Dr. Suresh Dugani, he is working as a professor of neurosurgery in SDM Medical College, Dharwar, Karnataka. He is an alumni of the prestigious NIMHANS Institute. He was also trained and worked in England, Newcastle upon Tyne. I request the moderators, please.
Still in mute, sir.
Am I audible now?
तुम इधर आ जाओ. Just he will change the position.
Apologies for the technical glitch. Our third moderator, Dr. Suresh Dugani, he is working as a professor of neurosurgery at SDM Medical College, Dharwar, Karnataka. He is an alumni of the prestigious NIMHANS Institute. He was trained and worked in England, Newcastle upon Tyne Regional Neurosciences Center. He has presented more than 137 papers and published 36. I request all the moderators to grace the virtual podium. Today's keynote address would be by Professor Basant Kumar Mishra. He is the first Vice President, World Federation of Neurological Societies, Honorary President, AASNS, President, WFNS Skull-Based Societies, Head, Department of Surgery, Consultant Neurosurgeon, Section Coordinator, Department of Neurosurgery and Gamma Knife Neurosurgery, Radiosurgery, PT Hinduja National Hospital and MRC, Mumbai, India. Professor Mishra, please could you deliver your keynote address?
Thank you. Thank you very much for this kind introduction. I will share my screen. Can you see my screen and can you hear me?
Yes, yes, you can. Please go ahead.
Many thanks again, Dr. Sinha and your team for doing an excellent job. It's been a privilege to be part of this, and thank you for the invitation. Dr. Sinha asked me to give a keynote lecture, and I thought maybe I would talk about a little bit of challenges and reflections over my last 40 years, basically addressed for some of the young neurosurgeons who may be attending this webinar. There are many important lectures you will have in this session on reconstruction. The one I don't want to deal on that because there are very nice talks which will be followed. I'll just tell one sentence: be it head injury, skull base, vascular, or spine, is critical to plan the reconstruction before the incision. My journey is of 4 decades, and this is where I spend my time. I trained at AIMS, Delhi, and that was my alma mater. And then I was a faculty at Sri Chitra. I spent my time as a lecturer of University of Edinburgh, and then registrar at the Western General Hospital. And finally, I moved to Hinduja Hospital in Mumbai. I've been there for the last 20 years. Just before I go on to my talk, I had very pleasant memories of Professor Graham Tisdale. I spent some time during my stint in Edinburgh. I used to go and learn he used to do the microadenoma, microadenoma, pituitary microadenoma endonasally. And we used to have understanding from Western General Edinburgh and Scotland, Glasgow, to exchange the registrars. And then I used to go every time when he had a case, he would inform my Professor Miller, and then I would go there to learn from him. The fantastic gentleman, very good teacher. And so it's been a privilege to have association with him. I have the fortunates of having exceptional teachers. My teachers were Professor Tandon, Professor Banerjee, in AIMS, known very well to many who are here in this and all over India. And after my training, I spent, as I said, in Edinburgh, Western General Hospital and Royal Infirmary under Professor Douglas Miller. I learned my acoustic from Douglas Miller and Brian Dale. I couldn't get a photo of his. He's the ENT colleague of Dr. Miller, and who taught me how to do the internal auditory meatus drilling, actually. My initial interest was on traumatic brain injury because, as you all know, Professor P.N. Tandon had a tremendous interest, and he's been instrumental in developing and improving the facilities in all over our country. And in fact, my first 2 publications were on, as a resident from AIMS, was on traumatic brain injury. And of course, the interest continues, and this was last year we published it. But as many of you know, in the 80s, cerebral vascular surgery was very glamorous. Everybody wanted to be cerebral vascular surgery. That was the kind of golden neurosurgery. So was I. And I'm very, very grateful to Professor Banerjee, one of my teachers, who had a tremendous interest in that. And he would push us to go to the lab. And we were in the first generation of residents in India who were trained in microsurgery, including microsurgery in the lab. And number of carotids we could do, bypass. I learned from there the microsurgical technique. And I was probably the first resident in AIMS because those times aneurysm was, clipping was a big thing. The first resident to have been given a independent microsurgical clipping of this was the aneurysm of a PCOM. And Professor Banerjee was operating in another theater and asked me to clip it. Of course, it bled, and we finally managed to salvage, and the patient survived. So that was a milestone for me. And that interest continued and continues till date. And this was one of the important things which happened in India. The first direct high flow bypass, when I was in Sri Chitra, we did it on 15 June 1994. And fortunately, that was successful. But the next, in 5 cases, 2 patients died. Second patient from sepsis, and the 5th patient from myocardial infarction. You can't give up. You have to be persistent. You have to have that obsessive compulsive personality to be successful in neurosurgery. I would quote Swami Vivekananda: take up one idea, make that one idea your life, think of it, dream of it, live on that idea. Let the brain, muscles, nerves, every part of your body be full of that idea, and just leave every other idea alone. This is the way to success. And that was my dream, to be a good cerebrovascular surgeon. And the interest continues, and we have had multiple publications, papers, and teaching programs, and which continues till date. However, when I moved to Sri Chitra, my boss, my senior professor, was interested also in cerebrovascular surgery, not unusual those days. And so I was forced to do skull-based surgery, which I had actually no knowledge about it. But I'm really thankful for all those who said no. Albert Einstein told no to me, but it's because of them I'm doing it myself. And that is when my journey in 1987 I started. And this was the first series of 11 cases of retroclavian meningioma we presented at the NSI in 1988. And that was a lesion that time. And this is one of those cases from that time. This was one of those lesions which was thought inoperable. And the interest continues. And this year we published. And acoustic, as I said, I learned from Professor Miller and Professor Dale, the NT colleague of his. And this was my first patient in 1986, where I could preserve the face and hearing preservation. Douglas Miller was a fantastic boss. He would just guide you, and he was very academically oriented. He was very busy in the teaching program, publication, and you will be always there in the OR, looking over you and asking, is that okay, BK? Is there any problem? And this is the first patient when he preserved it, and he was generous enough. We had a meeting, combined meeting from Edinburgh with Newcastle. So this meeting, I was asked to present, and Douglas got up and said it was done by BK, not by me. I said that was very generous and very kind of him. And that is where my interest continued and continues till today. And this was the first series in India in '93. We presented in Chennai, where we consecutive 100 cases, we had a preservation of hearing 30, and that was the first series which made some news. That was from Sri Chitra. It continues, my interest continues, and we have had many recommendations and many contributions to this subject till date. It's a balancing act. It's a significant challenge for especially neurosurgeon in the lower middle income countries, and was much worse than what it is now. Now my younger friends are doing much better than what we did those times, but it can be done. I'll give you just two examples of Abdul Kalam, one of our presidents of our country, India, as we all know. He was born in a very humble Muslim family. He distributed newspapers while in school, but he dreamt, and he dreamt big. He was the missile man. The successful missile program of India was founded by him. He got the highest civilian award, 97 in Bharat Ratna, and finally he became the president of the Indian country. So he started very, very small, but he dreamt big, and he could do that. So this is another unknown Indian who is my hero, who is my father actually. And he was lost his father, left his home, and everything he did on scholarship. And finally, he passed away 2 years back at the age of 99. And he wrote his Pursuit of Destiny, and he told me the passion and persistence makes your destiny. You can make your destiny with passion and persistence. So some of the highlights my career, why I'm showing it. And this is the dream. This is 2017 World Congress. After my plenary talk, Professor Yasser will congratulating me. Why I'm showing it? I'm showing it because if I can achieve it, anybody from any lower middle income country person can achieve it, and they would do it better. And many of them are doing it better. Because I came from a place, beautiful place, but a very small city, not known to many in the faculty here outside India. Many people don't know this city called Bhubaneswar in a eastern part of India, Odisha state, unknown area. But if I could achieve this, anybody could achieve it. Because to my young friends, as Mahatma Gandhi said, it's not too late at all. You just don't yet know what you are capable of. Dream big, have a passion, be persistent, and then you can reach the stars. And again, I tell you, for all my young friends, everybody is special, and find that special person in you. And this is something which actually heard. I had heard about this before, but do you know, I heard this from Fred Gentili. About 10 days after his brain surgery, he was addressing the graduate ceremony over the internet. And he quoted this. So I got that sentence from him. It's a beautiful sentence. Find that special person in you. So thank you very much. I'll block your dates for this meeting, which we are organizing virtually, the World Federation Skull-Based Surgery 2021, along with the 10th INU, many of the faculty in this meeting between July 23rd, 25th. Do join us. It would be a good feast of academics. Thank you very much for your attention.
Thank you, Professor B.K. Mishra, for such a fantastic and inspiring keynote address. Thank you once again. Now, may I request the moderators to carry forward the session?
Okay, thank you. So I want to welcome everybody to this webinar organized by Virendra Zina. Thank you for this effort to promote teaching. I want to welcome my co-chairman, Dr. Dugani. And I think we start with our first speaker, Professor Visocci. Is this the right explanation? He's from Rome. His special interest is in craniovertebral junction, and he will give us a talk about new trends in craniovertebral junction decompression reconstruction. Please.
Good morning. Do you hear me? Hello, do you hear me?
Yes, we hear you.
Yes,
yeah.
yes.
Just try to. I don't find the button for sharing. I don't know.
Screen.
How to do.
On the lower, you have to click on the lower part of your screen, and then there's a line coming up. And there's share screen.
Okay. Okay. Do you see my screen?
Yes.
Yes, perfect. Do you see my slide?
Perfect, yeah.
Perfect. Dear Virendra, dear moderators, dear Basant Kumar Mishra, allow me to spend few seconds of word to really thanks all of you. But right now, especially Dr. Mishra, since he moved me when he was remembering his father and the fact that the father was an humble person, and he was thanking him for generating him and teaching him life. I appreciate so much this respect and honor you tribute to your father, we tribute to our origin, our roots that make us possible to meet today and to share each other experience. Thanks so much. Thanks, Virendra. Now, my presentations deal with the craniovertebral junction surgery. As you know, this is an ideal anatomic segment confined between the foramen magnum and inferior third of the skull base, the clivus, up to the C2 body. There is a very popular motto in United States: many ways to skin a cat. Exactly what happened when we deal with skull base and the craniovertebral junction, and we try to plan and program surgical strategies. And since these topics very complex, difficult, and very variable according to personal surgical experience, we try to collect in our book all surgery strategies considered all over the world, and especially we try to better understand and investigate on biomechanics as we could record in this book of Enrico Tessitore. But which is the background? The true origin of our interest is the anatomic research and the cadaver lab. But cadaver lab needs soldiers, people's motivated with the right attitude to involve themselves and spend their energies, like medical students. Medical students are strategic in this scenario, and helps us to arrange a sufficient, effective cadaver lab able to approach and master craniovertebral junction surgery by establishing special targets for cadaver lab with limited researchers. We specialize in preparing heads and studying them with neuronavigation in order to better investigate 360-degree, the better approach, and tried to explain why each approach must be considered as the best approach for that special condition. And with this colored algorithm and panel, we try to investigate anterior and posterior direct approach, anterior and posterior oblique approach, and lateral approach. Anterior and other lateral approach are the most used all over the world. This is the submandibular retropharyngeal approach in our cadaver lab, but the same posterior approach, direct posterior approach, is the classic one that we every day use for tonsillar herniation, Chiari malformation, posterior fossa tumor, etc. But when we deal with the oblique approach, the posterior lateral approach, and the anterolateral approach, we deep more and more with the complex local anatomy that make this region also risky and challenging. Also, anterior transnasal, transmucosal, transoral approach are a challenge, since we used neuronavigation and intraoperative intra-cadaver lab CAT scan. We could better investigate in transnasal and transoral approach by using both and measuring in the sagittal plane the surgical domain of transnasal, transoral, transnasal, transoral, and in anteroposterior projection, the surgical domain of transnasal, transoral. It appears clear that transoral approach allows better surgical domain and allows us to better fit with this challenging region. Also, with the isolated head and neuronavigation in our cadaver lab, we had the opportunity to confirm that transoral approach is better offering surgical opportunities on the sagittal plane and on the coronal anteroposterior plane, and the volumetric evaluation again confirm the better domain of transoral among the transmucosal anterior approach. We also find out a red line, which is the preoperative line, allowing us to predict how high, how much up we can reach the craniovertebral junction when we perform a transoral approach, compared to the transnasal approach that you can easily identify in this slide. The green dots means what you can reach with transnasal. Transoral approach allows to better control the lower part of craniovertebral junction. And this is our finding. So concluding our experience with the following sentence, that the better approach doesn't exist. The problem is to tailor the association of a different approach, as in this case, or to choose the best approach for that specific case according to endoscopic and neuronavigation assessment and assistance that we can provide in our surgical room. Neuronavigation, along with the endoscopic approach, has been the warrior horses of the last decades. But right now, as you can see in this slide, the new entries are the O-arm or the CAT scan in the operating room, along with the exoscope with 4-key screen, which provide better magnification compared to the classic microscope, and real-time, reliable assessment of what we have done from a surgical point of view in terms of decompression and surgical removal. And this is our experience, published in one of the most recent issue on craniovertebral junction, concluding that exoscope is a new entry, very interesting, but it has a learning curve and some logistic problems which may produce some uneasy situation during the room. On the other hand, O-arm is very effective in the reliable assessment, real-time assessment of the decompression amount. Nevertheless, could be misleading in posterior stabilizing and fixing surgical procedures. And in our opinion, this is what news on craniovertebral junction surgical strategy. Thank you so much for your attention.
Thank you for this interesting talk. Should we discuss each paper after each other? I think it's better because of such different topics. Do we have enough time? Then please, are there any questions?
No, I think, Henry, the thing is, after about 3 talks, we can ask for the question and discussions. That's what.
2 talks.
3 talks.
Okay. Okay, then
Every
let's go.
3 talks. To the next speaker. Next speaker. Hello. Yes. Now it is my pleasure and honor to welcome Professor Shashank Sharad Kale to present his work on complex reconstructions of cervical spine, a short series. Professor Kale is at present head of the department Neurosurgery, the prestigious All India Institute of Medical Sciences, New Delhi, and he's member WFNS Neurorehabilitation and Reconstructive Neurosurgical Committee. Please, Professor Shashank, take over the screen. Thank you. We can start sharing your screen.
Okay, thank you very much. Am I audible?
You are audible. Yes.
Okay.
You are.
Okay. Good afternoon, everybody. That is good afternoon by the India time. My thanks go to the organizers, Professor Sinha, who has done an excellent job with his team. Thank you to the moderators for giving me this time. And share. So, okay, can you see my screen now?
We can see. Please go ahead. Go ahead, you can see, yes.
So today I'm going to talk a few minutes on the complex reconstruction of the cervical spine. It's basically a collection of a few cases which I put together. Now, reconstruction could mean a lot of different things, but in spine, the cases I'm going to discuss, this reconstruction means basically some kind of deformity correction. Okay, let's go ahead. So the flow of this talk is going to be, I'm going to show some complex cervical spine deformity cases, many of them Marfan syndrome, and then round it off with an unusual case which we had to manage in the last couple of years or so. So here's the first case. This was one of the earliest cases of cervical spine deformity, which I had to encounter in the department. It was a young girl, 8-year-old, and she was walking till the age of 3 years, and then she kind of regressed in her neurology. When she came to us, she had this X-ray. She had been managed at some other institute by putting a halo vest and putting a jacket of sorts to try and stabilize her neck deformity, but it did not work. And she was quadriparetic, could not walk, with brisk reflexes and upgoing planters. This was what her CT scan and the MRI looked like. So I figured that, okay, the C3, if you see, I don't know if you can see my arrow, the C3 vertebral body seems to be the sharpest point of the knuckle, which is pressing on the cervical spine. And somehow if we can straighten this out and get this knuckle out of the spine, things would be better. But it was a very small child, and she was not a very well-built child, a very small stature. And if you look at the pedicles of the spine, they're so small that I thought, I don't know if I can do something from the pedicles. It's very small bones, and the screws we had were quite big. Anyhow, so I was wondering how to go for anterior or how to go posterior, what to do. So we finally ended up doing this, just a posterior fixation after getting the spine straightened. And if you see, you can see the top of a cable over here. So there was some atlantoaxial dislocation as well. And we reduced the atlantoaxial dislocation and then did an occipital-cervical fusion. We did not go anterior. So this was the final result. In fact, this X-ray was taken 2 years after the surgery. So you can see that it's better than before, but it's not all that great. The spine doesn't have a normal anatomical curvature, but it's definitely better, and her spastic quadriparesis did improve. However, she had other problems which we had to encounter. This is the full picture of the little girl. You can see the neck was already operated, and then she had this big deformity in the lower spine, and a 94-degree curve at the lower end of the spine. So what we did was new to me. I mean, this X-ray must be about 8 or 9 years old, maybe 10 years old. So the growth rods were a new thing which were introduced at that time. And we used the growth rod in this little girl, and we kept on increasing the distance between these two rods. If you can see, this rod keeps on expanding. So as the child grows in her height, we try to maintain the curvatures of the spine. And it worked very well till she attained puberty and stopped growing. Unfortunately, she had more problems. Her disease was actually Morquio syndrome, some kind of a connective tissue disorder. And she developed problems with the other joints, the hip and the knee. And she's up for joint replacements at many of those 4 joints. I think that she has had 3 joint replacement surgeries since we did her spine. However, she could walk till the joints gave way. She could walk well, and now she's waiting for her joint replacement surgery. So that was the first case. And then this young girl came, a 20-year-old with neck pain for 3 years and a fixed neck deformity. This was what her pictures looked like. And the X-ray showed that even in full extension, the spine was kind of, it was not normal. There was reversal of curvature and the spine was fixed. So again, we were wondering how to tackle this. The rest of the examination showed she had a gentle scoliotic curvature, but we thought of leaving it alone because there was not much curvature there. So what we did was a anterior posterior approach, cages in places of disc and anterior plate, and then a posterior lateral mass and a rod. And that straightened out her spine quite well. And she did well in her life. And she got married and has started a family of her own. So marriage is a big issue. And then we had this 15-year-old with typical Marfan syndrome. You can see practically every sign described in the book in this young man. The thumb sign, the wrist sign, the palate, the teeth, the fingers, the toes, everything. And he had this horrible deformity of the neck where the C2 seemed to be slipping over the C3 and touching the C4 vertebral body. And the C3 again got pushed inside and causing pressure on the cervical spine. So I remembered that little girl which we had operated a few years ago. And this time we were a little more brave. We actually did a posterior first, then anterior, and then back to the posterior. We first went from the back, loosened up all the joints, put in all the hardware, the screws, and the occipital plate. Then I came anteriorly, did that corpectomy. And after closure, we finally went back to the posterior incision and put the rods and stabilized the spine. So these are some of the pictures, some of them intraoperative, some of them postoperative. And the final picture is this young man. He gained another 20 millimeters since this operation. And you can see two hands holding up his elbows. He had some weakness of the hands. And that's my resident standing behind this patient. So that's what happens with Marfan syndrome. They grow really tall. Anyhow, so we have follow-up of 6 years now with this patient, and his neck is holding out fine. And you had to fashion the cage. I had to fashion the cage. If you see, the top of the cage is kind of sloping, but the bottom is straight. So depending upon the deformity you have and the shape of C2, we had to fashion the shape of the cage so that it fits in and stays there. And luckily for us, it stayed there. And then once you start doing these things, they seem to get a momentum and more cases keep pouring in. There was another young man, a 10-year-old, smaller. And this time you see there seem to be two vertebral bodies buried inside C2 and C5. So this horrible deformity of the neck. Somebody had tried this halo. It wasn't working. Again, spastic quadriparesis. He had other features of Marfan's. He had a valvular disease of the heart and other problems as well. So again, we thought, okay, we're going to do the same thing. Back, front, back. And that's what we did. We did back, front, back for him too. And these are some of the pictures. First went in from the back, put in all the hardware, then came from the front, did this 2-level corpectomy, straightened out the spine and the cage and the plate, and it looked quite all right. And the image on the right, this image is the final construct after the surgery. Again, we have a good follow-up of him. He went on to have a valvular defect repaired for his heart, and he's doing all right now. His spine is holding, and this construct is working. And in fact, a couple of years after the surgery, we had scanned him just to make sure that there's bone growing, and you can see a good bone growing inside the cage. So he was doing fine. That's the cage with the bone graft, and it seems to be fusing at the top. And since then, he's doing all right. So then we collected, over the years, we've had about 8 or 10 cases of Marfan syndrome. So it's basically a misfolding of the fibrillin 1 in the connective tissue. The presentation is variable. It could be mild, or it could be a severe form of Marfan's. A distinguishing feature of Marfan syndrome from other Marfanoid syndrome requires the assessment of non-skeletal clinical and lab findings, especially of the eyes, of the aorta, and the heart. So the true Marfan syndrome would have one of these, problem of the eye, the aorta, or the heart. But there are many Marfanoid syndromes which may not have all these heart or aortic or eye problems. So it's a debilitating and a challenging problem, especially when it affects the spine. in the literature described, the syndrome-associated kyphosis is rare. My aim was to achieve neural decompression, try and correct the deformity, reconstruct the spine, and make sure that he reaches puberty safely so that he stops growing. So we thought this combined anterior-posterior approach, actually posterior, then anterior and posterior approach, a staged strategy, this gave us the best results and the best correction. I would like to show an interesting case in the end, just to round up the deformity. We had this 32-year-old lady, progressive neck pain and deformity. And for the last 6 years, she was unable to look up. She just could not look up. Her chin had fallen down, her neck had fallen down, the chin was resting on her chest. So a typical chin on chest deformity. And she had ankylosing spondylitis with all its manifestations, including eye problem. And this was what her CT scan looked like. It is difficult to imagine the anatomy just based on the CT scan because the deformity is quite severe. So to plan a correction, the CT scan was not enough. So what we did was we made a 3D printing technology we used, and we actually printed the model of her skeleton, or at least the skull, the cervical spine, and the rest of the spine. That helped us understand the anatomy. Then we did some mock runs. We tried to see how am I going to place this patient on the operating table. It was quite difficult. We realized that we cannot use the O-arm. So navigation will have to be difficult. It will have to be based on a previously acquired image, and we won't be able to acquire images on the table, at least not from the O-arm. And finally, after a lot of deliberation, this was the position we could safely operate the patient. It's kind of a sitting position one would use for an acoustic or other supracerebellar approaches in neurosurgery. That was the best. This was the horizontal position she could be in. And this is the position we operated in. This was the incision which was planned. Pretty standard, nothing special about the incision. The planned surgery was this, that do a wedge osteotomy, basically to reduce the bone and so that we can correct the deformity. And that is what we tried to do. Go through the pedicles, go into the body, take out the body from inside, and see that the bone is gone in that wedge shaped so that we can correct the deformity. And this was an intraoperative picture, and we could more or less achieve what we wanted to. You can see all the roots and the cord quite clearly, and the hardware in place above and below the place where the correction is going to be. These are the roots which you can see. So this was what was intended, that you take out that wedge of bone and then you bring the two ends together to make a correction. And then once you hold the neck together, you stabilize it by putting the rod and correcting the problem. And this is exactly what we did. Once we had done the osteotomy, we just straightened the neck by holding this holding the head and bringing it, making it straight. A short video, and there was a lot of excitement in the theater. I remember there must have been at least 15 or 20 people watching at that time, and somebody was monitoring her vitals and heart and blood pressure, and oh, what's going to happen? Dr. Kale is going to break her neck, and we literally broke her neck, except that we had things under control. And that's what happened. I think I'm going to just skip this video and in the end, after the correction, you can see my assistant has got his whole hand under the chin. So from the position where the chin was resting on the chest, we now had her quite straight. So this was the new position in which the head was fixed. We went ahead and completed the operation by putting the rods from the back and then having some transverse connectors. And this was the final result. You can see how acute an angle the cervical spine made. And after the correction, this was what was achieved. She could at least look in front of her eyes. She could look at her children. She had 2 small kids, which she had unable to see them. And now she could probably get on with her life. So this was not the end. There was work in progress. We did the similar operation in the dorsal spine as well to make her more straight. And then finally, we had to address the CV junction problem. After the second surgery, that is the dorsal correction, she refused to have anything to do with us anymore. She said, I'm done. I can look straight. I can walk straight. I'm fine. I don't want this. Her neck is rotated if you see the picture. I don't want any more correction. So this was after the first surgery. She became much better after the second, and she refused the third surgery. And she's doing fine with this correction. Her construct is holding. Her neck is straight. Her ankylosing spondylitis is under control with drugs, and she was just happy that she could see again. Thank you very much for your attention.
Thank you, amazing cases. So we go on with our third speaker. This is Dr. Wang Xu from Shanghai. He's the president of the Chinese Society of Hand Surgery, and he has a special interest in peripheral nerve surgery and reconstruction. Please, Dr. Chu, give us a talk for contralateral C7 transfer for spastic hand. Ni hao.
Yes, can you hear me?
Yes, we can hear you.
You can hear you.
Good,
Can you see your slide?
I share my slide. Can you see? I have done the. Can you see?
Yes.
Okay, good. It's my great honor to have the opportunity to join this joint meeting with the World Federation of the Neurosurgical Society and the Asia Australia Society of Neurological Surgeons. I'm a hand surgeon. So in China, we have different system, and the brachioplexus injury is handled by hand surgeons. Okay, so I will talk about the central neurological injury. So we are very familiar with the stroke, TBI, CP. It can damage the structure of the brain and lose the motor control to the contralateral limb. So it results in permanent medical disability. Only in China, we found about it's 23 million patients in China, and every year we have 2.5 million new patients. So it's a very huge problem. So we are talking about this patient. I mean, the chronic in chronic stage. So the main strategy is still to reactivate the injured hemisphere and plus rehabilitation. But we can see if we use the stem cell with the rehabilitation, even the lobo assistant rehabilitation, the functional increase is between 2% to 4% with current strategy. So we think the spastic arm is still regarded as one of the most difficult challenge. So we think the path to reactivate the injury may be dead end. So shall we have new paths? We can replace the brain. We use contraregional hemisphere. That means the ipsilateral to the paralyzed upper limb. This hemisphere to control the paralyzed upper limb, resulting in one hemisphere controlled by lateral hands. Actually, this is a dream. And 150 years ago, in both the medical and surgical journal, at that time is also the name of the New England Journal of Medicine. Brown Sequard, he raised that one hemisphere is sufficient to act motion in both sides and can perceive the sensation coming from both sides. However, for adults, for human, the bilateral hemisphere are highly functional, divided into adults. One hemisphere controls its contralateral limb. But if we do in this way, sorry. So this is brachial plexus. The C7 is in the middle part of the brachial plexus, and it contains about 20% of the fibers. If we cross-transfer the bilateral C7, then we can just put the paralyzed upper limb connect to the ipsilateral hemisphere. So it maybe can finish the one hemisphere controlled bilateral hands. So after the very, very detailed research, we applied this in the first case. We use it in cerebral palsy. It's 13 years ago, in 2008. Then we reported in the microsurgery in 10 years ago. Then we, step by step, we applied to very young adults, 21 to 30 years ago. We found the result is very good. The score increased, the Fagamil assessment, it can raise 17.8 compared with the control, 4.2. So we published in Neurosurgery in 2015. Then we started the RCT study and we published in New England Journal of Medicine in 2018. So this is about the original Chinese surgery. We used this study design as a randomized control trial, and we used this patient is a before 3 or 5 years. It's totally in chronic stage, and only rehabilitation can just help them, but no improvement. So the final results is we can improve the upper limb function in 1 year after the surgery and after the very regular rehabilitation. So we can see compared with the control group, we can raise the results 17.7. And also we just proved that the physiological connectivity was shown between the ipsilateral cerebral hemisphere and the paralyzed hand by electrophysiological testing, TMS and fMRI. It's a text by the editorial from New England Journal of Medicine. This is our results. And also we can see the functional MRI. About 8 months after the surgery, you can see the activation of the regional hemisphere. And the safety is great. Just like the C7 transfer in treating the brachial plexus injury, 6 months after the surgery, there's no complaint of the discomfort. So the neurosurgery comments from the Science Times, it says this trial represents a step towards the return of the major function in paralyzed limb, and it's a point of great promise for the many patients who have already lived with disability for years. And this year in operative neurosurgery, we just published this procedure. So also we have the Hua-San grading of the extremity. So because if we use the Vermeer score, it's very it will cost about 30 minutes. So it's quite inconvenient for a surgeon. So we just use the Hua-San grading. It's just we can finish it in 2 to 5 minutes, and very good test, reliable and the sensitive. And also we just set up the Hua-San rehabilitation program. It's a five stage. So I will show you just use a typical case. This is a preoperative. It's a 25 years old male because he got a very young stroke 10 years ago, and the paralyzed side is the right side. The majority disability is the limitation on position, positive elbow, wrist, and fingers extension. So 1 month after the operation, the spastic is released and hand function improved. In this period, the patient will complain about some in the intact side sore, tingling pain, and the neck and the shoulder discomfort. And about 3 months after the operation, we can see the patient is got to the functional improvement in the arm raise, and it's got him better. Perioperative is very a little bit poor. So in this period, the rehabilitating is antispasm. 5 months after operation, the discomfort was gone, and the nerve regenerated to the elbow. So we can see the elbow, you can got a very good elbow extension. In this period, the spasm stabilized. So this period, the rehabilitation should be focused on the recovery of the shoulder and elbow activity strengthened. Hand-brain feedback is a very good method. So since 5 months after the operation, we can do the rehabilitation is the brain-computer interface and the peripheral electric stimulation. And also we can use the neurotherapy and fine motor functional training. Till 8 to 10 months after the operation, the nerve regeneration is to the forearm. Then forearm rotation and wrist extension improved. So in this period, because we use the fMRI, showed the better side controlling area appear on the intact hemisphere. And about a year after the operation, the tingling sign, we can see the nerve regeneration complete to the hands. Then the patient can got a very good grasp. The fine motor function improved obviously. So this is, if we use this Hua-San rehabilitation program, we can just raise the results about 22 points from the, it's from real world study data. It's better than the 17 points in the RCT study. So this rehabilitation program is worth to be carried out. Also, we do some posterior intradural approach for treating the hemispheric.
Wang Dong,
sorry,
your time.
Okay, I do the results. Okay, we have finished more than 1,000 cases. and the duration of the disease from 1 year to 33 years old. So CC7 transfer can be applied to patients of any age or etiology. This is some typical CP patients 4 years ago. Very quick show you some cases, and so this is and also this is a male 5 years old CP from Germany. TBI patient. Stroke patient.
Professor Wendong, I think
Yes.
Your time.
Okay.
Please conclude.
Okay, conclude.
Thank
Yes.
you.
So also in conclusion, so this is editorial from. So this is we think it's a fresh approach and provides opportunity for insight into the basic neuroanatomy and neurophysiology. Thank you for your attention. Thank you for your time.
Thank you, Professor Wong. Professor Henry, after 3 talks, now can we go ahead with the discussions and question answers if there are any? Yes. In the question box, I think we have a question from Chaya SOK, and already question was for Professor Kale. That's been answered. Apart from that, there are compliments, but no questions for the speakers. Now, anybody has any question? There is one question from Dr. Muhammad Tahir to Professor Wong. What was the effect on ipsilateral triceps after C7 transposition to the contralateral side? Professor Wong, there's a question for you.
For me?
Yes. Yes.
Yeah. Okay.
From Dr. Muhammad Tahir.
Okay.
Yes.
So I think the C7, we cut the C7. We just do this surgery very early in since 1986. So it's a very popular surgery in treating the brachial plexus injury. So it's also applied in America and India. So it's within 3 months. Within the 3 months, some patients with complain about the triceps. It's lower strength. I mean, lower the muscle power. But after that, no problem. Yeah, it's a very safe procedure. Don't worry about the muscle and the sensation. Yeah.
Can I ask from Dr. Visuchi, in new trends, he is using the 3D techniques for CV junction surgery? Dr. Visuchi.
I think he's muted himself. Yes. Okay.
But I think he's using 2D because he is reporting the lack of dexterity and prolonged dissection time. So I think he is using the VTOM 2D. But nowadays we have a lot of 3D exoscopes, which will overcome this problem.
Yeah.
I have one question to Dr. Kali. He has shown so nice cases and very incredible reconstruction. Congrats for your good results. But in the first case, I don't understand why he's not making an anterior approach, removes the disc and make a unifusion, because when you only place metal in our experience, all metal will become loose after a while if you have not a fusion. So I think for this girl, even now, I would go again, remove the 2 discs and make a bony fusion.
Well, can you hear me?
Yes.
Yeah. I think that was the first case about 10 or 12 years ago. And to be truthful, it was just the fear. It was a small child going anterior, getting the C3 out, very small neck and deep inside. So I wasn't sure whether we will be able to get that out without doing more damage. So I thought, okay, let me go from the back first, and if need be, I'll come back from the front. But the back has held so well that, well, there was never any need to do anything more.
There was no loosening of the metal rods in this girl?
Oh, no, surprisingly, she fused well.
That's very interesting.
Yeah, it's the same question I had as Professor Henry, that once you fix them posteriorly and the spine is fixed and then go anteriorly to straighten the spine, the posterior hardware may come in the way to make it straight. Professor Kale?
Yeah, of course. That's why if you see in the later cases, the technique we thought would work best is go from the back first, loosen up all the joints, make it loose so that things are loose, put in the hardware, then come in the front, do the corpectomy, make the spine straight, put a strut, cage or a plate or both, and then go back and finish the job from the back. So the actual correction is probably from the front, but to do that correction, you need loose joints and you need to loosen up the back. So it became posterior, anterior, posterior.
Okay, right. Professor Visochi, is he here? Professor Visochi?
He left.
I think, okay, that's fine. Now I think we'll move ahead. The questions, any more questions from the panel or the participants?
I think
delegates?
Dr. Mohammed is trying to raise his hands.
Yes, Mohammed. Can you drop the question, Professor Mohammed, the chat box? There's no question dropped in the chat box. He had a question which already been answered by Professor.
I think we should go ahead because we run out of time.
Yes, I think we'll go ahead, right? So the next speaker in the section is Professor Sumit Sinha. He will be presenting his work on minimally invasive reconstruction of dorsolumbar spine fractures. Professor Sinha is the Director of Neurosurgery and Spine Services, Paras Hospital, New Delhi, ex-professor of Department of Neurosurgery, JPNATC and AIMS New Delhi, cerebrovascular and spine person, faculty at AO Spine, education officer, AO Spine Indian subcontinent, faculty advanced trauma and life support, founder secretary of Indian Society of Peripheral Neurosurgery, member of WFNS committee, secretary Neurotrauma Society of India, and ex-faculty of training research facility at JPNATC, AIMS New Delhi. Professor Sumit, stage is yours. Please go ahead.
Good afternoon, Dr. Suresh. It's so nice to see you after a long time, although virtually. Can I share my screen now? Can you see my screen?
We can see your screen. You can start the presentation. We can hear you also.
Perfect. So after wonderful illustrious presentations by Professor Besant Mishra, Dr. Kale, Professor Visochi, I mean, this is a basic, very humble presentation that I'm gonna make in the next few minutes that have been allotted to me. And I think this is the bread and butter of a spine surgeon. So it's a basic thing that every spine surgeon, especially a minimally invasive spine surgeon, is required to learn in these times actually. So I'll be talking on minimally invasive reconstruction techniques in dorsolumbar fractures or dorsolumbar trauma. And I will be taking you through 2 or 3 short videos if time permits. I have no financial disclosure. So before I go into the lecture, I would like to thank the organizing committee and especially Professor Sinha to give me an opportunity, and the WFNS to give me an opportunity to present my work and an opportunity to interact with the residents over here on this platform. So let's see as to how the MIS techniques can be helpful in these dorsolumbar spine trauma. So the most common and the most commonly used scenario, I mean, is the percutaneous pedicle screw placements, which we can do by means of minimally invasive approaches. Howsoever, before we delve into these MIS techniques, one should be very informative about the indications for these techniques to be used in such patients. Of course, the percutaneous techniques, percutaneous screws, I mean, they do not provide for fusion. So whenever fusion is not indicated, these techniques are to be used, and these are acute type A3 AO spine fractures which are less than 72 hours old, and fractures which have got an intact posterior ligamentous complex. So in such patients, you do standalone percutaneous screw placements. Howsoever, if you have a type B or a type C injury which suggests a 360-degree fracture, you need to have some sort of fusion also, which of course you can do with MIS techniques, but then the fusion element has to be incorporated with fixation. So here I'm specifically talking about fixation done by percutaneous pedicle screws. So taking you to a short video. I hope you can see this video running nicely over there. So this is about a burst fracture of the dorsolumbar spine, and this is showing the instrumentation used. Now various companies have various instrumentations, and you can do this technique of percutaneous fixation by means of either an O-arm, or it can be done elegantly and very beautifully by means of a simple X-ray machine as well. It depends on how many gadgets you have at your hospital. So this technique is being shown by doing it by means through an O-arm, and you can navigate it and put the screws under O-arm guided navigation. So we obtain an X-ray, a CT scan before the surgery, and then incorporate the data so that into the computer, and then so that we can work almost in real time by putting in the pedicle screw. You can see on the screen the trajectory of the screws is so beautifully displayed over in the computer screen, and it's just like playing a video game rather than inserting a pedicle screw. Howsoever, having said this, it all depends on your resources, and you can also do it by means of the availability of a simple C-arm technique. So this is all the instrumentation, the sextant system, which is one of the companies which provide, and the screws and the tabs and pedicle finders. These are the various things which are used in this. I will explain it later as they are used in the upcoming video. So first of all, after you have inserted this stealth frame, which is helpful in coordinating with the O-arm and telling you the trajectory of the screws after registration, what you do is you insert a Jamshidi, and you see on the AP fluoroscopy about the placement of your Jamshidi. Now this is the owl's eye. This indicates a pedicle, and the entry point of the pedicle is on the lateral border at the 3 o'clock position of the pedicle. So this is the entry point. Even if I use the navigation, even if I use an O-arm, I always make it a point to confirm it dually by means of a fluoroscopic image, because technology can make some glitches, but direct confirmation on an X-ray never does fail. So once I see this on the AP view, so this is the Jamshidi which I inserted into the pedicles, and once the pedicle is inserted into the body, through the pedicle, again confirm it onto the AP view and the lateral view that they are in the good trajectory. So place both the Jamshidis on one side, confirm it again on the AP view, and here you are there. Once the Jamshidi is gone, then what you do is you insert a guide wire, which will be your railroad for the subsequent surgery. And this guide wire is the most important equipment which will be again and again used, over which other instruments will be railroaded onto this guide wire. So after this guide wire, you put in subsequent 2 dilators to dilate the muscle and the muscle tract, and then the final dilator is placed. After this, you tap the trajectory of the screw with the tap, and this tap has markings so as to indicate the length of the screw to be used subsequently for the placement. So you can measure the exact length of the screws, and you can take these screws whatever length these screws are suggested. So K-wire has to be a very important thing, which is to be taken care of, not to remove this K-wire before you put in the final screws into the vertebral body. Now, this is the screw extender assembly, which is loaded with the screw, and this is a cannulated screw, which you cannulate over the guide wire over here, and then subsequently place it into the vertebral body. So this is how you place the screws into the vertebral bodies, and the confirm it lateral view as well as the AP view. And this is how you place the screw extender assembly with the screws on one side, and then you place it on the other side similarly, confirm it on the AP view again, and then finally all the 4 screws, when they have been placed, then you log these. Now these screw extender assemblies have got a male and female socket, and then you attach them, and then attach the screw, the sextant arc system with the rod attached at the end of it, and this sextant arc negotiates the screw heads with the attached rod. And then you see this is the rod which is going, and you measure the length of the rod actually by fixing this screw extender assembly, fixing this sextant arc system over the head of the screw extenders. And this is how it looks like on a lateral projection on both the sides. Either you can do one by one, or you can do both the sides simultaneously. Always confirm on the AP view after you are done with the insertion of the rods, because sometimes the rods do not negotiate the screw heads and lying on one side of the screw head. So it's very important, and you can always distract or compress depending on the situation demands once you have inserted the screws, taking out the screw sextant arc system, and finally removing the screw extender assemblies. And this is how it looks finally, and you are done with. This is the incision. This is how it looks like at the end, and you are done with 2-level fixation. So the benefits are decreased post-operative pain, and of course, shorter length of hospitalization and increased recovery time with these. These are some of the examples which in my clinical practice, you see reconstitution of the length of the height of the vertebral body, I mean, very beautifully remodeled after some time in the follow-up. And also the reconstruction of the post-operative, pre-operative kyphosis is very well maintained after this, and the reconstitution of the bony canal as well. And this is how it looks at 12 months follow-up, almost near normal. But the indications have to be very, very carefully selected. And this is the follow-up wound at 1 year, vis-a-vis the last picture you see in one of the patients referred from outside, where it was done by an open approach previously, and then done by percutaneous techniques. The technique in MES procedures which you can do is the kyphoplasty. Now this is very, very common thing, especially in the geriatric population, where there is a collapse of the vertebral body because of the poor bone mineral density. So It is a very simple procedure, also done percutaneously. And here I will take you through a series of photographs as to how you inject the cement into the bone and enable it to be strong again and reconstitute the height, thereby reducing the post-operative patient pain and reconstituting the kyphosis as well. This is one such fracture, osteoporotic collapse. As you can see, this is a type A2 injury. Superior end plate is depressed, and this is the position of the patient in prone, and insertion of Jamshidi. You can see that first of all, the Jamshidi, the entry point is the same as I mentioned, and the trajectory of the Jamshidi is the tip of the needle has to rest on the inferior corner of the vertebral body. So this is how you do it. After you insert a Jamshidi, you take the guide wire and cannulate it through the Jamshidi needle, and then the guide wire will be the future railroading instrument through which you can insert the rest of the things. And over the guide wire, you take into the cannula, and then this cannula rests, as you can see it in the last X-ray. This cannula, through this cannula, you insert the balloon, and you can see the two tips on the guide wire of the balloon. The balloon inflates between these two dots. So these two dots have to be placed where you want to expand the vertebral body to the fullest. Because it is here only that the balloon is going to be inflated. And then finally, when the balloon has created the space in the vertebral body, you can inject the cement through the cannula. So this is how the procedure is done, and this is the patient, which is absolutely pain-free immediately after the surgery and mobile. And this is a wonderful procedure. You can discharge your patients the next day. The third thing, which is very, very common in MIS techniques, is the tubular retractors, and there are a variety of tubular retractors in the market, both endoscopic and non-endoscopic, and this is how you use serial dilators during this technique, and you can do various things like minimally invasive transforaminal lumbar interbody fusions, and in cases of listhesis, pars fractures, or thoracolumbar displacements. So in view of shortage of time, I would like to skip the dorsolumbar fracture. The thoracotomy also can be used by MIS techniques in cases of dorsolumbar fractures. However, they are a wonderful technique through a small incision. MIS techniques, the take-home message is that they are wonderful techniques in spine trauma. They reduce the patient morbidity. However, the indications of MIS have to be individualized very, very carefully. And it is not just to simply do the surgical technique, it is to how to give your patient the maximum benefit by your minimal invasive surgery. Always choose these fixations only when there is an intact PLC or a single column injury. However, if there is a 3-column injury or a type B or type C injury, then always fuse along with the fixation as well. And then it will give your patient lasting results. And if, of course, the fusion is required, then you use the tubular retractors. Thank you so much.
Thank you, Sumit. It was an excellent shot and presentation on time. Really, really informative. Probably after next 2 talks, we'll have a discussion session. Now, there is little change. Thank you, Sumit. Well done. There is little change. Professor Atul Goyal is held up in the OR. So our next, I would like to invite our next speaker, Professor Henry, our good friend, and he will be sharing his work and experience on the skull-based reconstructions after endoscopic endonasal tumor surgery. Professor Henry Schauder is well-known person and our best friend from all of us in India. And he has been visiting our country very often and participates and teaches, takes us to modern endoscopic developments. He is a professor and chairman, Department of Neurosurgery, University of Medicine in Greifswald, Germany, President, International Federation of Neuroendoscopy, ex-chairman of Endoscopic Committee of WFNS from 2014 to 2017. It's an honor to invite you, Professor Henry Schneider, and listen to you. Stage is yours. Please start sharing your screen. Thank you.
Hello, thank you for the kind introduction. Can you see the screen? It's running?
Professor Henry, we can see and we can hear you. Please go ahead.
That's very good. So thanks for the invitation. Dr. Zina, good friend of mine. I'm very happy that you invite me for this nice webinar. So my topic is skull-base reconstruction after endoscopic endonasal tumor surgery. I think when you start with your surgery, the very important topic is that you really have a good positioning of the patient. And especially if you have obese patients, we always elevate the back 30 degrees, so to decrease the venous pressure in the head. That is one major part to prevent CSF leakage during the surgery, in my opinion. And then, of course, before you start with the surgery, you have to have an idea what kind of skull-base defect you will imagine. So we have to look very precisely at our imaging. So all of our patients get a CT scan so that you know about the bony anatomical situation. You want to see what is the septum, what is the size of the turbinates, what is the size of the sphenoid sinus, is this pneumatized or not, and then the septi give you a very good anatomical orientation, much better than any navigation. And then, of course, we have to look at the lesion. Is the lesion extradural or it's an intradural lesion? That is very important in the planning of your approach. This was a chordoma in a very young child, and you see this is a pretty extradural lesion, and so we did not raise a nasoseptal flap. However, if you see that lesion, you see there is a chordoma with a tremendous intradural component, then you know there is a dural leak and you need a nasoseptal flap to have a good reconstruction. So we have to look very precisely at the images. So I just want to show you some reconstruction, what we do in our department. The construction depends on the CSF leakage, what we have. If we have no CSF flow, we just put sometimes gel foam. We make a bony reconstruction of the sellar floor with bone or a resorbable plate. It's called polydioxanone. If we have a minor CSF flow, then we put usually Duragene with fibrin glue, and then we reconstruct the bony sellar floor with this resorbable plate. And if we have a major CSF flow, of course, we use fat and we use a nasoseptal flap. So if we have a small microadenoma, like in this patient, was an acromegalic patient, we dissect the tumor. The tumor is within the gland, so we don't see the diaphragma. There is still a lot of gland covering the diaphragma. And the diaphragma is very sick because it's a purely intradural tumor. It's a small microadenoma. There's no dural elevation of the diaphragma. So in this case, we just put some gel foam on it to keep it wet. That's all what we do. And in these cases, we never had a CSF leakage. Sometimes also when we have a normal bony anatomy of the floor, you can take the bony floor in a rectangular fashion. And this diameter is longer than the craniocaudal dimension. Then you can take a 1 millimeter Kerrison. You can elevate the bony floor and take it out. Then we have the exposure of the intracellular dura. Then we make the tumor resection and then we bring it in and we rotate at 90 degrees so that we have a good buttress. I think it's very important. Sometimes, especially in patients which have a small, very thin diaphragma, if they sneeze or cough after the surgery, you can have a leakage in a post-operative phase, although intraoperatively there was no CSF leak. This resorbable plate, it's, I think, a nice idea because it will disappear after 70 days and it gives a good buttress. It's a reconstruction of the bony floor. So we have here the opening of the dura. This is the opening of the bone in the sellar. Here was the tumor. We removed the tumor. We put some Duragene or sometimes simply gel foam in. And then we place this resorbable plate in the extradural space behind the bony margins of the sellar opening. So after tumor removal, we put just a little bit gel foam in the resection cavity, and then we have this bluish resorbable plate. It was originally used from the craniofacial surgeon to reconstruct the floor of the orbit in trauma surgery, but it's very nice to reconstruct the bony cellar. And then if the patient has increased intracranial pressure while he's sneezing or coughing, this has a buttress and avoids rupture of the diaphragm. Sometimes we use fat. That was a case of a chordoma, and we could not harvest a nasoseptal flap. So we put one big fat in the clivus indentation, and then a second layer of fat in the sphenoid sinus. Sometimes we take fascia lata and fat. This was a patient with a chordoma. We had also had no nasoseptal flap. You see the defect here. This is a spinal dura. It goes far down to C1, C2. So we make an inlay of fascia lata. We fix it with fibrin glue. Then we put a second layer, an onlay, also with fascia lata. And then we put some fat around to fix it. Of course, it's not ideal. A vascularized flap would be much better. But in this case, it was not possible because it was already, the pedicule was destroyed from the first surgery. And then again, fibrin glue and some Surgicel on it. And then we place gel foam and then the tamponates to keep it in place. And in these cases, we put a lumbar drain to fix the reconstruction. Of course, the nasoseptal flap is the best one. And we take the flap in this fashion, take a lot of the upper part, but here we relieve a little bit of the olfactory mucosa. It's very important to have a very good outcome for the patient to preserve the sense of smell. And everybody said that is in development of Haddad and was published in 2006. But if you look at the literature, it's interesting that Hirsch already in 1952 described a very similar flap taken from the nasal septum to cover a defect in the sphenoid sinus. So this is a variation of the Hirsch flap, I would say, which was discovered a long time ago. And then what we always do, if we take a nasoseptal flap from one side of the nasal septum, we make a reverse flap. So reverse flap is taken from the mucosa on the contralateral side. Then we remove the bony septum in this area, and then we flip it over the denuded septum where we took the nasoseptal flap from. And this gives a much better healing because you have not so much cartilage exposed to air. So I would strongly recommend to make also this reverse flap. So you flip it over and then you fix it with 2 stitches. It's really a nice addition. So this was a case of tuberculum salimeningioma. We just put a little bit of gel foam and then we have the flap. It's very important when you take a flap for reconstruction that you remove all of the mucosa from the sphenoid sinus. You drill all the septi very flat that you have a nice bed. So the margin of the nasoseptal flap should overlap the bony defect at least 5 millimeters on each side because the flap is shrinking a little bit. And then we fix it with fibrin glue. But we would never put any artificial material between the flap and the bony skull base because then it will not heal. So you take just the flap, put it on the bone, and then we put some tamponates to keep it in place. If you have such a big defect in a craniopharyngioma, you have a big hole to the third ventricle, then we use fat. We put the fat into the dural defect. We fix it with fibrin glue and then the nasoseptal flap. So no artificial layer, which was sometimes recommended to take Duragene or the other things under the flap. I would not do that. And also the group of Naples is not doing it. And that, I think, gives the best results. And if you have a good perfusion in the flap, then it's a good sign that you have maintained your vascular supply from the nasal posterior arteries. So with a nasoceptive flap, you can decrease the rate of post-operative CSF leaks under 5%. There are some very optimistic guys who say it's under 1%, but I think under 5 is already a very good result. So I had one case, I had a problem with the diaphragma. You see, this is an intra and supracellular lesion. So we expose it and then we make a cut in this area here where I usually make the incision a little bit away from the superior intercavernous sinus. So we open it with a knife. And then there was tremendous CSF leakage coming, and I was surprised what happened here. So we open more down. Then the tumor is pushed by the CSF pressure into the sphenoid sinus. You see the typical adenoma. And then we continue with the removal of the tumor, the bimanual technique. See, this is a normal gland, it's here. So the tumor is removed, but you see here, this is a complete cut of the diaphragma because there was a folding between the frontal-basal dura and the diaphragma. And to fix that, I thought it is not enough to glue or put some fat and glue inside. So we put 3 stitches to fix the diaphragma to the frontal-basal dura back. But I think it's very difficult to expect that it's a low rising diaphragma in this case, because we had no image previously where you saw how was the growth of these intrasupracellular adenoma. So we just saw one image, and of course you think the diaphragma is pushed up. But in this case, there was a folding because it was a low rising diaphragma initially, and then the tumor just pushed it up. And we had this duplication. So 3 stitches, and then we put some fat in and fibrin glue. But it was the first time I had this experience. So we put some fat in as a buttress. Then there's our resorbable plate, which keeps it in place. And you see this is after 1 day, after 3 months, and after 1 year, you see the fat is resorbed. It looked nice, no recurrence, no residual tumor. But here, this is the diaphragma, what you expect. But in this case, it was like this, because originally the diaphragma was arising here, and then it was pushed up. So what is an unusual complication? So my conclusion is that, of course, before you start with your surgery, you have a careful inspection of the images, and you have to plan your reconstruction before you start with the surgery. And the nasoceptive flap, of course, is a workhorse for skull-base reconstruction in high flow leaks. Thank you for your attention.
Thank you, Professor Henry. It was an excellent demonstration of technical skills and highly informative and educative. Thank you very much. Probably after the next talk, we'll take over the questions. So now I think we'll go to the next presentation by Professor Domenico Solari from Italy. He will be presenting his work on CSF leaks and repair. Professor Domenico Solari is Assistant Professor of Neurosurgery, Division of Neurosurgery, University degli Studi di Napoli, Federico, Naples, Italy. His special interests are pituitary and skull-base surgery, endoscopic endonasal surgery, and neuroanatomy. So Professor Domenico, welcome, and please take over, start sharing your work and screen. Thank you.
Thank you very much for this kind invitation. Like to Professor Sina, to all the chairman, I will present our experience with the repair of CSF leak that we had in Napoli, Italy. Professor Schroeder already showed like beautiful tricks that we are sharing along the experience of the schools that are dealing with this pathology. So this is our CD with like the Federico II, the emperor that gave the name to our university. And on the other side, there is the volcano that leads our city. On these sides, there is one of the most famous hero of the city that still is giving us. So my topic will be like the repair of CSF leak. Like, of course, we got experience dealing with iatrogenic CSF leakage, but what it is a CSF leakage? A CSF leakage means that there is an abnormal communication in between the subarachnoid space and the extradural structures, but there should be a pressure gradient. This is very, very important, like to understand, because of course, like if we imagine that there are like some weak points all along our base or all along our skull, we need like something that breach out and like something that push the CSF to go out. And there is also like the difficulty of understanding how like it is diagnosed like a CSF leakage, especially via narrow corridor as like rhinorrhea or otorrhea, because like there are not always clear direct or indirect signs, and there is sometimes like a misunderstood case history. There is a trauma back in the days that has been not referred from the patient. And sometimes there is like all these aspects that are covered by the presence of an harmful eventual complication of the CSF leak, like meningitis or hypertensive hydrocephalus. And again, like there are some things that could lead like to the increased risk of presenting CSF leak, either after surgery or like even like a spontaneous, like for the increased BMI could be one of those, like with an increased intracranial pressure leading to intracranial hypertension, or like in neoplastic patient that received radiotherapy. The use of radiotherapy could weak all the reconstruction material. And Professor Schroeder showed like the one of our enemy doing with surgery, the opening of the third ventricle with a lot of CSF in it, and of course the pulsation. So speaking about like CSF leak, for instance, in traumatic patient, we can have like doubt that something has breached at the level of the anterior fossa. So we can go ex adjuvantibus, we will say like in Latin words. So we can leave the patient having bed rest, like having all the medicaments to reduce the raise of intracranial pressure, and already said like the elevation of the bed, like the head should be quite over the level of the heart, like to lower the pressure of the vein and favor like the pulsation to get out of the eventual small defect that is not detected by any radiology. Or like we can identify clearly the seat where there is like the breach and the tearing of the CSF, and we should enter surgery immediately. And of course, like this is not free of complication, because also performing transcranial approach, there is like the eventual need of moving out like the brain tissue, like the manipulation, like there's a lot of air that still it is an irritating stimuli for the brain tissue. And you see here, like when you go for surgery, you should be a clean cut surgery, because like as long as you fail your surgery, then you have to chase the ghost of having like leak again and leak again and leak again. And back in the days, our ENT friends like developed this technique, especially in traumatic or like spontaneous CSF. And you see, you can have like both highs, like the one comes from the endoscope and it is a close high that reach the site of the defect, and on the other side there are ionophore technique like fluorescent green that can be adopted to identify the leak. And as they started like to use this technique to repair the base, to repair the eventual CSF leakage, like we noticed that the CSF leakage was one of the most feared and threatening issue of this kind of surgery. And this is also like another side of what we are talking about. Like sometimes you do not recognize the leakage, you do not see the CSF coming out, but you see this CT postoperatively with a pneumocephalus with the precise disposition of the air along the cistern and all the along like the system that has been interested by the surgery. And this gave like the really birth of a myth, like the reconstruction. Like Professor Schroeder dealt very well with the problem, like it is quite the most important phase after tumor removal, and you should deal with all the components that are needed to deal with, like intradural compartment, osteodural, and whatever. But coming from the nose, there are some consideration. You have like very important structure near the border that you open it. There is an irregular contour, and there is a lot of large arachnoid opening, and there is a lot of pulsation, and there is the gravity. Yet we did not found an ideal material. We are trying to prefer like autologous material according to this paradigm that Dr. Kelly came out with several years ago. Like whenever you open a cistern, you have to do your best to close up every component and have like considering that this is always a high flow leakage coming from the intradural compartment. So initially we started with this kind of reconstruction. We used it to fill the dead space. We used a semi-solid buttress, and then we used a lot of glue and support the materials. That was almost 10 years ago, when we preferred like this that we call the grandma's cap technique. There was something intradurally, then there was something wedged in the dura and the bone, and then the filling of the sphenoid sinus. Semi-solid, semi-solid buttress was close to the neurovascular extraction. So we changed our mind and we moved to this innovation coming from our friends Haddad and Bassagastegi. And so again, that was at that time the reconstruction, filling the dead space with glue, using soft material, and that was the semi-solid buttress that was pushed with the forehands technique, and then was covered with the nasoseptal flap and all other materials like oxidized cellulose. Then we find out again, like that was a risk for the patient to have like the contour and the peaks of that material coming so close to neurovascular suction. So we moved to this other strategy, like that was made of all soft materials, like autologous fat again to have a filler, and then lots of heterologous dural layer. We call it the sandwich technique, and the faces and layers were pretty the same. You see here, we performed like the stitching of the fat with the layers outside the nose, and then we dealt with it inside the nose. Again, two surgeons are moving hands, like one is moving the endoscope and the other is placing the material. Piece of free fat to have the first stop to the CSF coming off, and then this compound, that is a 3-layer compound, and the fat to satisfy the irregularity of the defect. You see here, like I move faster, then we try to wedge in the extradural space, the outer layer of this heterologous substitute, and then like try to cover as much as we can with heterologous material and forms the eventual discrepancies in between the material and the opening. And then we came out with this sort of let's say idea, but it was an old idea, like the use only of autologous material, only of fat. So we call it the 3F, and it is made out of fat, flap, and the fast mobilization of the patient. We ask the patient like to move as fast as he can, eventually on postoperative day 1 out of the bed, or like to stay as much as possible in a sitting position inside the bed. This is our experience with this technique, and you see that we adopted to all the kind of procedures that came to our hospitals, and so far we collected 91 cases, and a lot of them were with an increased BMI, and a lot of them was recurrent tumor that already had radiotherapy. So this is the so far output of our work, and we had like 2 that we consider minor postoperative CSF leakage that did not require a second surgery, and only 1 required a revision surgery. And it was a patient with a coexistence of a tuberculum cell and a dermoid cyst. I'm sorry, move fast. And that was an illustrative case. You see here, like there's a meningioma cell, like here you see like a quite very open angle at the level of the tuberculum cell, quite opening over the canals. It was a meningioma, so nothing should be left behind while removing the tumor. This is a huge chunk of fat that is pushed inside. We fill with the saline solution the space, and then we ask the anesthesiologist to raise the head of the patient, like to have the fat, the big pieces of fat, come across the defect and use really like a cork. Then we fix it with fibrin glue and we cover it directly with a dud flap, and then eventually use hemostatic foams only like to have the hemostasis. So that is the POD1 CT scan of that patient, and you see that basically the amount of fat should be exactly mimicking the tumor that was there behind, because already Professor Schroeder showed us like there is a huge resorption and there is no risk of compression of the neurovascular structure. And this is a really nice case that you see that you can trust on autologous material and on this technique also in huge opening at the level of posterior fossa. A chondrosarcoma in this huge lady that was a little overweight, like it was an 18 years old lady with that chondrosarcoma that was in the images. Lot of fat pushed inside the defect. We suspected that we use it too much, but you see there is no CSF. In this case, we cannot use the technique of raising the head because it is in posterior fossa. So we had an extra amount like pushing the fat against the floor of the cell that has been removed and fixed with fat. And then after that, we had the flap over it, moving forward in the sake of time. And then you see no leakage afterwards. The patient
No, we can't hear you. Suresh, can you hear him?
No, we're not. There's some technical problem.
At the end of Dr. Soleri only.
Yes. Hello. Professor Domenico, can you hear us?
No.
Hello?
No. Internet is not working.
No, he's disconnected, I guess.
Technical problems, yes.
Okay.
So I think we are late. I think we should go on, Virendra. Do you agree?
Yeah, please go ahead. Go ahead.
I
think he had come to the last part of his talk. Almost he had crossed 12 minutes.
Yeah, all right. Then it's a great pleasure to introduce my co-chairman, Dr. Dugani. Oops. For his talk. He is a very experienced micro and endoscopic surgeon. He was partly trained in England, and he established a regional neuroscience center in Hubli. Is it Hubli? 1996?
Yeah.
And he will talk about transcranial reconstruction.
I'm sorry. It was over, the presentation. Something failed with my thing. I'm sorry. Thanks a lot.
No, Professor Balag. It was excellent. We enjoyed your talk. Anyway, I think you had come to the last part of your presentation. Your work.
Yeah. I only had to say sorry. Thank you very much.
No. Your videos and work were excellent. We really learned and enjoyed the presentation. Thank you, Professor Domenico. Yes, Professor Henry.
Dr. Dugani, go ahead with your talk about transcranial reconstruction of the anterior skull base.
Thank you. Yes. Can you hear me and see the slides? Can you hear me?
Okay, yes.
And see the slides?
Yes.
Hello, can you see the slides?
We see a lot of slides.
Thank you very much. At the outset, I would like to thank them. Okay, thank you. Thank you, Professor Henry. Yeah. At the outset, I would like to thank Professor Sinha and Dr. Amit and Professor Professor B.K. Mishra, WFNS, for the kind opportunity given to us in this excellent scientific deliberations and learning and sharing from this scientific feast. As a part of this, I thought I'll share with you few of our work and experience in the management of skull-based reconstruction through transcranial route. All of us are aware.
So we see only an overview of your videos where you see videos.
Now is it seen? Can you see now?
No, we just see, yeah, we have the other, maybe you have two screens. We just see the.
Okay, I think there's some problem. I think I'll share it again.
Yeah.
I'll share it again. Yes. Now is it clear? Can you see?
Now it's okay.
Yeah, that's fine. Thank you. So as all of us know, the skull-based reconstructions are really challenging due to the location, nature of lesions, surrounding very vital neurovascular structures, surgical inaccessibility, and very high recurrence rates. So what are the causes of these defects we are going through? One is, all of us know, trauma is the most common factor with the high velocity accidents, including the skull base, anterior, mid, and posterior. And okay, fine. Okay, high velocity accidents, which involve upper face and mid face injuries associated with that. These are the few examples of upper face injury. They are extremely important, which includes the anterior skull base and frontonasal complex and the Lefort type of Lefort 3 injuries, thereby causing a significant injury to the anterior skull base, resulting into frontal lobe injuries, CSF rhinorias, optic nerve injuries, and olfactory nerve injuries. These are a few autopsy specimens showing you the locations of the defects in the anterior skull base, paramedian, midline, anterior, posterior, and sometimes they involve the middle cranial fossa, bilateral petrous temporal bone fractures, unilateral cranial fossa fractures. All this depends on the type and the force of the injury which the patient has been. Other lesions like developmental lesions, encephalocele, Rathke-States craniopharyngiomas, skull-based other lesions, inflammatory lesions like fungal granulomas, tuberculous granulomas, osteomyelitis, vascular pathologies, giant aneurysms, AV fistulas, and CCF fistulas. We have common ones: skull-based meningiomas, schwannomas, pituitary adenoma, giant pituitary carcinomas from the nasopharynx and the paranasal sinuses and eroding the skull base, angiofibromas, and esthesioneuroblastoma. Now the question comes, why do we need a reconstruction in such cases? That's most important. Already my predecessors have spoken in a great detail. Most important is prevention of CSF rhinorrhea, thereby fatal meningitis, pseudomeningoceles, encephalocele formation, empty-cella syndrome, chiasmatic, hypothalamic herniations, and skull-base osteomyelitis, and cosmetics is extremely important. To treat these lesions better, we need a multi-specialty involvement, especially ENT, maxillofacial, head, neck, plastic, and ophthalmology for the better outcome. Apart from that, we need a good amount of infrastructure to treat this. All of us know this better. High-end microscope, endoscopes. Just now we saw the excellent talks previously. Dural replacements, we need intraoperative electrophysiology, endoscope drills, tissue reconstructing agents, and microplates are extremely essential. We have 3 technical, which is used many times. Next, last about 2 decades, we are using endonasal endoscopic reconstructions. We saw just now the excellent demonstrations. Of late, we are using the image guidance and navigation, which is of great help in comprehensively treating these lesions better. What are the aims of reconstruction? here we need to isolate the brain and skull base from the upper face and paranasal sinuses, prevent CSF leaks and infection, bony support to the skull base, and cosmetic. The principles of reconstruction includes reduction and fixation of the bone and bone grafting in required cases, sinuses, cranialization of the paranasal sinuses and osteal closures, dural reconstruction of the basal dura mater, brain decompression of the frontal lobes or temporal lobes to reduce the ICP, and prevention of infections. The materials used to treat this again depends on the size, shape, and the location and the nature of the defect which we are treating. The most common here, temporalis muscle fascia, myofascial flaps from distant structures like thigh, abdominal wall, and forearm, bones and cartilages from iliac crest, fibula, or the skull itself. Gel foam and Surgicells, blood patch, synthetic dural substitutes are now available. We use them freely. Duragen, tissue seals, and fibrin glue, and lumbar CSF drainage in required cases to prevent CSF leak. I'll take you through few of our work and experience in the management of these lesions. Post-traumatic midline and paramedial skull defect. You can see the highest velocity injury with on the surface looking quite benign, but when we explode it, you can see the CT scan showing the global injury, orbital injury, optic nerve injury, and fracture of the anterior cranial base, frontal bone with extensive frontal bone damage. Now, once you open the site, you can see the multiple committed fractures, contused brain, and the skull base multiple fractures. So here the aim would be decompress the frontal bone, do the duroplasty, and reconstruct the frontal lobe. Now you see the shattered anterocranial fossa, midline, lateral, and the coating of the anterocranial fossa. So dura mater is closed. Now we have a new technique. We don't go anywhere else to take the bone. We get the bone from the skull, which has been little posteriorly exposed, and you can harvest the outer table or the inner table, any amount of material bone you want to reconstruct this. We use it as a graft and reconstruct the bone struct with the microplates, sometimes observable if the patient is affording, non-observable, and the reconstruction is done, and pericranial is spread on the surface of the reconstruction, and this is the end result. The patient is perfectly fine with no CSF leak. When the teamwork is involved in treating these formidable lesions, this is a nice example which we treated about 20 years back. A driver had a massive accident, split of the face, maxilla, mandible, and the palate, and the eyeball injury. Eye is already gone, optic nerve tear. There's a frontal contusion with the brain matter coming out through the basal frontal region. Many people asked me, was he alive during this? When you operated on this, I'll show you. This is he was operated by plastic surgeons, maxillofacial, ENT, and ophthalmology. And this is the slide shows he's alive, lifting his hands. He had a hemopneumothorax for which we had put an intercostal tube. The reconstruction was done from all specialties for almost 23 hours, non-stop. This is the end result. The skull base was reconstructed and the face was reconstructed. Eye was enucleated because already it was detached. And this is the end result. Now he's working in an office as an office boy. Now coming to the large skull base lesions. This is a young boy presented with a large lesion in the face and the cranial cavity, skull base. You can see the eyeball going completely laterally in the temporal region. This is the 3D reconstruction image. That's the anterocranial fossa and the face. This person, we did a carotid angiogram, showed the carotid artery shifted medially, and there is a vascularity coming from the external carotid artery. These are the images. You can see the extensive nature of the image. He was taken off for surgery. First, both procedures at a time, maxillofacial and neurosurgery. We did a Weber-Ferguson incision, tracheostomy, and external carotid ligation to prevent the bleeding and reduce the vascularity. First, we did the transfacial approach and take off the tumor completely with the microsurgical dissection. You can see the whole tumor is out, going into the skull base up to the clivus posteriorly, all the cranial nerves emerging, identified and preserved. And Next step, we went transcranial and took off the tumor from superiorly, and again the reconstruction was flat, and the facial reconstruction was done in the midline. Lateral wall and medial wall of the orbits also were reconstructed. This is the end stage of the surgery, and this is the tumor which was excised. This is the CT scan post-operatively. You can see the medial wall reconstruction, superior wall reconstruction with the bony graft, and perfectly fine. This is the patient pre-operatively, post-operatively, and 3 years post-operatively, the eye has completely come back to normal. There is no evidence that he had such a type of tumor. So this is the skull-based meningioma presented with the extending into the paranasal sinuses, involving more growth in the skull base rather than cranial cavity. We operated this through first endonasal. You can see the defect through which the tumor is going down. As I mentioned to you earlier, we use it as a graft for the required defect which has been created, and we hold it and fix it to the microplate so that it doesn't move, and create afterwards the meningoseals or pseudomeningoseals. So the surrounding of this bony defect, we spread it with fascia and fat from the thigh surrounding areas and covered perfectly, and we harvest the pericranial graft from the surface and move it on the graft as the carpet, which is already the pedicle and the vascularity is maintained. Once we do this transcranially, we put the blood clots on the surface, and the wound is closed. Anyway, we had excised it endonasally. We go down now through the nose, and the defect from below also, we seal it with fascia and fat, and surrounding area is smeared with the fibrin glue tissue seal. We can use the Haddad's flap. In this case, we didn't use it because there is extensive destruction of the skull base and paranasal sinuses. This is the seal from superiorly and inferiorly, transcranially, transnasally. This is the end result. The bone is fitting very well, and this is the patient post-operatively, day 5. Doing perfectly well. This is the decompression structure. Another skull-based meningioma, again operated through endonasal and transcranial, and no, probably that's the same one. It's repeating. Yes, this is cranialization of the sinuses and bony reconstruction. Again, skull-based meningioma through the endonasal, then again transcranial. You can see the large defect in the bone there. You can see the defect on the center. And here, the main aim is to define the borders of the defect and cranial, and take off the mucous membrane from surroundings, and all the ostia from ethmoid and anterior and posterior ethmoids are sealed completely, and bone wax is placed, and we take the outer table of the skull. We raised a temporalis fascia with the muscle and move it inside as a graft to hold it in place. And this is the reconstruction. You can see the graft there, and patient is perfectly fine with next day. So this is tuberculous skull base infection. Extensive skull base, you can see here, involving the skull base, bone is rolled, and tumor eroding the anterior skull base. This is a picture before the affection. This is a photograph after he developed this lesion. Now we operated again, transcranial first, then transfacial, bicoronal flap, left frontal craniotomy, as you see here, and the granulation is excised from the skull base and the orbit on both sides. And so on the left side completely, as you see, sinuses and the orbit is excised. Luckily, there is no dural tear here, and transfacially it was excised completely, and reconstruction was done bony as well as facial. And this is the situation 2 years down the line. There's little puckering of the skin. We wanted to have plastic surgery. He's quite happy with that. He doesn't want to have further things. So take-home message: face injuries and various skull-based pathologies where the erosion of the skull base takes place. It is really a life-saving procedure and requires multi-specialty involvement. Advances in microsurgery, endoscopic surgery, image-guided surgery have greatly improved the outcomes in this. Applications in advances in biomaterials, alloplastic materials have vastly improved the outcome and reconstruction status. Various local and distal reconstructive flaps are of great help in these procedures, and outcome is extremely good in majority of the cases when it is done well. Thank you very much for your patience.
Thank you. Thank you for this nice presentation. Amazing cases, very impressive, the reconstruction together with the craniofacial surgeons.
Thank you. Thank you, Professor Henry.
Yeah. Should we go on, yes, or should we discuss the 3 cases? No, we should discuss the CSF leakage cases. Yeah. Do you see any questions?
Definitely. Yes, there are a few questions. One, shall I read the questions for you? Yes.
The question was, do you use bone cement to cover skull-based defects? So I never use bone cement.
Yeah. I agree. Go ahead, please go ahead.
Dr. Solari, do you use bone cement? I think not, huh?
No, we had
no.
I'm sorry. We had an experience like almost 10 years ago with lipophilic cement. It was a disaster because like we removed from every patient that we used it because it's swollen and it got like 3 times bigger than when we used it.
Yeah, and I've heard about infections also, which occur. So we always use resorbables. This plate, what we use is also a buttress, but it's a resorbable, so it goes away. I think we don't have problems with infection in this material.
True.
But best, of course, is just autologous material.
That's right. And again, if you look at the cost effectiveness for a country like ours, it doesn't cost any money at all. Just a question of 10-15 minutes to harvest a graft. And now that we harvest from the outer table of the skull, it's very simple and easy. Earlier, we used to do this rib grafts, iliac crest, and fibula grafts. Now it is not necessary to do that. I agree with you, Professor Henry. Thank you. Now, there's a question for you, Professor Henry. The sequence of material, question is from question to both Professor Henry and Professor Solari. The sequence of material to be put in order to seal the leak intraoperatively, that is, which is nearer the gland and arachnoid, and which is the outermost?
Yeah, we use the inner layer is always fat. There was a paper from Ted Schwartz. He put his gasket seal and he put fascia, and then he pushed a rigid thing very close to the optic nerves. And I was always afraid that this is a problem. And I think he also stopped this because he had 2 patients with optic nerve deficits because he was squeezing the optic nerve. So what we use as an inner layer in these extended cases is always fat. Then we put fibrin glue and then just the flap. So what we used for more than 10 years is a 2F technique. We missed the 3F, but I think the 3F from the Napoli group is very important, that you early mobilize. We have frequently used a lumbar drain, especially in the high flow leakage, to decrease the pressure. But I think it's much better if you encourage the patients to get up very early. That is really a good idea.
Professor Henry, there's a question for you from Anita Jagatia. Which suture is used to repair dura endoscopically when you do that?
I have used the same what we use for transcranial cases. This is Prolene. This is a 04, yes, it was a 04 suture with a round needle to avoid that you cut to the dura and makes the hole bigger than it was before. But usually we don't suture in this area, so I don't use it. But there you have seen there was a 1 centimeter cut straight through the diaphragm, and that's why I thought it's better we adapt it with 3 stitches and then we put the fat and the glue.
Yeah. Thank you.
Yeah, Virendra?
Yeah, in a post during surgery, in a number of cases we don't see any CSF leak, but post-operatively there is a CSF leak. So in our institute, we use FAT in every cases. So what is your experience of post-operative CSF leak when you don't see CSF leak during surgery?
Yeah, that is what I mentioned. You
Yeah.
make surgery, you see that the diaphragm is thin, but there is no perforation. You don't see any CSF, especially, or also, although you make a Valsalva, you don't see it. And I think the problem if the patient is at the ward and he's sneezing or coughing or vomiting, he's increasing the pressure, and then the thin diaphragm will rupture.
Okay.
That's why if I don't see anything, I put Duragene, fibrin glue, sometimes additionally gel foam, and then I make this resorbable plate to make a bony reconstruction. This is a buttress, so if he's sneezing and coughing, the diaphragm will not go away. We had one case, there was a very thin diaphragm. I just put my Duragene, and then we finished the surgery, and during the awake process, he sneezed, and there was a fountain of water coming from his nose. So I think the bony reconstruction is really important. And also the paper from Dan Kelly, and he also said that if you have a buttress, you can avoid this late post-operative CSF leakage.
Professor Henry, there is a question for you. It is from Gurmeet Singh. Why you suture the diaphragm to the dura in your last case?
Because it was a big hole. This was a huge hole, and that's why I thought it's better. And it was easy to adapt because there was no dural defect. It was just a cut. You know, in some cases you have a dural defect and it's not possible, but here it was just a cut, and I thought it is better. And this was a good post-op course. We had no problems with CSF leakage. So there was Dr. Jane had a question.
Good evening, sir.
Yeah, hello.
Sir, I have hello, sir. So I have one question. In some cases which we are operating, sometimes we don't have intraoperative leak, like Dr. Sinha mentioned here. And post-op period, we see some leak is there from the nose. So in those cases also, do you prefer mobilizing the patient fast, or we have to like wait and put a lumbar drain for that?
No, the lumbar drain, so it depends. We just discussed it yesterday. When we have a good reconstruction of the skull base with fat, flat, everything looks good, you make an MRI, you see your flap is in good position, and there is a post-op CSF leakage, we put the lumbar drain. But if I know from my first surgery, I just put Duragene or something, so I make not a really good reconstruction, then I would go again and make a revision surgery.
Sir, as Professor Sinha just told, in our institute, we are taking every case as that it will leak or it has leaked intraoperatively. So we pack it with fat and put in a tissue glue, because it's very difficult for the patient post-operatively if he develops any complications like meningitis. So we do it preferably for every case. And in these cases, like so mobilization of the patient is still preferred, or we put in a lumbar drain and make him rest with the 30-degree head end elevation.
I think if you see already that CSF is coming and you had put fat in, I would go with a lumbar drain. I would go for the cases who have no CSF leakage. These are encouraged to go up to make this 3F early mobilization. I think that is good. But if you have already a CSF leakage, only mobilization, I don't know. I think maybe Dr. Solari can comment, because sometimes they just inject fibrin glue. I have never done this. So if I have a leakage, I look in and put the fibrin glue in anesthesia to see where it is coming from. So just with a patient awake, just injection of fibrin glue, I don't know.
Right.
Thanks. Yes. Unfortunately, like my speech stopped at that moment. Like we go in with the endoscope to check out like where it is the CSF and which is the amount of CSF coming out. Like if the material and above all the flap still is there, like and it is attached and there is no deconnection from the posterior wall of the sphenoid sinus, then we use the glue only like to get the counter pressure to have the flap to adhere to the osteodural defect. And we use that like several times per day, per 5 days, let's say. And we let the patient walk, because this is what we call a minor CSF. The patient has no fever, no pneumocephalus, is not complaining of any headache. If there is any of these signs, then there is no need like to adopt this technique. You should go back to the OR or have an anesthesia and do whatever you think it is correct to deal with that. There is no point on having like this glue injection because it will not be useful at all.
Yeah, this is a good point. If you place a lumbar drain and you have not a good reconstruction, then you have a disaster, because then you suck in the air into the head. And this may be really a problem. So if you have a non-compliant patient, you should not place a lumbar drain, because this can really bring all the air into the brain and then you get an infection.
That's right.
Thank you, sir. Thank you for that. Thank you so much.
So I think, Professor Henry, shall we go ahead with the next one?
Yeah, we should.
Next, see, there is a little change. The two speakers are coming a little late. So we'll be skipping Professor Sanjay Bihari and Professor Miguel Aranja from Spain. Now we'll be going directly to Professor Antonio Germano from Italy, and he will be sharing his work and experience on the management of surgery for deep-seated brain lesions, the role of minimally invasive neurosurgery combined with 3D reconstructions of eloquent brain networks. Professor Antonio Germano is a division of neurosurgery and by BIOMORF department, University from University of Messina, Italy. We are honored to have you, Professor Antonio, and kindly take over the stage and start sharing your screen. Thank you very much.
Thank you, sir, for your kind words. I was impressed by the previous speakers and the excellence of this meeting. Let me say thanks to the organizer, and first of all and mainly to my long-lasting friend Massimiliano Visocchi. Massimiliano and I have shared many experience in neurosurgery, and the friendship that exists between us is one of the best for my entire life. So when he asked me to participate in this meeting, I immediately accepted, not only because of his invitation, but for the quality of the speakers and of the presentation I've seen. On my presentation, I will a little move from the arguments that have been used till now, probably in a kind of integration, in the sense that before reconstruction, you have not to destroy, or if it's the nature that destroys something in the patient, then our duty would be to preserve the function and to make the less possible complication existing. Give me the time to share my screen, and I will immediately start my presentation that is not dedicated to the skull base, but is dedicated to the deep-seated brain lesion. And again, the best strategy to reconstruction is not to destroy. How can we be less destructive possible? Using all the stuff and all the tools that we have daily in order to understand the function and the structure and the anatomy in all the sense of the brain. And now it is diffused in the worldwide, the concept of connectome, that goes from genomics to connectomics in a sense that different brain function areas are connected each other in a complex network that is cortical and subcortical in a plastic way. And if we study this connection, we may save the function and we may preserve the final outcome of our patient. And in our OAL, being in India, being in Italy, being in US, the tools are basically the same. And you have seen that the stitches are the same in Germany that we use in Italy, and the materials to repair the dura or the cranial base are worldwide the same. And that is very important. We share ideas and we share knowledge, and the equipment we have are not different than the one that exists in all the different departments of neurosurgery. One of the special issues that we have developed in Messina is to use as much as possible the preoperative technology we have, that we have starting from the neurophysiological mapping in a preoperative way, combined with the navigated transcranial magnetic stimulation. This is a tool that is able to localize function cortically and to export information subcortically in order to understand not only the surface anatomy, but how the network goes. Look at this example. When you stimulate the cortex of a patient, you may elicit different functions in the arm, in the leg, in the face, if you take a look on the motor function. Or you can export these tools in other opportunities, such as all the networks that we are needed to use daily, and not only to localize the motor cortex and to define and segment, but also for language. This, of course, is in Italian because he's an Italian patient, but we are able to use transient virtual lesion and to assess the location of the language function in that single patient. We are able to export this information in the OR and to use it in a daily fashion, not only for language, not only for motor functions, but also for visuospatial or other activities, and in the reconstruction of the language and motor and visuospatial networks. How can we use this 3D network reconstruction to manage deep-seated lesion, as in these cases? Combining the network reconstruction with the use of tubular retractors that we have seen in the skull base in the presentation, and in the spine, the presentation that were before today shown different kinds of tubular retractors, but again, the strategy is the same. These are less invasive than standard microsurgical technique that is able to displace and not to disrupt the white matter fibers. And insertion of this tubular can be guided by navigation or by 3D network rendering, as I will show in some examples, in a kind of battlefield where you can look at a lesion and find the best strategy to reach the lesion in that single patient, assessing his specific function. Here is an example of cases that I'm presenting to you. It's a series of 10 patients with meningiomas, cavernomas, gliomas, and some mets, all deep-seated, that have been treated at our institution by this strategy. The method is a combination of the navigated transcranial magnetic stimulation combined with DTI, neuronavigation, and the tubular retractors in the OR. And here are some examples. This is a man with a left ventricle meningiomas. It's not a special case, but the search for the best optimal strategy is essential in a way to save his final function and his visual ability. This is how we reconstruct the the fibers of the arcuate fascicle in orange, of the inferior longitudinal fascicle in green, and of the inferior frontorbital fascicle in pink, and the optical radiation that you can see here in red. We have assessed not only the language pathways, but also the visual pathways of these specific cases. And let me show you how we can combine the information that we have obtained by DTI with a strategy that allows us to find out the best corridor to reach the lesion without inducing lesion in this patient. To preserve the fascicle, a posterior approach has been planned. See at this arrow. Curiously, this patient has only here the optical radiation. So here is the navigation in the OR, and you can see the movement inside his brain to reach the lesion and to remove it in a safe way. I will show in other case the other strategy that we have adopted. So again, the insertion of the tubular, navigated through the corridor we have anticipated, I've shown to you. Nothing different that we use in our OR, but probably new is the combination of the DTI generated by the MTMS. And here is the navigated insertion, the exposure of the meningioma, and standard microsurgical approach with coagulation, reducing the bulking and removal of the lesion. We can go, here is it, confirmation by navigation. I'll go faster. Here it is clearly the meningioma. Because we work in a corridor, we need to verify the limits of the approach and of the lesion, trying to assess if we can easily removing the lesion without inducing damage. And here is the microsurgical approach, coagulation, debulking, inside the bulking of the lesion, cavitron, ultrasonic aspiration, piecemeal fragmentation for histology, cotonoids to prepare the cleavage plane, and at the end, the removal of the lesion. Here is the postoperative CT scan that show the corridor, and the patient has completely no deficits. Here is the sparing of the fascicle that have been preceded, including the optical radiation that you can see in red, and the reconstruction DTI. This is another case, again a meningioma. Interestingly, again on the left, the corridor that has been chosen is quite different in these cases because of the presence of the optic radiation that here are in red, avoiding the risk of damage of the optic radiation and to use language pathway disruption. We use this different corridor that you can see here with the arrow, and again insertion of the tubular guided by DTI navigation and the patient-specific characteristics, same strategy as above, microsurgery, reducing the bulking inside, and organization of a plane to remove the lesion, and again here, and the complete removal. These are cavernous malformation. Is an interesting cases that I want to show to you. Is the last case I'm showing again on the left. Language mapping has been performed in this patient with finding of two cortical language essential sites that are close but not overlapping the cavernous malformation. That are the spots I'm showing to you. And here is the reconstruction of, in white, here is the cavernoma. And you can see in light blue, the arcuate fascicle, in green, the inferior longitudinal fascicle, and the IFOF in pink. And in this video, I'm showing to you immediately here is the lesion. So again, a safe corridor tailored to this patient. And if you look at the postoperative MRI, you may imagine a possible disaster, especially for language. But this strategy, look at the postoperative DTI that we have performed. Fibers are dislocated, but not damaged by the cavernous malformation that was here inside. And here is the reconstruction of the DTI fibers, again dislocated. Here the position of the cavernous malformation. You see the fibers opened up by the approach and by the tubular retractors. The results allowed with this strategy a close total resection of about 80% and just a 10% of subtotal resection and partial in 10. We observed immediately postoperatively 2 language and 1 visual field deficit in terms of an homonymous hemenopsia, but at 3 months, only the case with homonymous hemenopsia remained. The language deficit completely disappeared. So we obtained a 90%, 3 months complete recovery of the postoperative initial deficits, and the patient returned to normal life. This strategy allows us to improve our surgical planning in terms of risk assessment, finding the tailored surgical corridor to that specific patient, and may be considered as an useful adjunct to microsurgical technique in terms of finding a safer microsurgical corridor with a better control of the cavity and a preservation of the wide fibrous tracts. Again, as I've started, in order to reconstruct, it's better to preserve the neurological function. I thank the organizer for the opportunity. I have concluded my presentation. Thanks again.
Thank you, Professor. Technical demonstration. Really, it was highly educative and informative. Thank you very much. Probably at the end of the last talk, we'll have a discussion. You have 2-3 questions to answer. Probably you please stay back. In the end, we'll go through the questions. Okay. Thank you very much.
Thank you, sir.
Thank you. Professor Henry, I think there's a little change. Now, Professor Sanjay Bihari, he's available now. I think next talk will be by Professor Sanjay Bihari. Professor Sanjay Bihari, my best friend, and is at present Professor, Department of Neurosurgery, Sanjay Gandhi Postgraduate Institute of Medical Sciences, STPGIMS at Lucknow. His areas of interest are skull base and neuro-oncology, complex spine and craniovertebral junction studies, surgeries, and vascular neurosurgery. Welcome, Dr. Sanjay, and we would like to hear you, and stage is yours. Please go ahead and start sharing your screen. Thank you.
Can you see my slides now?
Yes, Sanjay. You can see and you can hear also. Yeah. Please go ahead.
So I'm really honored to be here, and I'd like to share with you some of our experience with surgery for petroclival meningiomas, the decision making regarding the approaches, and neurorehabilitation. So what exactly is a petroclival meningioma? It's not really a petroclival meningioma, it's a petroclivotentorial meningioma, which is just anterior to the 5th cranial nerve and is attached to the clivus and the petrous bone here. And there are multiple insinuations, multiple blood supply, and the arachnoidal plane is often deficient. So how is the surgical approach decided? So if there is a suprasellar tumor, or there is a tumor anterior temporal going into the cavernous sinus and above the internal auditory meatus here, then you can use very well the half and half approach, which is a combination of frontotemporal, transsylvian, and subtemporal transtentorial approach. So this is a combination of transsylvian and subtemporal approach. If the petroclival lesion is in the middle and the posterior fossa mainly, but above the internal auditory meatus, then Kawasai's anterior petrosectomy, which is a transzygomatic subtemporal anterior transpetrous transtentorial approach that is to be adopted. If there is a large lesion below the internal auditory meatus with intact and serviceable hearing, you can either go retrosigmoid, which is our most conventional approach, or you can go pre-sigmoid. So you can actually go pre-sigmoid, go directly to the tumor, and also combine it with the subtemporal approach. If there is a large lesion which is extending across the clivus midline and into the cavernous sinus, and there is a serviceable hearing, then you can do a combined anterior and posterior petrosal approach. If there is a small lesion just anterior to the internal auditory meatus here and not reaching the midline, of course, our retrosigmoid approach, but the cerebellum has to be retracted medially and downward so that you can go directly to the fifth cranial nerve. And finally, if there is an extensive middle and posterior fossa tumor with no serviceable hearing, then we can do a complete petrosectomy and actually get to the entire large tumor. And let me demonstrate some of these cases. So why not retrosigmoid always? Why should we keep so many approaches? Like there is the simple tumor here, which is going into the peduncle. And as you can see, when you actually come to the diffusion weighted images and T2 weighted images, you find that there is a lot of edema in the brainstem and there is a pile breach. So even post-operatively, you see that there is cerebellar edema and there is also brainstem edema. And this patient will have a long-term problem with rehabilitation. So sometimes, you might leave a little bit of tumor or you might choose another approach to approach this lesion. Now, the other problems with a classical retrosigmoid suboccipital craniectomy is that you have to work between the cranial nerves. So this is the 7th, 8th nerve complex here. You work and above the 7th, 8th nerve complex, go on dissecting the arachnoid. But sometimes what happens is that the tumor is below the cerebellum and it is difficult to actually reach the entire tumor below the brainstem. And therefore, sometimes you have to work in the corridors between cranial nerves and completely decompress the tumor, go on decompressing the tumor. The 5th cranial nerve, this is the 7th, 8th cranial nerve complex. This is the tumor, this is the fat which is placed on the petrous bone with fibrin glue. And this is the tumor cavity and this is the arachnoidal plane. So you have to work between the cranial nerves. You have to shift the cerebellum downwards and medially rather than working between the 9th, 10th and 7th nerve corridor. So you have to work on a corridor which is infratentorial and lateral supracerebellar corridor here. Let's look at another patient where the tumor is in the supracellular cistern, going into the middle fossa, going into the posterior fossa. And this is the postoperative image which shows a fairly good removal. And here we went by the half and half approach. So first we separated the temporal dura from the cavernous sinus dura and worked between the maxillary and the mandibular nerves and remove the tumor from the cavernous sinus. And it was possible to go on removing tumor extradurally from the cavernous sinus. And you could see the cavernous carotid artery here. And the important point is that a lot of tumor is decompressed through the extradural plane before you actually even open the dura. So there is no chance of, very little chance of, temporal lobe and the frontal lobe bulging because of the tumor. So as much of tumor as can be removed from the extradural approach. And of course, a zygomatic craniotomy has also been done. So you must be careful when you are actually dissecting the tumor from the cavernous sinus. The first is you should not go too much anterior in the cavernous sinus because there is still some patent vessels there, the veins, and this can cause significant bleeding. And the second thing is medially, you will always find the carotid artery which is pushed medially. And therefore, you must actually be very careful when you are going with a medial approach. And this is a piecemeal dissection within the cavernous sinus from where they can remove the maximum of the tumor. So the advantage is that there is an extradural retraction of the temporal lobe. And the next step is that you dissect the transsylvian approach. And this approach is usually this is the superficial middle cerebral vein. And this is the frontal lobe. And this is the frontal subfrontal area. So this is the arachnoid of the subfrontal area. And you can see the carotid artery here. This is so a very good transsylvian dissection. So you can follow the carotid artery to the middle cerebral artery here. And this is the optic nerve. So, and then once a good sylvian dissection has been done, then follow the temporal lobe. These are the anterior temporal vein going into the sphenoparietal sinus. You can coagulate and divide a few anterior temporal veins. And this is the bulging cavernous sinus. Here you can see the tentorial edge. And this is the carotid artery. And there you see the tumor there. And this is the lateral to the carotid artery. This is the tentorial edge again. And and the brainstem will be medial to it. So then you do a good cavernous dissection. And this is the third now, which you can see going into the cavernous sinus. So now there you can see the third now going into the cavernous sinus. This is the subarachnoid part of the third nerve. This is the tentorium, this is the cavernous sinus. And now the tentorium is retracted so that we can actually see the fourth nerve. Why is it important to see the fourth nerve? Because you would always divide the tentorium posterior to the fourth nerve. This will facilitate two things. One is the tentorium has two layers, and both these layers have a venous lake. And so if you are working posteriorly, this venous lake will not come in your view. This is the third nerve. This is the ambient cistern. This is the tentorium. And now we are giving a division on the tentorium posterior to the fourth nerve. So both the leaves of the tentorium have to be divided together. And this is the temporal lobe, which has been gently retracted backwards. And once you divide, you can see the fourth nerve there. You can still see the fourth nerve there. This is the division of the tentorial incisura. And now you get the entire tumor in the posterior fossa. So with a subtemporal approach, anterior subtemporal approach, with a transsylvian approach, we have been able to take out the entire tumor from the suprasellar area. We have been able to take out the tumor from the posterior fossa. And finally, you see the fifth nerve, the subarachnoid part of the fifth nerve and the brainstem and the arachnoidal plane of the brainstem in the posterior fossa. So from a half and half approach, from the middle fossa approach, you can actually directly reach the tumor, which is both in the suprasellar area, in the middle fossa, in the cavernous sinus, and also in the posterior fossa. And then with a piecemeal dissection, trying to cut off the connection to the tentorium, the fourth nerve is still intact. You can see the fourth nerve there, and you can actually decompress the entire tumor from the middle fossa approach into the posterior fossa. And there you can see the fifth nerve and the surface of the brainstem covered by the arachnoid. So you get a fairly large corridor, which is facilitated by our transsylvian dissection, which is facilitated by our anterior temporal retraction and by the tentorium cutting. And then this is the final part of the tumor after it has been dissected from the tent, and you see the entire brainstem, you see the intact fourth nerve, you see the sylvian fissure, and this is the anterior temporal lobe. So you get a fairly good corridor, and the reconstruction involves putting in a lot of fat here and then splitting the temporalis into two parts. So one part you can stitch to the dura of the frontotemporal region, and a part of it you can keep it on the bony surface. So this is a very good approach for a suprasellar region, which is also going into the cavernous sinus. Now we have another tumor where the tumor is mainly in there along with the tumor in the posterior fossa, causing significant brainstem compression. There is significant tumor blush here. You can see the stretching of the blood vessels on angiogram. And this is an extensive, fairly extensive petroclavian meningioma. And here, with the same approach, we are doing a transsylvian dissection first. And here, one thing which really facilitates this approach is that if the tumor has completely invaded the tentorium, then just opening the sylvian fissure first, and then doing an anterior temporal lobectomy. So if you do an anterior temporal lobectomy, you directly reach the tumor, which is involving the tentorial incisura and is infiltrating into the tentorium. And as you go on dividing the tentorium and removing the tumor, you get a very nice corridor, which takes you into the posterior fossa, into the ambient cistern, and you can see the posterior cerebral artery here. Now there's a little bit of bleeding from the posterior cerebral artery when we are doing the dissection, probably from some perforator. So please resist the temptation of causing coagulation here. It will cause an infarction in the region of the posterior cerebral artery. It is much better to mash muscle, put thromboplastin, and then put fibrin glue. And that takes care, that will release thromboplastin, tissue thromboplastin, and really stop the bleeding. And then the whole tumor can be dissected from the middle fossa and the posterior fossa. And there you can see that there is a very large corridor created. And you can see the branches of the basilar artery. You can see the basilar artery here. You can see the posterior cerebral artery on both sides and the superior cerebellar arteries. And the entire ambient cistern is now completely denuded of the tumor. And therefore, this is a very nice approach. And a little temporal lobectomy gets you the good corridor. Then comes another very interesting tumor, which is predominantly in the posterior fossa. You can approach it using a retrosigmoid approach, but this was completely calcified. So we prefer to directly approach it through the middle fossa by using an anterior petrosectomy or a Kawasai's approach. And how do we actually do that? So one important caveat when you are operating, doing an anterior petrosectomy is that the anterior petrous apex is quite posterior. So it is at the root of the zygoma. So the craniotomy has to be centered at the root of the zygoma. And then we are going extradural subtemporal. So this is the extradural subtemporal approach. This is the temporal fossa. You can see the groove of the middle meningeal artery. This is the middle meningeal artery being cut, and you can see the mandibular nerve here. The maxillary nerve will be somewhere here, and the tumor can be seen just posterior to it. So go on dissecting this till you reach the edge of the bone. You have reached the edge of the bone, and then a very nice dissection would be to separate the cavernous sinus dura from the temporal dura. Once you do that, and with a little release of CSF, the temporal lobe retracts very simply, and then you can go to the edge of the petrous bone and keep it there. Now, this is the mandibular nerve. You have the groove for the superficial petrosal, greater superficial petrosal nerve, and you have the arcuate eminence here. So arcuate eminence, greater superficial petrosal nerve, where you have the carotid artery, and this is the entire tumor that you see. So this tumor can be removed using the Kawasai's quadrilateral, and because this was calcified, so we had to drill a significant portion of the tumor in order to decompress it. Now the problem is that the corridor available with this was very, with the extradural corridor was very little. So what we did was we opened the dura and went subtemporal and saw the tentorium from the subtemporal aspect and saw the entire tumor. And so a part of the tentorium was also torn because of the infiltration by the tumor. And now we have the tentorium, and this is the cutting of the superior petrosal sinus here. So once the superior petrosal sinus is cut, the free margin of the tent is cut, and you see the entire tumor from the middle cranial fossa to the posterior cranial fossa. And a part of the tumor is calcified. So again, using a drill, since we have a very wide corridor, we can actually use the drill very gently using a diamond drill, and the broader the diamond, maybe 4 mm drill, we can actually gradually decompress, break it up into pieces, and then remove the bony pieces. So just by doing that, we can just gradually decompress and go on removing. The problem with the calcified lesion is that the capsule does not fall into the tumor cavity created. So here, using a drill, you have to break it up piecemeal till the tumor starts getting mobilized. And here, even here, you have to make sure that the arachnoidal planes are well maintained. And you can see that the fifth nerve can be seen here and the arachnoidal plane. So you do need a wide corridor by doing an anterior petrosectomy. This is the mandibular nerve in the middle fossa, and the Kawasai's quadrilateral has been drilled. The tentorium has been cut, and you can see the posterior fossa, the tumor is being removed from the posterior cranial fossa. It was impossible to decompress it. Normally, you would not remove it in toto, but you would actually decompress it a little. But since it was absolutely calcified, so we could remove it. And this is the posterior fossa capsule that you see here. And then reconstruction consists of putting fat with the fibrin glue here, and then taking a layer of the temporalis fascia and stitching it onto the dura here, and then keeping the outer layer, the outer pedicle of the temporal muscle over the temporal bone and the zygomatic bone. And the zygomatic bone, usually we keep it in the temporalis muscle only, so that when we reposition the temporalis muscle, the zygomatic bone actually falls in place, and we can just put mini plates or sutures there. And then the postoperative scan from the middle fossa, the entire tumor could be removed from the posterior fossa also. And now we can sometimes have a tumor which is mainly in the posterior fossa and going below the internal aortic canal, and the entire petrous bone is actually adherent to the tumor. It is arising from the entire petrous bone, both and coming right up to the base. And here we can use a pre-sigmoid approach. So what we did was we did a mastoid drilling, used a pre-sigmoid approach, and the advantage of using a pre-sigmoid approach, this is another tumor. So the advantage of using a pre-sigmoid approach is that you can go from the petrous into directly into the tumor without encountering any cranial nerve of the cerebellopontine angle. So what do you do? This is the spine of Henle. This is the mastoid base. This is the digastric groove. So following the spine of Henle downwards leads you to the vertical pass of the facial nerve. So leave a thin piece of bone on the vertical pass of the facial nerve, then do mastoid drilling, go posteriorly toward the sigmoid sinus, deroot the sigmoid sinus till you reach the cortical bone of the semicircular canal. Stop here. If you drill any more, then the patient will lose hearing. So preserve the semicircular canals, because if you drill the semicircular canals, then you go to the seventh nerve, the meatal part of the seventh nerve. And if you just mobilize the seventh nerve in its canal, then you go into the internal auditory meatus from the mastoid area. But you don't want to do this. What you want to do is to preserve the semicircular canals, go to the sigmoid and deroot the entire sigmoid sinus, come to this area here, which is known as the Trotman's triangle, and from there directly reach the tumor and decompress it. So this is the incision, the horseshoe-shaped incision here, which is in the middle fossa and going up to the posterior fossa. And then you make a burr hole here. And the important thing when you're actually starting your surgery is to expose a little bit of temporal dura by doing a craniotomy, doing a retrosigmoid suboccipital craniotomy. This is the mastoid, and this is the transverse sinus. So once you do that, you get your bearings right, you see where your sigmoid sinus is, and then you start drilling the mastoid. So once the mastoid is drilled, keeping the facial canal intact. So this is the inferior portion, this is the superior portion. You have kept the facial canal intact here. And then the entire sigmoid sinus has been deroofed. And then you come to the Trotman's triangle by retracting the sigmoid sinus. Now, the problem with this is that this part is not very wide. And these are the semicircular canal, the cortical bone covering the semicircular canals. So by retracting the sigmoid sinus, you do give a vertical incision on the Trotman's triangle and directly reach the tumor. And all you need to do is to go on decompressing the tumor till you reach the arachnoidal plane, and you do not encounter any cranial nerve. You just encountered the cerebellopontine angle cistern. And then you just do a dural reconstruction. Finally, we have very extensive tumors. You have this tumor in the middle fossa, in the posterior fossa, going into all the cisterns. And here you have to use multiple corridors. You have to compartmentalize and actually work in different corridors: precellar, retrocellar, carotid-ophthalmic, paraclinoid, cavernous sinus, temporal, anterior petrous, and retroclival. You have to do an angiogram to see what is the space available. You have to do a zygomatic osteotomy along with it. But this patient did very well. And just before discharge, she was tracheostomized and had a Riles tube in place because she had very significant lower cranial nerve palsy and was almost quadriplegic. And then she improved. You see, this is the image. If the tumor is a little soft in consistency, then it will be possible for you to extensively remove the tumor with multiple corridors. And after 1.5 months, the tracheostomy tube was removed and the patient became completely ambulant. So some of these tumors will have a very, very good prognosis provided you aggressively remove them. And there is another one where we went through the middle fossa approach and also to the posterior fossa approach. And this was a meningioma here. So when we went to two multiple corridors, we could actually remove totally the tumor, which is, so sometimes you might want to use double corridors. And sometimes you might want to use an anterior and posterior petrosectomy. So when you see this irregularity and edema along the brainstem, then the arachnoidal plane has been breached. So you might want to leave a little thin capsule of the tumor along the brainstem so that the patient does not develop severe brainstem signs. And here we did a total petrosectomy, reaching right up to the internal carotid artery canal here anteriorly, and completely remove this tumor from a complete petrosectomy. So our results can be seen in this publication of large and giant petroclival meningioma, where we focused on the middle cranial fossa approach. Gamma knife is a very good adjunct, and now I think if there is a significant amount of tumor left at the cavernous sinus or at the brainstem, then you could give gamma knife with a recurrence rate as low as 5% and morbidity only in about 6 to 7% of cases. But there is a short follow-up, and long-term radiobiological effects are still not known. So as far as possible, avoiding deficits and trying to do a good job is the key.
Professor Sanjay.
So what is the consensus? In greater than 50% of tumors, The change in growth rates can predict clinical deterioration. If there's an asymptomatic patient with a small petroclival meningioma, follow-up with meticulous radiological monitoring and increased growth rate merits active intervention. If there's a large asymptomatic tumor, please remember a large asymptomatic tumor, follow-up with meticulous radiological monitoring, increased growth rate merits active intervention. But if there is a large symptomatic patient, or if there is a small tumor which is growing at a rapid rate, then safe microsurgical resection with adjuvant stereotactic radiosurgery is the key to getting a good outcome and less morbidity. Thank you very much for your kind attention.
Thank you, Sanjay. It was excellent demonstration of the complex skull-based problems. When each one of us are called upon to treat, it is really good, and all techniques from all the angles. It was really educative and informative. I think the questions will go after the next talk or end of the session, because already we are running late by 3 talks. So we have now next 3 important talks again. I think by the end we'll discuss the things. Professor Henry, next speaker, would you like to?
Yeah, we have. Now we can continue with Professor Sandeep Chatterjee. He is professor of neurosurgery from Calcutta, and he has also interest in a lot of neurosurgical topics like oncology. And he will going to talk today about this pediatric spine and reconstruction techniques. Please, Professor Chatterjee, share your experience.
Thank you. I'd like to thank Professor Sinha and his colleagues for giving me this opportunity to present our experience of pediatric spine reconstruction with you. Screen. My screen is visible?
Yeah, it's okay. We see that.
Okay, so since I can't cover the whole of pediatric spine, I'm going to limit myself in children. And I'm going to start with like 25 years ago. This is a 12-year-old boy who had tuberculosis of the cervical spine and presented spastic coordinators, 4th cervical vertebra. And at that time, we had no option but to do a 4-level corpectomy, which had already been done. A field graft, and then whatever treatment we had at proposal 25 years ago. A lot changed, and this in spite of saying had a remarkable recovery, but pediatric spines, the
Of the video.
This problem being soft atoms of growth skeleton. So here's a child who's 12 years old with neglected trauma, and you can see the cervical spine. Of course, the cervical junction is the area to child. You take a correct, you go a total sign. And clearly this needs an anterior decompression and fixation. How do you get to that solution? Adults use the transaxillary or approach of sternoclavicular disarticulation. None of these are suitable for an adult. And that we we wrote about the approach where we do join using a craniotomy, if you please, and then U-shaped piece.
So it's a very bad connection. So it's hardly to understand anything. For me, I don't know how is it with you, but for me, it's very difficult. The connection is very poor, Professor Chatterjee.
He can off the video if possible. Dr. Sandeep Chatterjee, can you off your video? So it will be better.
But the micro should be on. Just stop the video.
Now, shall we call Professor Goyal?
I think it would be better because there seems to be a connection problem.
Yes, yes.
Yeah. Should we continue? Atul, are you ready?
Yes, yes, absolutely, absolutely.
I think you
Ready.
don't need any introduction. Everybody's knows you. I think there is no topic in neurosurgery where you not have a paper on, right?
Thank you, thank you, thank you, my dear Henry. Thank you.
Yes.
So should I share my screen or you?
Yeah, please go ahead.
Okay, you remove this one. Yeah. Just a minute.
So the topic is strategies for skull base and skull convexity reconstruction.
So I am going to talk on a subject where I normally do not talk. And normally people do not talk on this important subject. But I must say that reconstruction after your operation is absolutely important, absolutely mandatory, and it has to be perfect. And you will all agree with that. So what I'm going to present to you is some alternative methods of reconstruction of skull base with locally available alternatives. You remember this term, locally available alternative. And this is my very 25-year-old chapter, which I had written for a book. So this was my book in 1996, where I had described various skull base techniques and all those things, and also my techniques of reconstruction. So this was in my book chapter in 1996, reconstruction of skull base. And there is another chapter, reconstruction of skull base, some personal techniques. So you just see my locally available alternative. So we must remember that the dura is the most fascinating structure that God has made. It is like it embraces the brain. It embraces the entire, completely, all the brain and all the cranial nerves and all the foramina which are there in the skull base. And that is why dura mater or dura mother. And it will not allow anything to come inside, and it will not allow anything to go from inside to out. So no corona can go inside, and no infection can, there is a solid immunity inside the brain and so many other things which are so important. Now, if we have to do a good tumor resection in the anterior skull base, in the middle skull base, we have to prepare the operation right from the beginning as to how we remove the tumor. That is one, of course, but how we reconstruct the skull base after we have finished the operation. That is absolutely important. And that preparation has to be done before the operation is started. So anterior skull base has been repaired by various alternatives after transnasal operation, after transcranial operation. And you see these are historical slides which are showing fascia lata and all those kind of things. This is, of course, nasoseptal flap is not historical. It is latest innovation in the endoscopic skull base surgery from the nose. So we all know this vascularized pericranial flap of the anterior skull base. We all know for a long time this flap has been described. And you see there are multiple blood vessels in the anterior skull base which are used to design this vascularized pedicle flap. And I must tell you that vascularized term is very important for any flap to stabilize and to be accepted. So this vascularized, when you raise such a flap, and you raise a vascularized flap, and you see lateral flaps are not so common, or at least they were not so common, but there is so much vascularity in the lateral aspect of the scalp, including the superficial temporal arteries, middle, anterior, middle and posterior deep temporal arteries, temporalis fascia, and things like that. So my keywords are vascularized is my keyword, and the other keyword is locally available alternatives, which I am going to show to you. So all these pictures which I'm showing you are from my book in 1996. So there is nothing new which I am showing. So if there is a huge tumor in the anterior skull base and it is going in the paranasal sinuses, you can imagine if you remove the entire tumor, which you have to, of course, remove, then there is a question of how you will reconstruct the anterior skull base. And this was my technique, which I described 27 years ago. This was the tumor removed. Vascularized osteomyoplastic flap, vascularized bone flap for anterior skull base reconstruction. You see, I based the flap on pericranium. I've split the skull, and then I have mobilized the flap into the anterior skull base. Now you will ask me whether bone reconstruction is necessary or not, whether only pericranium was good enough. Those are questions which I don't want to answer at this point of time. But you see this picture, there is a split cranium here, and there is a bone flap in the anterior skull base. So this is what I had described. Vascularized bone flap for anterior skull base reconstruction. Now you see this another flap, vascularized osteomyoplastic flap. Now here there is a big skull base petrous bone defect, and you see the air bubbles going from intracranial to extracranial outside the ear, and the ventricle is communicating. These are very old scan, so you can see there is no MRI at that time, which I had not done at that time. But for this reconstruction, you see what I have done is I have taken muscle flap with bone flap. So that is osteomyoplastic flap. And then I have put some fat here, and then I have rotated this flap. So this is vascularized osteomyoplastic flap. So this was in 1994. You see here, this is the bone flap. These are split here. And this is then reconstruction is done using this defect is reconstructed using some bone from here, and it has been put here. And you see, this is the reconstruction anterior middle cranial fossa, osteomyoplastic bone flap. Now, this was another beautiful case. You see, there is a big osteoma in the forehead. And this osteoma, what I have done is, you see this flap. This is a long osteomyoplastic flap. This is muscle. This is facial layers of the muscle, temporalis muscle, both superficial and deep temporalis fascia, and superficial temporal artery, deep temporal arteries. The bone has been split here like this, and this split has been moved after removing of the bone, after removing of this tumor, the whole bone flap has been shifted here. So this is a long vascular pedicle cranial flap. So you must imagine if you use vascularized flap, the acceptance rate is higher, the take is higher, and there is no question vascularized flaps are indeed beautiful. Now you see very carefully this slide. This is the temporalis muscle. This is temporalis muscle has superficial temporal fascia, deep temporal fascia. The superficial and deep temporal fascia are continuous with the pericranium. So what I have done is I have cut here, and the pericranium along with the superficial temporal fascia and deep temporal fascia and the muscle. You see, this is a long vascularized flap. And what you can do is you can cut the fascia here and rotate it like that and keep it attached here. So there is a long muscle fascia flap. So this is a huge long muscle fascia flap, which you can rotate in the anterior skull base, in the middle skull base, and you can do beautiful reconstruction for glomeruloneurojugular tumors, for chordomas in the region of cavernous sinus, and for so many. So this long vascularized flap has been very extensively used by me. Now you see, this is the long extended vascularized temporalis muscle fascia flap. Now what is done here, this is the temporalis muscle. The superficial and deep temporalis muscles are rotated upwards, and there is a defect in the mastoid here, and this muscle fascia flap is rotated to fill the flap, fill the defect. And this is a very beautiful kind of reconstruction, extended vascularized temporalis muscle fascia flap. Now you see there is a huge defect in the middle cranial fossa, and there is CSF leak from here. And there is a defect, the whole temporal brain is herniating, along with there is an encephalocele here, you can see this. So to repair this kind of huge middle cranial fossa flap, what you require is, one is you have to understand the temporalis muscle. Then you have to understand the temporalis muscle fascia. So there are two layers which have been described, superficial temporalis fascia and deep temporalis fascia. Deep temporal fascia is the thick one. Superficial temporalis fascia is this one which goes along the pericranium. One more layer that we had described for the first time in the literature is Subgallial fascia, this is gallia. There is another layer which is subgallial fascia, which was first described in the literature by us. And that layer can be added to these two layers of fascia. And then what we can do is we can use a long fascia, temporalis muscle, subgallial fascia, superficial fascia, deep fascia, and pericranium. So you see here, extended subgallial fascia, this is a new layer, and pericranium, and superficial and deep temporal fascia and temporalis muscle flap. So this is a very huge flap that you can use for reconstruction in complex situations. So now we know the temporalis muscle is a very fantastic muscle, and it has great, and this is the muscle which affects our middle cranial fossa surgery, and that is why we do temporalis zygomatic osteotomy to get this extra space. So this is a commonly done procedure. So we had described splitting of the temporalis muscle to get this extra space without doing zygomatic osteotomy. And this is another kind of splitting which we have done, and which I commonly use, this splitting of the temporalis muscle for. We also use this basal extension of craniotomy for subtemporal. See, this is the craniotomy, anterior rotation of the temporalis muscle. So you avoid rotating the muscle on the zygomatic arch. Now you see the versatility of these flaps. So this is one long muscle fascia flap. You see, I have cut here, and this is one flap. And this is the rotation of this muscle after cutting the deep and superficial temporal fascia. Now, what you are seeing is multi-layered middle fossa reconstruction. So there is a big defect here. You rotate this flap first, and then this flap second. So there is a multi-layer in complex cases. So you can use this temporalis muscle in a very elaborate fashion. This flap first, this flap second. So we describe for this kind of reconstruction. You see the case which I had shown earlier with CSF leak. This is the reconstruction. This is the bone here. This is the bone flap, which is half now, which is placed in the midline. So there is multi-reg reconstruction of the middle cranial fossa floor, which I described 25 years ago. Now you see another very fantastic case. This patient was operated 13 times for CSF leak, son of a politician and a big time politician. And the whole ventricle was communicating with the middle fossa defect. And you see every time somebody used to go and they used to make additional holes in the skull base, and now the hole was in the right here, and he had undergone several shunts, ventriculoperitoneal shunt, ventriculoatrial shunt, thecoperitoneal shunts, and the ventricle was communicating like this. So we did this beautiful reconstruction, which I will show you. So this is the flap I used, by long muscle fascia flap. This is one layer which was rotated in the anterior skull base. Then you see I used multi-layer reconstruction of anterior skull base. This is the one flap. This is the flap from this temporalis muscle. And then there is this temporalis muscle. And there is a bone also here. So I used multi-layer reconstruction of anterior skull base using locally available alternatives and vascularized flaps. So what you can do for this kind of craniotomy, you can raise a big pericranium flap and you can rotate it down complete from, see there is a big flap here and you can rotate it down and cover the anterior skull base. We also describe subgallial preservation of calvarial flaps. You do craniectomy. I don't do craniectomies now. For last 25 years, I have never done decompressive craniectomy in my lifetime now after at least 25 years. But earlier we used to preserve the bone flap in the subgallial space. And then, so this was an important subgallial space, is a very beautiful space and quite a vascular space, and you can preserve without, and it is a local, you can do locally available. I also used reconstruction, which Henry will be interested, and we describe this mucosal flap. You see this mucosal, sphenoid mucosal flap? I use this as a vascularized flap after pituitary tumor surgery. And this is a very fantastic reconstruction, and you can avoid these nasoseptal flap and all those things. This vascularized mucosal flap we described about 20-25 years ago. We also described outer layer of dura as a pedicle flap for reconstruction about 25 years ago, and this can sometimes be used 2 layers of dura and you can use the outer layer for reconstruction. So this is the one case we described where we use a 3D model to find out the bone defects. And this model, this was also a very high profile administrative officer, and underwent several operations with great failure. And you see the defects, and I used this kind of investigation to find out where the defect is and how we have to do reconstruction, and we did fantastic reconstruction. And at the end, you can use these kind of tenting stitches. This was incidentally my first article in the subject of neurosurgery in the year 1987, where I used this kind of tenting stitches. You see these tenting stitches? Tenting pericranium subgaleal stitches and tenting pericranium and bone stitches. So when you close, at the time of closure, you can approximate the scalp firmly with using these tenting stitches. I find them very fantastic and very useful. Same concept of vascularized pedicle. I described this vascularized pedicle laminectomy or laminoplasty. Vascular, cut from here and rotate the whole flap of laminectomy as a vascularized pedicle flap. And we described this for the first time in the literature, and many people like to use this vascularized pedicurium flap instead of loose free spinous process, which also we described, and you see this can be used beautifully. So this was my laminoplasty using spinous process. These were free flaps, but later I described vascularized pedicle laminoplasty. So these I have published on several occasions: rotational temporal flaps and reconstruction of anterior transcranial after malignant tumor resection, how to do reconstruction and things like that, and repair of skull base defects in various journals at various point of time. And you must, if you have time, please read some of my beautiful work on skull base reconstruction. And we must all realize that skull base reconstruction is a very important component of our surgery. It has to be done beautifully. It has to be planned before operation, and it has to be done preferably using vascularized flaps locally available, which are available in abundance. Thank you very much, my dear friends.
Thank you, Atul, for this nice presentation. As expected, for every technique, a paper.
Thank you.
But I completely agree. If you have an area which is not well vascularized, you should bring a living structure into it. And this is a vascularized flap. I completely agree with that. So I think we should discuss now before we start with Miguel Ares' talk, correct?
Yeah, that's right.
Can you read some of the questions? Suresh, do you have questions for a speaker?
No, at present, there are no questions at present. Probably at the end of the talk, I think we can have the discussions. There are no questions at present.
Okay.
They're all best wishes to Professor Goyal for his excellent talk. Compliments to Professor Goyal.
Thank you so much, Suresh, and so nice of you, and so nice of, I enjoyed my presentation, and there is a big opportunity for me. Thank you.
Thank you. We also had a good time and enjoyed it. So many flaps. Even for a younger generation, it is really a big lesson.
Just one comment or two for your recommendation for the endonasal reconstruction. Unfortunately, the mucosa is frequently very thin, and so I think it's not a very robust flap. So if you have the luck to have a thick mucosa, you can use it. But most of the time, and at least in our patients here, it is very thin and not so.
Henry, I agree with you. You know what? In India, in particular, and I am not sure if other panelists will agree to it. You know, in India, we have a lot of infection, nasal infection and paranasal infection, much more than any other country. And I have a feeling that the mucosa in the paranasal sinuses in Indian population is much thicker than what we see in a Western population. This is my impression. And I also know that you cannot use mucosa in every case, but in some selected cases where the mucosa is thick, particularly in cases with acromegaly, you have a thick mucosa and you can use that mucosa effectively, and you can avoid other kind of reconstruction in some selected cases at least.
Yes, all right. I agree.
One small comment that I'd like to make. I have found, Professor Goel, that whenever we use a bone flap in communication with the paranasal sinuses, it often causes, a subclinical infection. So for the anterior skull base, just using a pedicle pericranial flap is usually and putting, bone, even if it's vascularized, may cause the problem.
See, that is a very important question, whether you want to put a bone or you don't want to put a bone. That is one thing. You, in most instances, there is no need for bone. There is some echo coming, Henry. Is that okay or what? Yeah, now it's better. So it is one question. Number one is whether you want to put bone or whether you don't want to put bone. That is a question. These are my flaps, which are 25, 30-year-old flaps. I'm not saying I'm using bone in all the flaps now. I am not using bone in several of these cases, but this is an option. Second thing is bone. You cannot put bone in proximity to paranasal sinuses without putting a fascia, without putting pericranium. There has to be a layer and bone has to be, you cannot expose the bone to the paranasal sinuses. You will certainly infect the bone. So you have to have some layer of tissue which is vascularized and the bone has to be put over it. Bone cannot be put directly in front, but bone reconstruction is very useful in the orbital region. And sometimes in the middle fossa, you have a big defect following chordoma surgery and following various, you can use that very effectively, this bone flap reconstruction.
Exactly.
Can I ask you a question, please? Dear Atul, welcome.
Yes.
Good to see you.
My dear brother,
And, I'm happy to find out that you are not only a constructive neurosurgery, but also a mainly reconstructive one. And I enjoyed so much your presentation. I have a very simple question to do. You showed the beautiful experience of temporal muscle flap transfer to repair middle cranial fossa lesions. And my question, very simple question is, what do you think of the opportunity to split the muscle in two layers, like the sheets of a book, and so leaving the one, making the masticatory function still effective in order to spare the complication of dysfunctioning of mandibular activities, and to use the other half to repair the bone. What do you think about this option?
Yeah, this is a very important thing that you are saying, Dr. Visochi. The thing is, you know what, I have shown you that we can split vertically. There is a vertical split, and then the posterior part you can use, and the anterior part you can replace back. After all, temporalis muscle is a very important muscle. Now, what is important is, if I showed you the temporalis muscle has huge vascularity. The vessels in the temporalis muscle, the superficial layer, temporalis artery and the deep temporal are so massive that you can use a very vascularized flap instead of using, any other free flap or any other, if these vascularized flaps are absolutely, you can use free pericranium. But instead of using free pericranium, if we use a vascularized temporalis muscle, fascia, and pericranium, it gives a very effective barrier. And you can rotate the flap in a very circumferential manner from anterior fossa to middle fossa to posterior fossa. I use these flaps very often after glomus jugulare surgery. Very important flap for me, this extended muscle fascia flap.
Yeah, and second consideration, since you underline that it is an hypervascularized flap, what about the hemorrhagic complication, post-op hematoma, or swelling of the muscle itself, and so compression of the temporal base? What's your opinion about that?
So this has never happened, but this can certainly happen. This can certainly happen. So what you have to do after the flap, whatever vessels are going beyond the flap, you have to coagulate. and you have to achieve your hemostasis. It is not so beyond it. Such long vascular flap is not that vascular that blood will come out of the flap. So you get your hemostasis, have a long flap, and then rotate it. This is very effective flap.
Professor Visochi, I'd like to make a point here to the splitting of temporalis muscle. You know, the pterygoids are very strong muscles, and usually there is no mandibular malocclusion based on splitting of the temporalis. There may be a little atrophy of the temporalis muscle, but there won't be any malocclusion on chewing. The only problem is if you extend the incision too low, to right up to the capsule of the temporomandibular joint, then it becomes a big problem because, you know, later on at follow-up, opening the jaw becomes a big issue. And that is something that we have to really guard against. So when we are actually making the flap, taking your incision right up to the temporomandibular joint, when we are splitting vertically the temporalis muscle, one should really guard against. That's, I think, a very, very important point. Otherwise, you know, the patient later on cannot open his mouth completely. That's a big issue.
Thank you, Sanjay. I think already we are quite late. I think excellent discussions and excellent information. Professor Henry, I think, shall we go ahead with the next talk?
Yes, I think we should now go to Miguel Ares from Spain, Malaga. He's known to everybody of you. He's very active in the World Federation, and he's the chairman of the foundation of the World Federation. And he will going to talk about neuroreconstruction of the mid-base historical perspective. Miguel, please.
Henry, good afternoon, everybody. Thank you for the kind introduction. And also thank you to Dr. Sina and Dr. Visochi for the invitation to this wonderful webinar. My apologies because due to unforeseen reasons, I have to go to the hospital and my talk has been rescheduled. I think that my talk, I will share my screen. I hope, okay. Okay, can you see my screen and can you hear me?
It's good. Yeah.
Thank you.
Thank you.
Thank you. So I appreciate very much the talk of my very good friend Atul Goel, because due to that, my talk over the next 10-15 minutes will be useless. He has said everything, and I very much appreciate the perspective and these beautiful images. So, well, I will go around this historical perspective, and I think that initial description of something related to the need of skull-based reconstruction came from the description of Galen, who just talked about the first time in the history of medicine about CSF fistula. And we have to mention that the surgical management actually came up 1 century ago. As you can see some videos about what happened exactly 100 years ago. This is just top on bottom left. This is on the occasion of the 2000 craniotomy of Harvey Cushing. And we can imagine the way of working at that time, and we can imagine the difficulty for reconstruction. But at that time, even before that, 1913, an approach to the hypophysis through the anterior cranial fossa by Dr. Frazier. So due to that kind of operation, you can imagine that skull base need reconstruction, and it happened. And it began more than 1 century ago. If we go to what we consider the more recent history of the skull base, we have to go to the 60s, the moment where the concept, what we consider now the concept of skull base, did start. Ethmoidal carcinoma, as you know, was the first operation considered to be a real skull-based approach, and skull-based reconstruction with rotated temporal muscle was very popular in the 80s. As Professor Goel mentioned, this is one of our cases. In the late 80s, I was at the end of my training program. It was the first case I was involved in my last year of the training. And this is in that particular case when my interest to skull-based start. And you can see how the temporal muscle through the maxillary region was rotated and able to be sutured to the mid base. And later on, and in the 80s and 90s, this very well-known approach was very popular. Extended frontal approach. It was based in the publication and seminal work of Patrick Derome, the transbasal approach. And you can see how the reconstruction is not only related to the dura, but also to the bone. This is one of the examples. In the late 80s, I was also involved. You can see this huge tumor. Just you could see that through the nose, and the way we can do this by frontal craniotomy, orbitofrontal osteotomy, leading to the removal of the tumor. At that time, we used for a huge dural, let's say, defect, that kind of alien material that very soon we did abandon because of the high rate of failure, infection, and not satisfactory watertight seal. We use also to do some fat. At the beginning, we were not very confident about the possibility of infection and things like that, but little by little, fat became a very good ally of our techniques. And as Professor Goel mentioned, the pericranial graft, vascularized pericranial graft, has been absolutely useful, basically when talking about transcranial approach to the anterior fossa. This is one of the examples. You can see a typical chordoma, the way of growing and just invading and compressing the brainstem, and the way, okay, this is first step after anterior fossa osteotomy, optic nerve decompression extradurally, and the way we managed to drill the clivus, and in that particular case, and due to the soft consistency of chordoma, fortunately, we did manage to remove the lesion from the macroscopic point of view completely. And this is the way the skull base was reconstructed with this simple pericranial graft that was sutured to the posterior wall of the pharynx and was very useful. Some other complex anterior fossa lesion, this is a chondrosarcoma, not only invading mid-face, not only invading mid-base, orbit, and so after proper hemimaxillectomy, as we used to do that at that time with maxillofacial surgeon and ENT colleagues. I like to mention Dr. Eduardo Valencia, that was an amazing person, an amazing surgeon, and we did learn a lot of things. And as I mentioned, we have to do the removal, but also reconstruction. Nowadays, this case probably is going to be done without much problem, at least the big facial part by means of endoscopy, but at that time we used to do in combination with ENT that kind of aggressive approach. And as you can see here, using the area of removal of the maxillary anatomy, we managed to rotate the muscle and link to the muscle pericranial graft. I like very much, I enjoy very much hearing my very good friend, Professor Goel, talking about the so many different possibilities that imagination may provide, and we have been using that for a certain, let's say, number of years, not only muscle, but also muscle with pericranial graft, pericranial with galeal graft, a lot of possible combination. And I think that also very interesting to see how Mother Nature is helping us. This is the muscle. This is 2 months after the operation. This is the way we just suture to the hard and soft palate, and this is the muscle nicely epithelialized because of the contact with some air cavity. Mother Nature just is giving you a hand always in terms of reconstruction. So pericranium frontogaleal Myofascial flap, combination of that possibilities, temporal myofascial flap, fat graft, and microplates, of course, later on, just to make the fixation of the bone. Very important point about the reconstruction and extent of surgery. This is a patient we operated at that time. It was the early 90s. You can see this tumor. It was a malignant meningioma. See the invasion relationship with the anterior circle of Willis. So what we wanted to do at the operation? Of course, radical removal. So we did radical removal. Sorry, bad quality is taken from some slide at the time, but you can see pituitary, you can see optic nerves, both carotid. This is clinoid, planum sphenoidale has disappeared, sphenoidal bone, optic, optic nerves, and orbit region. Very satisfactory removal, but my dear friends, how to reconstruct in a watertight fashion that kind of extensive removal? So we try to do our best, lying down some pericranial graft, but look at what happened in the postoperative period. The patient was coughing, pneumonia, pneumocephalus, and finally the patient died. So we learn case by case that sometimes in the first operation, in one of the first attempts, you have to, this is another case, you have to sacrifice at the beginning, in the first operation, the extent of the removal, trying to be sure that you will get a completely and satisfactory reconstruction. Because in the best hands, anterior fossa invasive tumors, in the best hand, rate of complication due to reconstruction over 50-55%. So in cases like this one, by the way, not amenable for endoscopy due to the invasion of the bone along the anterior fossa, we have to make a partial removal and then leaving the part of the tumor involving clinoid, involving the posterior planum sphenoidale and tuberculum cell intact and ready for reconstruction. And then after reconstruction, you have to figure out what the next step of operation of complementary radiation therapy should be, because otherwise 100% resection, that's okay. The patient dying at the postoperative period, as I mentioned before, frequently due to reconstruction. We also have some other tumors, of course, in the skull base. This is a very easy case to be reconstruct, pericranial graft, or wherever inside you can put graft, you can put a muscle, you can put fibrin glue. You have to try to preserve mucosa. I don't think this is a very complicated case for reconstruction, but this is far beyond the difficulty of the previous examples. So we also did many, going through this journey along the last decade, in the late 80s, 90s, we did many cases by means of this open door maxillotomy as popularized by Professor Crocker. See this chordoma, classical example, nowadays, of course, removed by endoscopy. But at that time, by means of maxillotomy, open door maxillotomy, that was, as you know, Lefort-1 osteotomy with the addition of midline splitting of the hard and soft palate. Before that, we used to put microplates in order to avoid any problem with occlusion. And just after that, we removed microplates, making osteotomy and removal. Sorry. You can see one of the videos. This is something nostalgic for me, because we did many cases, I think successfully, but later on endoscopy came to stay, and now we are embracing that technique. But we used to do the Crocker retractor, removing, in that case, extract dural lesion, drilling around after the removal. Okay, and in any way, if dura wasn't open, just using fibrin glue, satisfactory result. Also for cases in that hourglass fashion growing inside posterior fossa, it was a very good approach. You can see the removal of the intradural component very carefully, because we had important brainstem compression. The opening of the dura was followed by some cardiac arrest transiently, of course. So we had to be careful. And anyway, radical removal, as you can see here, unsatisfactory extent of resection. You can see vertebrobasilar system, lower cranial nerves, and the way we used to reconstruct. Big piece of fat, as you can see here, lumbar spinal drainage for 5-7 days, and then converting that into permanent lumboperitoneal shunt to avoid CSF fistula that was terrible. And last part of our journey, endoscopy. This is something that came to take part of the armamentarium. Just regarding the youngest colleagues in the audience, we are very much loving endoscopy, but please keep in mind the usefulness of many skull-based, classical open microsurgical skull-based approaches. Anyway, this is a case that is giving us remembrance of one of the initial cases in the sense of chordoma growing inside posterior fossa. This is pituitary, of course, growing toward nasal cavity, optic nerves, and that kind of tumor just more than 10, 12 years ago, we started to remove by means of endoscopy, very satisfactory result. At that time, at the beginning, we were still linked to the classical techniques of spinal drainage, fat graft, and so, but look at what happened 10 days after this operation. We just readmit the patient due to CSF leak, and CT scan, you can see some bubble of air, very bad sign, meningitis, and CSF fistula. So we learn in the context of our learning curve that we have to modify our technique. And this is when we did embrace nasoseptal flap. You can see the very easy way of see where the skull base had been, not properly reconstructed. Just very quickly having a look inside, and this is the brainstem. So from this case operated on 2009 on, we just modify. We managed to solve the problem with fat graft, but we just learned that we have to go back to the currently accepted, widely accepted, wonderful techniques for reconstruction at the skull base when CSF fistula is coming. This is one of the chordoma cases. See this arachnoidal membrane leaking, and the way nowadays the nasoseptal flap is very easily and very effectively solving the problem of the closure of the anterior fossa at the endoscopic endonasal approaches. You can see this robust and very nicely vascularized flap that is giving you some idea that the postoperative period is going to be smooth and satisfactory. But in any way, we are talking about chordoma. This is not the main aim of my talk, but clival tumor personal view, back to microsurgery in certain cases. Upper and middle third of the clivus, we do endoscopy for chordoma cases. Lower third of the clivus, anterior and lateral foramen magnum, see this case, see this chordoma. We just went back to the classical far lateral approach that is very satisfactory. You can see the transcondylar approach, exposure of the vertebral artery, drilling around. This is real condylectomy. This is the condyle that is removed in the context of the radicality of the lesion. This is a very pretty satisfactory MRI after the operation. You can go to the anterior foramen magnum from posterior lateral. This is something very well known, and I learned a lot from that from Dr. Bertalanffy, who is mastering this approach. And also talking about reconstruction, the reconstruction of the skull base is not only a reconstruction of dural plane, CSF fistula. We have to reconstruct anatomy and function. And if you want to deal with all those complex cases, you have at the same time to master the occipito-cervical techniques. See the current technique in that case, fixing between occipital bone and second cervical vertebrae. So my last slide to summarize, complications are of paramount importance in neurosurgery and skull base. Complications are very much related to reconstruction at the mid base, utmost difficulty in skull base tumors, of course, and we try to just to show all cases I have shown has been personal cases, and I think I try to show the evolution of reconstruction that is very much linked to the evolution of the techniques for tumor removal. You have seen more or less our perspective, and I like to give this small but final remark regarding the importance of the open skull-based techniques, still very useful in neurosurgery. Thank you very much, my dear friend, and I wish you all a very nice Saturday and very nice weekend.
Thank you, Miguel, for this nice overview of the different techniques and very nice cases. I think we will continue with the last two speakers and then we discuss.
Yes.
Suresh, please.
Yes, yes. Thank you, Henry. I think we are over almost 1 hour late, almost. So we have another two speakers. Now I think our Sandeep Chatterjee is ready with his presentation. Professor Sandeep, is he ready?
Yes, I'm sorry. Can you see my screen now?
Yeah, we can hear you and you can see the slides also.
Very good.
Yeah.
My apologies. I'm actually out of the city, and that's why the connection was bad. But I'm just going to present our little experience with reconstruction of the pediatric spine, and I'm going to limit myself only to the cervical spine and the craniovertebral junction because this is where the real challenge lies. Here's a 12-year-old boy that we operated on 25 years ago, who came with tuberculosis of the cervical spine, where 4 vertebral bodies were completely eroded. We ended up doing a decompression, fixing with a fibula graft, and then fixing him with the only available material that we had at our disposal 25 years ago. He did very well, and a year later, he was still moving his neck and living happily ever after. But I show this to tell you a lot has changed, but what has not changed in the pediatric spine is that there are 3 basic problems. One is the problem of access. The other is the problem of the bone being soft, part of it being cartilaginous. And of course, the third is the problem of a growing skeleton. The biggest problem of access lies in the cervicodorsal junction. Here is a child who had an injury which was neglected and came to us with a delayed spastic paraparesis. You can see what's happened to the bone on the X-ray itself. There's a topple, there's a posterior retropulsion. That's what the MRI looks like. And of course, how do you get to the cervicodorsal junction? Clearly, you have to get at it from the front. And these are the options in an adult: a sternotomy, menubriectomy, a transaxillary approach, or a sternoclavicular disarticulation. None of these are suitable in a child. And in a child, when we want to reach this region, this is what we do. We go in from the left side and do what we have described as a U-shaped menubriotomy, which means that we effectively take out a piece of menubrium U-shaped using a craniotome. And that gives you access and visibility down up to the 4th dorsal vertebra. And you can then go in and fix them from the front. And then, of course, this has to be supplemented with a posterior fixation. And that's what that child looked like thereafter. So here's another little boy I'll never forget, because this is the only child with this condition that I've seen. He's 3 years old, and he came to us with the history that ever since every time he tried to pick up a ball from the floor, he would lose power on one side and come crashing to the floor. Of course, he had a spastic paraparesis when he came to us, a tilt like that. This was his CT and MRI, and he had a very strange condition, which I've never seen again. And this is an os odontoideum, but one of this hemios is floating. So every time he bent forwards, this hemios would go and hit his brain stem. And of course, with a small mouth like this, we couldn't do a transoral surgery. It wasn't fit for endoscopy. So the only way we could operate on this floating right hemios was to do a transmandibular transpharyngeal approach, which we've just seen eloquently described earlier today. And not so easy in a small child. We exposed the anterior arch of C1, removed the hemios, and that was his post-operative image. And he did very well, in fact, after the surgery. The other problem, of course, is that the problem of soft bone. Here's a 6-year-old girl with neck pain who has what we thought was an aneurysmal bone cyst. And we decided to go in and take it out. Now, the problem with the pediatric spine, again, this is a transoral approach. We're drilling off the anterior arch of C1. The problem didn't lie there. The problem didn't lie in the access. The problem was that after we drilled off the anterior arch of C1, we were able to get to C2, and then we're drilling off the body of C2 to get to the tumor. There was no other way we could get to this because this was in the body of C2. And we knew that we would have to do a posterior fixation. The problem was that once we got to the tumor, this is a 22-year-old video, so I apologize for a little problem of quality, but it just to emphasize a very, very important point, and that is once we got in to the tumor, it was an aneurysmal bone cyst, as you will see, very vascular, and the only thing you can do is to take the whole thing out. The problem was that once we took the whole tumor out, we saw there was a huge gap between the anterior arch of C1 on the top and the body of C3, and we had effectively removed the whole of the body of C2 and the odontoid process. And the question was how we reconstruct this, because in a child of this age, trying to leave that gap and doing just posterior fixation didn't sound logical when the child was going to grow. So I did something atrocious. That's the huge gap. So we took a little low-profile plate, took an iliac crest graft, connected that graft first to that plate, and then lowered it in through the transoral approach into that, and ended up with a picture like that, and of course reinforced the child from the back. As luck would have it, 6 months later, the child came and coughed up the plate. So the plate was rescued by a mother from the mouth, and that's what we ended up with. Fortunately, we decided just to keep the child immobilized, and fortunately, 5 years later, everything seemed to have healed, and there was no need of an anterior graft at all. Problems of soft bone can be terrible when you're operating on children of this age. This is an 11-month-old with an atlantoaxial subluxation, a lateral pro-atlas failure, an abnormal piece of bone. And of course, the only thing you can do in an 11-month-old baby like that is to design your own equipment. And this is a contoured rod, which we used to do an occipito-cervical fusion reinforced with graft. Again, where do you take the graft from? The only place we could take in this situation, and this is the only option you have at this age, to take a rib. And that's what he looked like a year and a half later. Coming down to a little bit of the subaxial cervical spine, a lot of our work resolves, like Professor Shashank Kale shared with you earlier, on syndromic children. Here is a girl who came to us with an X-ray like that, 3 vertebral bodies missing. Of course, they're not missing. A digital flexion extension X-ray and a CT scan that makes you wonder how this girl is moving around and where the space is for the cervical cord at all. And of course, there was also a craniovertebral anomaly. That's the MRI. And we thought, how the hell do we go about this? Of course, there's no missing bone. The problem in this is a syndromic problem where the bone is cartilaginous and therefore collapses. We decided to do this in 2 stages. This is in 2015. And we used neuromonitoring, of course. We went in from the front. We reconstructed as far as we could without having any problems with the monitoring. Woke the child up. The child did reasonably well. And the next morning, we took her back to theater and did the posterior fixation. Of course, I would do this as a 1-stage procedure now. That's the pre-op CT scan. That's the post-op CT scan, and you can see you can get a fair amount of correction. And that's the pre and post-op MRI again. And this child has done very well now, 7-8 years down the line, is an adult, and it has very minimal spastic periparesis. The problem with cervical spine reconstruction is particularly bad in children that have neurofibromatosis. One, here is a young boy, and you can see there's not loss of cervical lordosis, there's a cervical kyphosis here. And of course, the CT scan would not win a prize in a beauty contest. With these children, of course, we need to put them on traction. We do not keep them in traction in bed. We let them be on wheelchairs if they're paraparetic like this child, or even on a walking frame. And that's what the images look like. This is the maximum we could get with NF1. It's very difficult to get a complete correction. And when we lost the SSEPs, of course, we stopped trying to do further correction, and this is what we ended up with. The bigger problem occurs in children when you have to do revisional surgery. Here's a child that presented in a different part of the country, underwent a anterior decompression and fixation, then went to another unit where they found that the child was deteriorating. They thought there was still compression, did a revision, put in another cage and a plate. And this child came to us much later. This was the second surgery, came to us with a discharging sinus, spastic paraparesis. And this was the scan. And if you look at it, you can see that there are 4 vertebral bodies missing. There's clearly an infection that's going on. And in this situation, when you have to reconstruct, that's what it looked like. We had to take that horrible looking infected cage out, put in fibula from the front, and then fix from the back. And this sort of revisional surgery, of course, is much more difficult. And of course, this was tuberculosis and responded well to anti-tuberculous treatment. What are the problems then with children like this? There's a problem of abnormal anatomy, problems of abnormal bone, compounded with problems of a growing skeleton. This is the child. You can hardly see there's any cervical spine. There's proatlas failure. All the cervical sclerotomes are gathered together in that short space. The thoracic sclerotomes are right up there with almost an absent neck. How do you start? Where do you start and where do you finish? And of course, this is a very difficult sort of reconstruction that we did. And I end with this patient with a quadriparesis with a C1 hypocaudal bow aplasia, C1 anterior arch agenesis, free-floating occipital condyle. And of course, how do you try and fix them? We had to redesign the foramen magnum here, and then to try and reduce this, we would have done a Professor Goyle's described procedure, but of course there was no C1. So what we did was we put in a hook into the reconstructed foramen magnum, a pedicle screw into C2, and then distracted the two. And you can see this is very modified surgery, and then distracted the two to get a fixation. And this is what you ended up with a hook in that foramen magnum and a pedicle screw into C2. So to just sum up in the last 30 seconds, in cervical deformity, mainly kyphotic, you have to understand the anatomy. You have to decompress. You have to reduce, and you have to restore alignment as far as possible. And of course, for us, neuromonitoring is a very, very essential part of this. Thank you very much. And I apologize again to Professor Sinha for the problem with the connection before. Thank you very much for this opportunity.
Thank you, Sandeep. It was an excellent demonstration of very complex, formidable problems, more so in the children. Always they are the real challenges to face. Thank you very much. It was excellent demonstration and highly informative and educative. I think we are already 1 hour behind the schedule. I think we'll postpone the question and answer session. We'll go to the final talk of the day by Professor from Philippines, Professor Lynn Lunesia, and she is first board certified female neurosurgeon to practice in Bicol region of Philippines. She is a fellow and past secretary of the Academy of Filipino Neurosurgeons, and presently a board of director and chair of Philippines Board of Neurosurgical Examiners. Madam, welcome, and start your presentation.
Hello.
Start sharing your screen.
Hello. Hello. Thank you. And okay, I will share my screen. Can you see it already?
We can see you, but you can't see your screen.
Okay, wait, sorry. I will try to share it again. Okay, share screen. Okay, here. There.
Yeah. We can see your screen.
Okay.
We can hear
and
you.
then,
We can hear you. Please
yes.
go ahead.
Okay. So after all the very high level and intricate discussions on the techniques and different cases, now I will go back to the basic and addressing the scarcity of neurosurgeons in where I am practicing. So using the task sharing and shifting model. So a short CV. Thank you so much. Okay, in the World Federation of Neurosurgical Societies Global Neurosurgery Workforce Map, I think we are all very familiar with this. We see the density of neurosurgeons per 100,000 population. It's very much scarce in the areas of Africa. And there are 23,000 neurosurgeons needed in the low to middle income countries. And 5 million essential neurosurgical cases are treated each year. So there is a want of neurosurgeons in the sub-Saharan Africa and Southeast Asia. And in the Philippines, it's 0.108 per 100,000. And where I am practicing, it's 0.050 per 100,000. That's the ratio of neurosurgeons to the population. In 2017, the global burden of disease was recorded 195 million new cases of road injuries worldwide, mainly motor vehicle and motorcycle accidents. And here in the Philippines, it rose from 65,000 cases in 2005 to 110,000 cases in 2017, all occurring in Metro Manila alone, which is the capital city of the Philippines. So with a population of 109 million, we have 4.8 of 8.7 million vehicles are motorcycles. So as I said, there was a 45.76% increase from 2006 to 2015 in deaths from road crashes. So what happened now? In 2016, there's 1.2 million injuries with 10,000 deaths or more. And in 2019, we did a survey of the 10 training institutions in neurosurgery, in which there are 80 to 100 cases of traumatic brain injury per month. And the mortality in severe traumatic brain injury is 80 to 90%. And disability would include even post-concussive syndrome in mild TBI in 20 to 30%. So this is the geographic distribution of the fellows in 2018. As you can see, the region 5, that's me. I'm serving around 5.796 million people. So in the Philippines, there are only 145 fellows or neurosurgeons which are board accredited, and there are only 10 training institutions. So in Bicol region, where I am based, there are 5.8 million people, 1,200 cases of traumatic brain injury, 6% are surgical. And we have me as the permanent neurosurgeon here. There are some visiting neurosurgeons too. And with this scarcity, what did I do since the time that I came here? I was here from 1999. So I started doing all the neurosurgical procedures, but then I found out that I cannot half myself or put myself in different places at the same time. So what are the approaches that can be done? There can be short-term missions, there can be training camps or twinning, or there can be task shifting or task sharing, which is what I did here in the Bicol region. There's task shifting, task sharing. So the difference is that when you have task shifting, you delegate tasks to existing or new groups with less or narrowly tailored training. And the new task owner will have clinical autonomy over the patient care. Whereas in task sharing, the workplace strategies are built upon the collective input of the health team, and they share the responsibility and autonomy over the patient care with the more qualified individual maintaining the responsibility. So theoretically, there should be a structured training curriculum with an oversight from the consultant, and a competence-based evaluation, which can be objective or subjective. And this should be integrated into the workforce or the team. There should be an appropriate referral network and the defined scope of practice to prevent task creep. And there should be maintenance of certification. There should be financial compensation or salary and recognition by the health system and professional development. In the Philippines, this is the model. We have a general surgery residents doing 3 months rotation at the very least, or 6 months right now, because there's scarcity also of surgeons. And they go to all neurosurgical cases, consulting with neurosurgeons on the phone and also on Viber and internet. There's progression of autonomy, and the focus is the medical and surgical management for trauma. There's supposed to be regular feedback on rounds and conferences, and there's competency-based approval. Okay, so this is me doing surgery and demonstrating to my residents. And also later on, I will assist them, and later on, I will have them do it by themselves with me still supervising. So the study design was that we did a retrospective logbook review from the 2015 to 2018, which included all patients with traumatic brain injury or elevated intracranial pressure. So we did all this information, and we did Chi test with multivariable regression analysis. Primary outcome was mortality, with the secondary outcomes infection, length of stay, and admission score changes from admission, GCS, to discharge. So there were 3,241 cases, 2,233 at the government hospital and 1,008 at the private hospital. The surgery was for 214 admissions, which is actually comparable to high-income country rates at 6.6%. So the neurosurgeons, meaning the had private patients, older patients, and the mechanism of injury was secondary to fall. The scan was done the same day, and if the mechanical ventilator was needed, it was given. Whereas the task sharers, meaning the general surgery residents, had public patients or government patients, and road traffic accidents were the main cause, and they were not really given ICU or were maintained on ambu bagging when the need arises. So multivariable regression was done. And what remained significant, the year, mechanism of injury, and traumatic brain injury severity. The results were here. Neurosurgeons and task sharers were comparable with the mortality, and even the other scores like length of stay in the hospital were all comparable. In conclusion, this retrospective cohort study is one of the first to thoroughly examine the quality of task sharing and task shifting care provision in neurosurgery. And it demonstrated that emergency neurosurgical care can be delivered safely using a carefully designed task sharing and shifting model. What are the future directions? More data needs collected where task sharing and shifting is being practiced. And this is where what I am doing now, collecting more data within the whole of Philippines. And maybe later on, a collaboration with other countries that does this kind of model. And there should be more formal approaches to the task sharing and shifting. So I would like to acknowledge my co-researchers. Professor Key Park was also there. And these are the publications for this research. And also I would like to acknowledge Dr. Faith Robertson, the primary author, and with Dr. Michael Lawton, who visited us. I would like to thank everyone for your attention.
Thank you, madam. It was an excellent presentation and giving us the demography of the neurosurgeons and what's the scarcity and type of work you are doing. We really congratulate you and thank you for bringing it out. It was really nice.
Thank you so much.
Thank
I
you.
apologize for not making it yesterday. Sorry.
No, it's okay. It's we're all professionals. We understand that.
Yeah, I was in surgery.
Work is always important, right? I think Professor Henry agrees with me. Already we are 1 hour late, and I think we will postpone or cancel the question answer sessions, Professor Henry.
Yes, I think if there are questions, we ask the speakers to answer them in the chat,
Yes.
or to via email.
Yes, that's
we are,
right.
unfortunately, we are running too late. Sorry for that.
Yes.
We are very bad chairmen. We agree that. But there were
No,
so
no,
many nice discussions.
Exactly. Senior faculty, a lot of senior faculty. So, you know, and a lot of participants, almost more than 150 participants. So, you know, let us enjoy their lifetime work and learn from them. So I know we are bad chairman, but I think people got benefits from us, isn't it?
Exactly. So we want to thank all the speakers, the participants for joining this as a morning session for the webinar. We thank Dr. Sina again for taking the effort to organize this nice event. And we give now over. I want to thank my co-chairman, of course, Dr. Dugani.
Thank you.
Doing the work with me, and we want to give it now to the next session, rehabilitation and neurosurgery. So thank you everybody for participating, and we wish you also a nice evening after this meeting. Thank you. Bye-bye.
Bye, Henry. Bye, all of you. Thank you. Go ahead with the next session.
So thank you. I would like to thank and congratulate all the speakers for such a fantastic talk. And my special thanks to the moderators for conducting the session seamlessly. With this, we move on to our next session. Dr. Gaurav Jain, who is Assistant Professor at SMS Medical College, Jaipur. He would be coordinating the session. So may I request Dr. Gaurav to take over.
A very good evening to all from India. And it's been a very good day being with you all and hearing lectures from very top neurosurgeons of the world. Now we have started the journey from the neurotrauma, the neurocritical care, and went to the neuro reconstruction. And now the most important part is the neurorehabilitation. So today we bring you the session of neurorehabilitation, and I take pride to introduce the moderators. We have with us Professor Andras Rubiano, who is Professor of Neurosurgery and Neurosciences at University El Bosque, Bogota in Colombia. He's also the chair of the Neurological Surgery at Cali, Colombia, and is serving as president of the Colombian Association of Neurosurgery. We have also with us Sir Professor Muhammad Tariq Khan from Pakistan. He's the chairman of Alliance Health Care, as well as the Dean of Neurosurgery in the College of Physicians and Surgeons of Pakistan, as well as the Northwest School of Medicine in Peshawar. He is also the chairman of Neurotrauma Committee and faculty in WFNS. A very warm welcome to both of you and a sincere request to kindly uphold the virtual dais. Now, moving on with the session, we have a keynote from a very important and an eminent neurosurgeon. Let me introduce him to you, Professor Xiao Won Tu from Singapore. He's Senior Consultant Neurosurgeon at the National Neuroscience Institute of Singapore and the KK Women's and Children Hospital, Singapore. He's also the Associate Clinical Professor at Duke NUS Medical School and serves as the President, Asian Australasian Society of Neurological Surgeons. This post he's holding itself is self-explanatory for his stature. Sir, please accept a warm welcome, and we are here to listen to your experience. Over to you, Professor Shaw.
Thank you, Dr. Jain. I really want to thank the organizers for letting me say something in this keynote. Can I share my screen, please?
Yes, sir. Please share your screen, sir.
Okay. So I'm just going to take a few minutes to talk about rehabilitation in neurosurgery. And I actually, as a part of the keynote for this meeting, I'm a pediatric neurosurgeon, and really my congratulations to Professor Sinha, Professor Visochi, and Dr. Chakrabarti for really organizing this great meeting. And so just some words about rehabilitation in children. I think basically when you look at yesterday, we've actually looked at the, looking at neurotrauma, and of course today we're looking at reconstruction. So now we come to rehabilitation. So I think most important, I think all of us know, children are not little adults. Nervous system at the time of injury are still not fully mature, as you heard from Dr. Sandeep even, on the spine. And they're still in the process of developing, acquiring new skills. And then following injury, children must not only meet the challenges of recovery, but the ongoing challenges of development and maturation. So the impact of TBI on the child's ability to achieve developmental milestones is really a critical factor in determining long-term outcome. And most of us, we've been trained, we assume that children progress a greater capacity for neuro reorganization after injury because of neuroplasticity. And yet it's true, but we tend to think that therefore the younger the child, the better outcome. Well, that's not true, right? Because there's increasing evidence that children may be more vulnerable to the adverse consequences of TBI in adults. Obviously, for a certain degree, if a kid and a adult would get the same trauma, right? The child may actually die from the trauma while the adult survives. On the other hand, if the child survives, maybe he might do a little bit better than the adult. And apart from severe injury severity, of course, the pre and comorbid factors, age, and developmental stage at injury have great influences of subsequent recovery. And as we know, greater mortality and disability are noted in the very young compared to the older children. And also functional recovery has been observed to be related to this. If we look at the list that I show, the wide spectrum of neuropsychological deficits that actually children with severe TBI have, and that's because of the fact that they're still developing. So you see arousal, alertness, orientation, attention, intellectual functioning. Sure, you see these things in adults as well, but because in children, many of them have not really been well developed, they actually end up with worse problems, right? And even if they physically recover, they may not actually recover from this type of injuries. So because of that, children who survive, the quality of lives are going to affect them. It's not only just them, but also the family who we have to look after them as well. Maybe a little bit different in adults compared to children, but nevertheless still there. And therefore, it's very important to make sure that there's interdisciplinary approach to the rehabilitation. And so you see a whole list of specialists that you need: the rehabilitation physician, the pediatrician, of course, a therapist, occupational physio, speech psychologist, rehabilitation, social worker. All right, so you need individually tailored training to allow children to re-experience life and face life's challenges again. And so definitely, as even in adults, the greatest benefit is seen in patients who receive rehabilitation early after onset of injury, right? And therefore, the hospitalization itself, because they also need to go to school, education and training is also needed for the children and the family to understand and manage and prepare for discharge, right? And of course, you need tailored goals directed towards the sufficient return of injured children to full function. In many of these cases, you need also a point of contact, because not just the hospital, the therapists, but the schools as well. And of course, the positive partnerships with professionals will actually help this type of recovery, right? But I think one of the things, and yesterday when Professor Keepak talked about the unmet needs for neurosurgery, neurosurgeons in all these other developing countries, we actually look at the rehabilitation needs is even worse, right? When you can say that you need neurosurgery, you need neurosurgeons, but many times you also need rehabilitation, right? And that's usually not available, right? So it's in many parts of the world, and especially for children. Right? So in many hospitals, in the countries, there are actually no pediatric hospitals or no pediatric rehabilitation hospitals or no pediatric outpatient facilities catering to children, right? So there is therefore an emergent priority for improvement and the need for strong imperative to strengthen and meet children's needs, because their needs are not being met. And so when we talk about the need for more neurosurgeons to help in trauma, there's also an even greater need. And I think the two of them go hand in hand. So thank you very much and have a great learning experience.
Very thank you, sir, for your wise words, and especially in pediatric neurosurgery. I think experience is needed much more than the skills, as children are our future. And you are right that we need a good rehabilitation for them. I now request both the moderators, Professor Rubiano and Professor Tariq, sir, to kindly take over and please allow the session to start. Sir, please.
Thank you, Dr. Jain. Thank you, Professor, for talking on this very important topic. I think this session is one of the most important sessions because you can do excellent management in brain injuries or surgeries on vascular or brain tumors. But if you have no rehabilitation, you end up in a lot of problems. So obviously this is a very important session. So I'd like to invite our first speaker, Professor Max Maiden, former professor and chairman, Department of Neurosurgery, Keele University, and chairman WFNR, chairman Ethics Committee, Medical Faculty, Keele University, and past chairman of WFNS Neurorehabilitation, Reconstructive Neurosurgery, and a good friend of mine. And he's going to talk on ethical implications of reconstructive neurosurgery and neurorehabilitation. Professor Maiden, Max. We can't hear you. Is Professor Maiden muted?
Oh. Can you see my picture, my screen?
Yes, thank you.
Okay, so probably will come. So we had heard excellent talks about neurosurgery and we heard excellent talks and we need neurorehabilitation, and because we are in a wild world, in a big world, I would show this picture from a Peshawar meeting, which you had so perfectly organized some time ago, 2 years ago. Ethics in neurosurgery and neurorehabilitation, primum nihil nocere, has been mentioned yesterday also by our world president, Professor Salvador. General considerations, special aspects, and conclusions should be discussed. Beneficency and no maleficency, that's the other ethical principle. So you should do good and provide benefit concerning autonomy, self-determination of the patients, and justice, veracity, and confidentiality should be considered also when you look at these patients. So we know, or we think, that all men are created. Are they really created equally? And we have seen these differences, like from these beautiful surgeries from India. We have seen examples from the Philippines. Everyone is working very hard to improve on neurosurgical patient care, but we also have to implement more adequate rehabilitation in low and middle income countries. We know these figures, which have been shown yesterday by Key Park and has been also shown in the previous talks, and a similar situation occurs for neurosurgeons. So I think neurosurgeons do have to take care of neurorehabilitation as well. That's a slide from Tariq Khan, which I borrowed yesterday. So here at the end, neurorehabilitation starts, and we have to try to integrate every neurorehabilitation into the setting of acute neurosurgery.
Your slides are not moving, Max.
I don't know. What can you see? I see the changes.
We just see the first slide.
Oh, that's awful. Sorry. I don't know what happens here. So
I think you can reload it, sir. You can restart your slides, sir.
So I start. Can you see them now? You see this one? Do you see the second slide?
Oh.
Can you see the second slide?
No, we cannot.
Oh, it's awful.
Maybe you want to
so stop the sharing and you can reshare.
Yeah, I'll just wait a second.
Yeah, it's moved now.
Okay, now I give. Can you see these ethical principles?
Yes.
Okay, now I start again with the whole screen. Can you see now?
Yeah, the second slide, the ethical principles.
Ethical principles. Okay, so you can read them yourselves, and you see the third a slide? All men are created equal?
No.
It's a pity. So I don't know what I do.
Sir, you go to the presenter view, sir. That's
yeah,
the
okay,
full screen
okay.
for your
It's moved
slides.
again. It's moved again.
I don't know what's happening.
You have two versions of the slides on.
What
You
do I
have
have?
two copies
In
of
the
your
background
slides.
also.
You're okay. You have the third slide. All men are created equal.
Can you see the world here?
Yes, we do.
Okay, so it's good. So we have to implement more adequate rehabilitation also in the low and middle income countries, as we have seen from previous speakers. I'll leave it like this, maybe. That's better. So we have now seen this slide yesterday in Dr. Khan's presentation that rehabilitation comes at the end of the journey of a patient, but we have to really try to get everything together. Can you see the balance now?
Yes, we do.
Okay, perfect. So acute medicine, acute neurosurgery concerns with the chances of survival already on the quality of survival, but this needs to be balanced again. The quality of rehabilitation medicine concerns the quality of survival in these patients. So the World Health Organization has made the international classification of function of impairment and health, which is slightly different from the classification of diseases and health impairment. It classifies the individual level of retained health or functionality concerning the activities of daily living. A person is considered healthy if his or her bodily and psychological functions and structures correspond to general norms. So the goals of neurorehabilitation are to provide the patient with the independence, to have a good self-esteem of himself, and to be able to participate in social life and to be efficient. So
I'm sorry,
now,
sorry, Maximilian. Can you put in presentation modality?
yeah, now I go to presentation because otherwise it would not work. Can you see it now? Levels of neurorehabilitation.
We see all the slides on the left side.
Okay, can you see this one? I don't know what's happening here. And
yeah, we can see the slide, but what we would like you to do is to go into the presenter mode.
yeah, that's what I am in.
No, it's not.
Again. I'll try again from the other one. Sorry for the confusion, but this should do.
Yeah, okay, maybe carry on.
I adjust quick. It doesn't matter so much. So the highest level of neurorehabilitation certainly is a prevention, and everyone knows this. If you see these pictures, it's awful. That's nothing for neurorehabilitation. So efficiency of neurorehabilitation has been studied some time ago concerning effects of timing and intensity of neurorehabilitation on the functional outcome after traumatic brain injury in a study from the Netherlands, and they found out they discussed both the timing and the intensity of the neurorehabilitation program in a couple of studies, meta-analysis of these studies, and the results. I don't want to go in detail. They conclude that the available evidence indicates that early onset neurorehabilitation in a trauma center and neurointensive neurorehabilitation, the rehabilitation facility, promotes functional recovery of patients with moderate to severe TBI compared with usual care. So it is important to start as early as possible in the early neurorehabilitation as part of the intensive care. Neurorehabilitation should start immediately after the injury in the ICU, and then neurosurgeons send patients to the neurorehabilitation unit. And so the question is, where should the neurorehabilitation units be located, hospital-based or outpatient neurorehabilitation, or both?
Max, your slides are not moving again.
It's a bit shame.
It's still on that, yeah. Okay.
I just continue and without the slides, and so I have some pictures here of basal stimulation. I don't know why it doesn't work. So evaluation for, can you see evaluation of interventions?
Professor Max, you have two copies of PowerPoint running. So you should switch off one and then you should be able to play the other one.
I don't know why this happens.
It's okay now.
So maybe I just say like this.
So you can come to the presenter view now.
No, if I go this one, it continues. You see, I have this presentation mode. So I don't know.
Okay.
I stay with this one. It's a pity, but doesn't matter. So we have to evaluate everything which is studied about the interventions, which are, and like minimal invasive studies. There has been a study on prospective memory rehabilitation using smartphones, which might be interesting for low and middle income countries. So it shows that smartphone users have fewer memory problems at the end, but there is insignificant improvement and no real changes in quality of life. So the opposite is effect of regular electroacupuncture, which has been tried with improving consciousness of patients after traumatic brain injury. And there is a suggestion for a study protocol, but no results are coming out, and we're looking forward. So we have to be very honest what is coming out. We can evaluate the interventions like to study neuroplasticity and
Sir,
when I don't know. So when we have research, the bench is closer to the bedside than we think, and we have to try to find out the ethical ties between preclinical research in translational neuroscience and in patients of clinical studies. When we can launch, we as ethics committee, a research ethics committee, which I'm still the chairman of, we can only launch new clinical trials ethically when new approaches show sufficient scientific promise. So they need to be really well presented and intelligently presented. And what if such studies do not show such basic use? They don't use design elements as blinding or randomization. So a study needs to be performed and present and is planned in a very good way. The regulatory agencies sanctions human exposure. What if agencies don't have access to all the relevant data? And that's always a problem when we discuss with the proposers how they would like to have their study. Do we really have access to all the data they rely on? Because no nonsense studies which have a certain risk to the patient don't do any good to the patient either. So that's an interesting presentation some months ago. From the bench to the bedside, improving locomotor function in mice. They are paraplegic mice, and they have a stimulation system implanted, and this stimulation system then afterwards go also to the patient, and first steps can be done with such a system. So that's one of the good examples by the Lausanne group from Bloch and others, the Lausanne, Switzerland group, improving patient care, getting them back on their own feet in a very tedious way. So when we look at the global perspective, who decides for which kind of therapy, based on which guidelines? It's certainly country dependent, and we have a variety of ethical problems. One of the major problems certainly is the allocation of resources and the study of the long-term results, which is very important. We can do better if we select our patients very, very carefully. Like if we evaluate patients who would benefit from targeted agents or neurorehabilitation, do we need magnetic resonance stimulation for diffuse studies for diffuse axonal injury in minimal or severe traumatic brain injury population? Is this ethical to do this? Can we exclude many patients? So we need very careful studies to discuss this. That's a slide from my good friend who unfortunately deceased, Potapov, and they studied here the fibers in the brain. You see this big damage, so you would expect also to the corpus callosum, you would expect there is a severe damage to the brain, and you can say, well, we don't do anything with this patient anymore, but you can still continue doing this. Neuroimaging in disorders of consciousness to find out which patients would benefit from what kind of additional procedure. That's certainly for selected groups of patients that needs to be presented very carefully, and we as clinicians have to draw our own conclusions on this afterwards, whether it's really helpful for these patients. What is efficient? How efficient are we? Can do all the devices which are offered, for example, through the internet, are they all very efficient and colleagues from Lima. They performed a overview of the literature of the available systems, including telerehabilitation devices, electrical stimulation devices, and they found that about only 1/3 of these devices had undergone a randomized controlled study to prove efficacy for rehabilitation purposes. So we as neurosurgeons also have to be very careful what we offer to, what we suggest to our patients to get these devices or not, because they may be quite expensive. Concerning cost effectiveness, I like to present such a young man who was 18 years old, 17 years old. After cuddling with some friends, playing with some friends, he got tetraplegic because of ischemia of the cervical cord. And that's after having done everything of neurorehabilitation, so he's tetraplegic, he's still tetraplegic. He is in a wheelchair, ventilated, and he's only able to drive around with his mouthpiece. So that's a situation we, in some instances, can offer it to patients, but it's certainly a question of the economic situation in the different countries. So ethical or ethnical variations may also exist. That's a study from the Netherlands, where they, together with Chinese researchers, where they tried to find out the differences after mild brain injury in Dutch and Chinese patients. And you see there are differences in the different profiles of the SF-36 scores concerning mental health and the role of physical, bodily pain, general health situations. So there are differences which need to be considered as well. You cannot rely on all European or American studies to show benefit for certain issues in your own area. Robotic systems, as long as a patient or the doctor can control these systems, the virtual reality, or as long as he only has his exoskeleton to support him to work, to be able to walk, that's certainly helpful. But as soon as you get into the deeper problems like brain-machine interface, you come into the problem of ethics, of influencing the consciousness, influencing the neural workspace, which is a very delicate situation, as we all know. That's concerning deep brain stimulation, cortical implants, and other things as well. So this concerns deep brain stimulation, one of my favorite techniques, which I applied very frequently in patients. DBS could become an effective treatment for special post-traumatic movement disorders if medical treatment fails, like Holmes-Tretter. It's a standard indication. Holmes-Tremor, it's a standard indication. But then we come to the problem of vegetative status or minimal conscious diseases. And there have been a couple of studies where this may be helpful, and we have to advance very, very slowly to be really on an ethical level. So we need this patient-centered approach for the basics of neurorehabilitation. We need a dedicated personnel. We need trained and enthusiastic personnel. It needs to be supervised, and the results need to be audited. I discussed already earlier on where such a neurorehabilitation location should be located. And I think it's very good if they're as close as possibly to the acute neurosurgical unit or neurological unit, and not in separate places as in some areas. And it always comes back to the money. Who should pay for this? We have seen beautiful surgeries from India. We have seen beautiful surgeries from around the world, from Spain and everywhere. Who should pay for the neurorehabilitation? Should it become all-inclusive from acute injury, from acute therapy till discharge after neurorehabilitation? Or should each single step be built separately? That's a certain very difficult issue to talk. And I've seen many instances where all the money goes to the acute surgery, and afterwards the family doesn't have any more money for the rehabilitation. So the patient is left at a certain point, which is very, very awkward, I would think. We have to discuss for our own. So the future is up to us, whether we have a bright future or whether we have a stormy future ahead of us. I think we as neurosurgeons need to take care of neurorehabilitation as well. And with this, I would like to finish and would like to thank the organizers, congratulate them for this excellent meeting, and would like to thank them that they allowed me to share some of my slides with you. Thank you very much. That's it.
Thank you to Professor Maximilian for this great talk. I think there are some topics that have been really important, and taking in consideration that the Rehabilitation Committee of the World Federation have been very active under Professor Sinha. I think it's really important that we all, as neurosurgeons and people who work in the neurotrauma field, we need to be very aware of all these ethical implications, because we live with these situations every day, with all the peer review and non-peer review publications that are showing up with different options. But definitely we need to take into consideration which ones works and which one not. And this will be very important in the near future. So continue with the program. We want to do the introduction for Professor Russell Andrews. Is Professor Andrews here?
Yes, we're here.
Okay, Professor. So great to see you and hear you here. So we are going to move to the next conference that is called Nanotechniques for Neuro Repair. So Professor Andrews is really well known for us. He has been very active, and the idea is that we can go over this very important talk. So Professor Russell Andrews.
Okay.
Your screen. I think you are not in the full screen mode. Yeah, now you're in the full screen.
Now?
So Professor
And you
Russell
can hear me?
Andrews. Yeah, we can hear you.
Okay. Just a second. Well, thanks to the organizers and also to the moderators, and welcome from California. Great. Okay. When we talk about the nano realm, let's get our size down. In the upper right, you see a 1 meter tall child is roughly 4 years old. We go to red blood cells are about 10 microns, and then we get down to the level of the molecules and atoms, which is really in the nano realm. But most importantly is we're dealing with assembling molecule by molecule rather than cutting things smaller, as we're used to as surgeons. Two big ideas that I'd like to get across that where nano really intersects with neuro repair is nano scaffolds and nano techniques to maximize the benefit of neuroinflammation or minimize the detriment. And we're all familiar with the problems of damage to the spinal cord and the brain, for that matter, cysts formation, gliosis, myelin degradation. And so we'd like to find some biomaterial solutions for these problems. And I'll talk today about the nanoscaffolds and the multifunctional nanoparticles. Surface patterning is really not that relevant to this matter. Here's an example of a rodent model of intracerebral hemorrhage, and using a self-assembling peptide. This RADF16 is one of the most common of these. They're actually a clear liquid. They're peptides that assemble. This happens to be arginine, alanine, aspartate, and alanine repetitive pattern. And as you can see here, they caused a hematoma. There's the sham operation, and then the various treatment modalities, a saline injection, no injection, or the nanoscaffold. And on the left, you can see the histology, but let's concentrate on the right. You can see the effect of the various treatments on the number of neutrophils that infiltrate acutely, but more importantly, the self-assembling peptides really reduce the macrophage and microglial infiltration acutely. And as you can see, apoptosis is greatly reduced as well. And what the bottom line is, you can see this modified limb placement test is there's significant improvement in the animals that were injected with the self-assembling peptide. Using the same treatment modality, this is a rather interesting experiment again in rodents. A knife cut in the superior collicula is basically blinding these animals. And if you focus on E and F in the center, that's 1 month out. The E is a saline control, and the F is the one who's had this self-assembling peptide injected.
and 3/4 of these animals recovered functional vision. It's really quite an amazing result. This is a similar study using manganese enhanced MRI to follow the fiber tracks. And if we look here at the MRI scans, the bottom 3 panels are blow-ups of the top. In D, you see prior to lesioning, the optic tract and the superior colliculus. Then you see the lesion and the accumulation of the manganese in the optic tract at the point of lesioning. And then the bridging once they've been treated with this self-assembling peptide. This also, the same peptide can be of benefit for peripheral nerve repair. This is a 1 centimeter gap, and you can see in C the fibers that are regenerating the axons with the peptide, and D is a control. And again, you can quantify this, the significant improvement in the number of axons that regenerate. So we've talked a bit about biomaterials in the bottom left, but we can also look at optimizing the growth factors and other moieties for recovery. And stem cells are really part of this, how we can optimize their benefit. And on the right-hand side, the whole conference has been, or this session is really dealing with that, the rehabilitation aspect. After injury, you see this sort of two-phased reaction, the acute macrophages and cytokines that infiltrate, and then the chronic ones up to a couple of months out. And in the macrophages is really the M1 are good guy or bad guys that come in early, and the M2 are good guys that come in later. If you want to look at what we might call the bad guys, they really peak about a week out, as you see in the graph on the upper right, but they still hang around for up to 2 months. But there's also this anti-inflammatory effect of many of the macrophages and microglia that occur later. If you look at the upper left, you can see these pro-inflammatory macrophages mostly come from the spleen, peak at about a week, and then the anti-inflammatory, which are largely bone-derived or locally recruited macrophages, appear later on, a month or so out. And so there really is this long recovery period that we've all alluded to. This is a very interesting study using nanoparticles to attach to the immune cells to enhance recovery. And let's look at the bottom first with the illustrations. As I mentioned, the quote unquote bad macrophages tend to come from the spleen, and these nanoparticles will help have the spleen reuptake these nanoparticles. The macrophages that are attached to the nanoparticles. And if you cause an injury, obviously some of these are going to go to the spinal cord. And that's quantified in the graph and the bar graph in the upper left. But most importantly, if you look at this Basso mouse scale, which is a measure of hind limb motor function, it's significantly improved again when you inject these nanoparticles that attach to the macrophages and really redirect them to be taken up by the spleen again. Turning now to the clinical situation, most of the spinal cord injury trials with stem cells have been done in China and India, with smaller studies in the US and Europe and a few other countries. Interestingly, only about a third have been given significant rehabilitation. And this may be why, and certainly in the Chinese trials, there's been modest benefit. It's very likely due largely to the very intensive rehabilitation in most of their programs. And you can see in the upper left that about a third of the time the injection is intramedullary, a third of the time intrathecal. And in the bottom left, you see the follow-up has usually been limited to about 2 years, which may not be optimal. There's lots of different types of stem cells we can use, the mesenchymal, embryonic, swan cells, etc. And unfortunately, you see there's been a plateau in the last few years of the use of stem cells for spinal cord injury. It's probably because of the very modest benefit we've seen to date. And I think nanotechniques will help optimize the benefit from stem cells. If you look at mesenchymal stem cells, most of them are derived from bone marrow. They're clinically used. And you can see the cells that can be generated in the bottom. We're obviously most interested in the neural cells.
mesenchymal stem cell transplantation. I won't read through all these benefits that can accrue from stem cell and spinal cord injury. Whoops, sorry. If I can go back. You can also look at this anatomically, the benefit of the stem cells, rostral to the injury, at the injury site, and caudal to the injury. And just taking one example here of these chemotactic cytokines that stem cells are associated with. And you can see in the upper right, that's the salt solution control. And then the mesenchymal stem cells, there's enhancement of the regeneration and reduction in the scar formation. In the bottom right, you see, obviously there's no injection of the stem cells in the upper, the salt solution, but they do migrate to the injury site. And you can see that the stem cells do cause some benefit in the skin Basso-Mouse scale and functional recovery. One of the important aspects when we get down to the nano level is exosomes, which are these lipid bilayer spheroid structures that allow cells to really communicate one to the other. They can get exocytosed and then they get endocytosed in an adjacent cell, and they can be used to carry proteins, nucleic acids, and enzymes for diagnosis and treatment. And they really have become quite widespread in their use. You can see here from cardiac repair, skin healing, tumor treatment, autoimmunity, TBI, even disc disease, and COVID. And this is just one example of the benefit of combining techniques. These are, we know from mesenchymal stem cells that they can form nanovesicles that contain most of the moieties that are of benefit for recovery. But one of the problems is getting them to go to the right place, as we've seen. But if you can infuse or fuse the membrane from the macrophages to the nanovesicles, then you can help direct the beneficial moieties to the area of injury. And this is what we're seeing here. At the upper left, you see the non-injured spinal cord in rodent model. Next to it is the injured with no treatment. Below that is injecting just the nanovesicles of stem cell nanovesicles. And then if you incorporate those with this macrophage membrane together with the nanovesicle, you see significant improvement. And you can see it illustrated in the bottom. By far the right is the most significant recovery. And again, the Basso-Mouse scale shows they get the most significant clinical improvement as well. So this is, I think, a rather exciting area. Finish up, we're all still in the COVID pandemic. Here's the virus and the spike proteins we're all familiar with. And the technique for infection, you can see the virus is endocytosed, it replicates, and then is exocytosed. And the vaccines, we're familiar with really two major types, the mRNA of Moderna and Pfizer-BioNTech, and also then the attenuated live virus vaccines of Johnson & Johnson and AstraZeneca. But the problem is with the Moderna and Pfizer was getting the mRNA into the cells, not getting degraded. And so they've been encased in a lipid nanoparticle. And you can see if in the upper left there, they're encased so they don't get degraded. The mRNA is then released intracellularly and disrupts the replication process of the virus. And so it seems to be quite effective, I think much more than we anticipated. And if you again look at the upper left, there's a schematic of the mRNA within this lipid nanoparticle. And in the bottom right, you see lipid 5 is the lipid that's used by the Moderna vaccine. The Pfizer one is quite similar, another type of lipid. So I'll just conclude by summarizing the two real take-home messages. One, there's these nanoscaffolds that can really guide axonal regeneration in particular. They're also quite effective hemostatic agents as well. And so there's going to be neurosurgical uses for that. The nanoparticles, many beneficial responses and reduced detrimental responses, but perhaps one major application is going to be improving the stem cell efficiency. And with that, I will conclude. Just want to, our group at NASA Ames is not really doing work in this field so much, but Jessica Caney is a very dynamic young researcher who's been there for a number of years now.
And I just showed, since we're talking in India, Krishnan Ganapathy, who many of you know from Chennai, came and visited a few years ago, and we're glad to have him visit. And with that, I want to again thank the organizers and the moderators, and look forward to meeting everybody in person quite soon. Thank you.
Thank you, Professor Ross, for this great talk. You have been very successful with all these analysis of the new technologies that are available for repair, all this interaction between the live tissue and the neuroproteomic work that is generating all these new trends in science. So I will let to my colleague Tariq to introduce the next speaker, Professor Rajoshi from India.
Thank you. So our next speaker is Dr. Joshi from India's Director Rehabilitation Research Center, SMS Hospital, Jaipur, and Senior Professor, Department of PMR, SMS Medical College and Hospital, Jaipur, and also member governing board foundation by Special Children. And he's going to talk on chemoneurolysis, a lost art. Dr. Joshi.
I thank the WFNS committee for inviting me to this wonderful webinar. I will share today how we deal with refractory spasticity issues in a low-cost, effective manner. Without getting into details of spasticity, definition, assessment, or pathophysiology, I will draw your attention to focal spasticity, where we have three options: botulinum toxin for chemodenervation, alcohol or phenol for chemoneurolysis, or surgical intervention. We use phenol as a chemoneurolytic agent in our setup. Phenol was first used by Sir Joseph Lister as an antiseptic agent, and later in 1964, Khalili and his colleagues popularized it as a peripheral nerve neurolytic agent to reduce spasticity. Botulinum toxin has become popular and a primary treatment of choice because ease of use, inclusion in Medicare, and funding from private groups for studies and seminars. There is explosion of articles, whereas phenol has remained an orphan child with no external support, while demanding better skills. It is comparable in many ways, and no doubt, it is cost-effective. A single treatment session of phenol will cost you $20, whereas botulinum toxin will cost $500. Nerve blocks are very popular as a process of applying a chemical agent to interfere with nerve conduction, and we see it frequently in pain management. We can also use it as a diagnostic block for evaluation of spasticity, or we can use a therapeutic nerve block to manage spasticity. But despite its long history and safety profile, its use has declined. Many have completely abandoned it. Most of the young consultants either have not performed or have not seen such procedures, but it remains a cost-effective option. Phenol is also called as carbolic acid. While doing spasticity management with phenol block, we can do a closed perineural injection, or a closed motor branch block, or an open motor branch block, or a motor point block. And we use primarily those nerves who either are purely motor nerves or have a minimal sensory input. Phenol preparation comes in two kinds, aqueous or glycerol. Glycerol diminishes the necrotizing effect, and aqueous solution induces marked endoneural damage. Aqueous solution penetrates the perineurium better. We usually use 3 to 5% solution for percutaneous blocks, and 3% glycerin solution is favored for open blocks. And our setup, we use 5% aqueous solution of phenol. After doing a block, it reduces the amplitude of M response, but it relatively preserves the voluntary strength. It destroys exons. Type A alpha are affected preferentially, Many other studies have shown that it has no preference and it blocks all the fibers, and histology shows persistent fibrosis. The duration effect varies depending on the site of block, concentration, volume, procedural dexterity, date of manufacturing, how many injections we have repeated, and on an average, it's around 6 months depending on the procedural dexterity. It can vary from a couple of months to 6 months. It has its own bag of side effects. Local pain and swelling. One of the most common side effects is dysesthesia, though we have not seen it commonly in spinal injury, but yes, we have seen it in cerebral palsy. Sometimes there is peripheral edema, tremors or convulsion if the dose is too high, CNS depression, deep vein thrombosis, cardiovascular collapse, or sometimes prolonged sensory loss if we have inadvertently injected in a sensory branch. Due to subcutaneous injection, it can have skin slough, but that's a procedural mistake. Sometimes it can have extreme motor weakness, or accidentally an intravascular injection can be done by mistake. The dose is usually 0.25 to 0.5 mils of 5 to 6% of solution. The lethal dose of phenol is 8.5 grams. Zefonte et al. Recommend 1 gram per session, maximum 20 ml of 5% aqueous solution. We at our center usually don't go beyond 12 mils in a single treatment session. The common problems that we see around us is shorter internal rotation, where we can have either a pectoral nerve block or we can have a motor point block for pectoralis or subscapularis, or arm adduction, where we can have thoracodorsal nerve block or a motor point block in latissimus dorsi. Elbow flexion attitudes, we can do musculocutaneous nerve blocks, or a motor point block with phenol for biceps and brachioradialis. If we have wrist flexion, we can do motor point block for flexor carpi ulnaris and flexor carpi radialis. For finger flexion, we can do flexor digitorum superficialis motor block. And if we have thumb in palm deformity, we can have a nerve block at recurrent motor branch of median nerve, or we can have a motor point block for opponens pollicis, flexor pollicis longus, and flexor pollicis brevis. In lower limbs, if we have knee flexion attitude or knee flexor spasm, then we can have either a sciatic proximal nerve block or a sciatic distal nerve block or a motor point block for hamstrings. If we see scissoring or hip adductor spasticity, we can do an obturator nerve block, or we can do an adductor longus motor point block. For equinus or plantar flexor spasticity, we can do a posterior tibial nerve block or a motor point block for gastrocnemius. For hip flexion, we can do a motor point block for iliopsoas. If there is a stiff knee gait or a knee extensor spasticity, we can do a motor point block for rectus femoris. I won't go into the details of the procedure, but will give you a snapshot of how we perform it. Thoracodorsal nerve exits posterior cord and moves along subscapular artery along posterior wall of axilla. It terminates in latissimus dorsi, and the spasticity of latissimus dorsi causes shoulder adduction and internal rotation. Medial and lateral pectoral nerves are small and purely motor nerves. Medial pectoral nerve innervates pectoralis minor and lower portion of pectoralis major. Clavicular portion of pectoralis major is supplied by lateral pectoral nerve. Pectoralis major causes humeral adduction and internal rotation, and pectoral minor depresses and rotates scapula. Previously, we used to use only nerve locator, but now we use a nerve locator along with ultrasound while we are doing the block. And we can see here the nerve lying near the thoracoacromial artery, sandwiched between the pectoralis major and pectoralis minor. And here it is mostly a motor nerve. Musculocutaneous nerve exits lateral cord travels obliquely and laterally to supply coracobrachialis, biceps, and brachioradialis. It also gives some sensory supply to radial aspect of the forearm. Again, we need help of ultrasound as well as a nerve locator. The musculocutaneous nerve lies sandwiched between the biceps and the coracobrachialis. And once we locate the axillary vein and axillary artery, we can see it lies between the biceps and coracobrachialis. For the recurrent branch of median nerve, the motor branch of median nerve, we can draw a straight line from the radial border of middle finger to the cardinal line, also called as Kaplan's cardinal line, and where the lines intersect each other. Here in the diagram, we can see A and C, and where the A and C intersect with each other, we have location of recurrent motor branch of median nerve while it enters the thenar muscle mass. And we do this block to manage thumb in palm deformity. For sciatic nerve block, we do posterior approach, particularly in cases of spasticity secondary to spinal cord injury. We draw a straight line from the posterior superior iliac spine to the greater trochanter, and midpoint, a couple of finger beds below, we can locate the sciatic nerve. We can also do a distal sciatic nerve block selectively for hamstring by choosing a landmark from ischial grossly 20% of femur length and 33% of femur length towards the lateral femoral condyle when we want to reduce the spasticity secondary to hamstrings. For obturator nerve block, we can either do a direct block at the obturator nerve, or we can do a double block, blocking anterior and the posterior branch. For obturator nerve block, we mark 2 cm medial to femoral artery below the inguinal ligament. We palpate adductor longus tendon 2 cm below and laterally from the pubic tubercle. We enter inside, from inside to outside, and with the help of nerve locator and ultrasound, we can perform the obturator nerve block for adductor spasticity. This is our standard setup where we use a linear high frequency ultrasound probe with a frequency of 7.5 to 11 megahertz, along with a nerve locator and a stimuplex needle. Thank you.
Thank you very much. Thank you talking about nerve blocks, reminding us about nerve blocks. When I was young, it's a very common thing. It is really, I'd forgotten about them as well. We'll have questions and discussion at the end of the session. So our next speaker, I would like to invite is Dr. Gupta. And Dr. Gupta is working in rehabilitation medicine. In current affiliation, professor and head of Department of Neurological Rehabilitation, National Institute of Mental Health and Neurosciences in Bengaluru. And he's going to talk about ambulation of spinal cord injuries and conventional methods to robotics. So, Dr. Gupta.
Thank you. Thank you very much, and good evening, everybody. At the outset, let me congratulate the organizers for organizing such a wonderful conference virtually. And the topic is ambulation following spinal cord injury, conventional methods to robotics. Am I audible and my slides are visible?
Yes. Thank you.
Okay, thanks. Okay, so the locomotion is an important component of spinal cord injury rehabilitation. We know what are the advantages because it helps in combating the osteoporosis and slow bone loss, helps in alleviating bladder and bowel symptoms. It helps in reducing the spasticity and preventing contractures, especially in the lower limbs, preventing pressure ulcers because of improved mobility and access, and it has got its psychological advantages. But there are certain problems faced by the spinal cord injury patients for obvious reasons, because of this motor weakness and paralysis and spasticity. They have high energy demand. They have to use their upper extremity more to hold the assistive devices. Muscle spasticity could be a problem, or if muscle atrophy, especially in patients like Kodaikwana or in the chronic spinal cord injury patients, they find it difficult to don and off the orthosis. And there are always chances of falls and fracture risk because of the weakness. And old age is added disadvantage in these group of patients. And it may not be a priority in acute inpatient rehab, especially the patients who are having a lot of complications like pressure ulcer, severe symptomatic UTI, sepsis, and all these issues. So what are the types of locomotion we come across in spinal cord injury patients? One type, say the most primitive type, the patients are non-ambulatory. They are bedridden, they are not able to do anything. Or therapeutic ambulation, that is the first part which we teach our patients, where for the sake of just upright standing, we make the patient to stand, but they would be requiring long orthosis, assistive devices, therapists would be helping them. So that is only a therapeutic ambulation. Then the next grade would be independent ambulation, where the patient is able to walk for some distance. Say patients are able to walk for 2 or 3 meters. So household ambulation, what we call usually is if the patient is able to walk for 10 meters, so at least the patient can go to toilet from the bed, can go to kitchen. So that probably is good enough to make patient independent ambulator within household, but not amenable for community ambulation. For community ambulation, we believe patient should be able to walk for minimum 150 feet or more, should be able to don and off orthosis on his own, and should be able to stand from the sitting position. So that would make him the candidate for him or her candidate for community ambulation. In general, we believe for community ambulation in spinal cord injury patients, they should have hip flexors power minimum 3/5, or at least one side of quadriceps are 3/5, so that they can be given one side long caliper, one side short caliper, like one side KAFO, knee ankle foot orthosis, other side ankle foot orthosis. And if the proprioceptions are intact, so that we can cut down on the sensory ataxia, and these patients can be trained. And most common of these patients, other than incomplete motor injury, we would see in Kodaikwana patients. If you want to prognosticate what are the chances of a spinal cord injury patient if he or she is likely to walk in future in rehabilitation setup, once the patient has been transferred to us, like in our setup where we get more non-traumatic spinal cord injury patients as compared to traumatic spinal cord injury patients, then you have to probably, according to the Asia impairment scale, you can say if the patients have motor incomplete injury, they have more chances of walking. And if they have Asia D status, we believe as much as 75% chances of patient becoming independent ambulator in future or at the time of discharge from the rehabilitation setup. And if the patients are having motor incomplete injury, we believe there is no difference between tetraplegia and paraplegia in terms of potential for locomotion. So what are the important components of gait training in these spinal cord injury patients? We know activity-based training, which is the simple basic activity where patients have to do 4 to 6 hours activity with the help of splints, with the help of assisted device, with the help of therapist. The walking could be over ground or walking could be on the treadmill with or without body weight support. We know the concept of central pattern generators, which are in abundance in the lumbosacral spinal cord. And this is probably the reason the spinal cord injury patient, even with complete cord transaction, are able to walk, because they're able to generate walking because of these CPGs or central pattern generators. Of course, training-induced spasticity is important component in these patients for gait training. Weight bearing is important. Muscle activation, especially the antagonist or the weight bearing muscles. And sensory inputs of course help in ambulation in these patients. These are some of the examples of conventional gait training in our center. You can see the patients are using conventional methods. They may be using elbow crutches, using parallel bar, or the patient is walking using the walker, the knee gaiters, and the therapist is helping, or the patient is using walker for walking and the long calipers bilateral for gait training. So these are some of the conventional methods which are still very effective in these patients for locomotion. Then there are some relatively recent technology which have come in the last 30-40 years, like electrical stimulation or brain-computer interface, robotics, and exoskeletons used for the gait training. Activity-based therapy, as I told you, is a simple basic thing where patient has to devote a lot of time every day, 4 to 6 hours gait training with or without assistive devices, calipers, with the help of therapists, and training has to go on for long term. So this is one study where the authors had taken 48 spinal cord injury patients, adults more than 18 years of age, and all of them were having chronic spinal cord injury of more than 1 year duration. All of them were motor incomplete, Asia C and D, and 9 hours per week of activity-based training. The outcome measures for most of these training or the research part remain the same: 10-meter walk test, which is most commonly used for the speed, walking speed or gait speed; 6-minute walk test, which is used for the gait endurance; timed up and go, just to see their balance also; and spinal cord independence measure, or the SCIM test. What were the results? The patients showed not only neurological recovery, which was significant at the end of the training, but they showed good improvement in gait speed as well as endurance at the end of the training. So we believe activity-based therapy has the potential to improve not only patient, remember this patient was chronic spinal cord injury patient, so they do show neurological recovery as well as functional recovery in incomplete spinal cord injury patients. Our own experience, we recruited some 66 spinal cord injury patients, and more than half of them were non-traumatic spinal cord injury patients, young patients, 32 years of age group, and mean duration was less, around 3 months, and they had to stay with us for more than 5 weeks because we can't do it on OPD basis. Once the patient has gone back, it's difficult to train them on OPD basis, and majority of them were having dorsal or lumbosacral insult. What were the results? Functional outcomes using Barthel index, spinal cord independence measure, or walking index for spinal cord injury, or the WISCI, commonly known as. All 3 tests showed significant recovery at the time of discharge in these patients. And we tried to correlate their walking ability according to WISCI, that is a walking index, with their other parameters like length of stay in rehabilitation, duration of injury. So what did we find? The duration of injury was lesser the duration of injury, or the earlier you recruit them for the training, better are the results of the walking ability in these patients. And they have a direct correlation with Barthel index score on the SCIM, which are the functional outcome measures, and improvement in the ACE status. So walking index is directly proportional to their functional recovery as well as their neurological recovery. Then there is a body weight support treadmill training, which came into being probably 1989. The pioneer is Dr. Edgerton and his team, and 1989 we had got this body weight support treadmill training, and it you can do unweighing up to 60% with this method. You have to take the support of a therapist who's going to promote your ambulation. Treadmill you have to walk, you have a harness, and you are suspended, and this suspension can be used for unweighing. And this training also, we believe, induces neuroplasticity and helps in patients in walking better. The next step is, instead of walking the treadmill, so why not make the patients walk on the overground? So that next step was the equipments like 0G, where the body weight support was there, of course, but the patients were asked to walk instead of treadmill, walking on the ground, and they are able to cover actual distance. As you can see, suspension is there through the ceiling, and patients are able to actually walk over ground instead of treadmill. Then recently, last 15-20 years, we have robotic gait trainers. Here you have the harness, of course, where you can do the unweighing. Patients with complete spinal cord injury can also be given this exoskeleton, and patients have to walk on treadmill. No therapist can engagement is required, and patients can walk. It's a totally robotic gait training, and the patients can be, spinal cord injury patients can be trained to walk with this. Does it work? The Locomat, does it have added advantage over the other conventional rehabilitation therapies? So there was one systematic review or meta-analysis published in 2017, and this particular systematic review included more than 500 cases, 10 trials, and robotic assisted gait training versus other rehab measures. The outcome measures were similar to the previous study which I mentioned about, and their functional ability, they used WISCI and functional independence measures. What were the results? But the robotic assisted gait training had effect in the acute phase as well as in the chronic phase in improving their gait speed in spinal cord injury patients. In terms of endurance, in the acute stage, they found significant better effect if the patients are trained with robot, but in the chronic stage, no significant difference was found. Functional recovery was observed in the acute phase, not in the chronic phase. And by effect on balance using timed up and go test, they observed in acute stage spinal cord injury, there was no significant improvement, but the robotic trainer had significant effect in patients who were having chronic spinal cord injuries. Spasticity, no effect was found, no significant advantage of any method in both acute and chronic stage. Then the next stage, we had exoskeletons and spinal cord injury for walking. Exoskeletons were wearable orthosis, and they have their own energy source, so the patients can be made to walk. And they can be made to sit and stand, they can be trained, and they can do the community ambulation wearing these orthoses, but they have better quality of life. But there are certain disadvantages with these exoskeletons, the most important being the exorbitant cost. Technology is not available in a lot of countries, so exorbitant, and you need to give extensive training to all these patients in order to walk in community ambulation independent. Excessive weight of the battery, which they have to carry as backpack, and the battery weight could be 12 kgs, 15 kgs, 20 kgs. So all those were the disadvantages with these exoskeletons. And these are the commonly available exoskeletons in the market. And I have taken few studies, recent study. This study is with Indigo, the US product. And this particular Indigo was used in a multicentric trial with 32 chronic spinal cord injury patients. All were traumatic spinal cord injury patients. Age were more than 18 years, and both complete and incomplete spinal cord injury patients were recruited in the study. Outcome measures common as used in the earlier studies, and they were trained 3 times per week for 8 weeks. And the conclusion, they observed patients were safe. There were no adverse events like falls or getting injured, improvement in walking, and improvement in donning and doffing of the orthosis was also observed. Another one is the Cyberdyne. Cyberdyne is using the hybrid technology, and it has the EMG based surface biomarker, which is stimulating the key muscles as well as the battery operated system. And again, this study included one study which included 55 chronic spinal cord injury patients. 12 weeks of body weight support treadmill training was given to these patients along with the Cyberdyne, and outcome measures as mentioned earlier. And what did they observe? 10-meter walk test, the patients were able to walk taking 37% less time. So their walking speed improved. Their endurance improved by 50%, irrespective of age of the patients. And age and level of lesion insignificantly affected functional outcomes at the end of the study in this using this particular exoskeleton device. As I told you, the cost is exorbitant, and this is the exoskeleton which has been developed by Indian startup Bionic Yantra, and we have acquired this equipment, and we are collaborating with AIMS, we are collaborating with IIITB. As you can see in this, wearable orthosis is there, and you have suspension, overhead suspension, and weighing system is available, and the weight which is usually carried in exoskeleton by the back as backpack, we have embedded this in this panel so that patients don't have to carry weight. But as you can see in this picture, the advantages are huge. The cost is very less. It is indigenous technology, but the disadvantages, community ambulation is not possible. So it is a training module. We can train the patients, and we are already running 2 projects, one with spinal cord injury and one with stroke patients using this exoskeleton device. So I'll conclude. Lesson from the past about technology. Great technology not necessarily transformed into the success. The research should be useful and should be for the healthcare benefit of all. There are certain barriers to deployment of technology, and in a country like India, of course, exorbitant cost. The cost is a big issue, and then the material should be locally available. It should be feasible and accessible to the patients. So these are the issues which we have to keep in mind while rehabilitating the spinal cord injury patient. Use the technology, but don't leave the conventional methods. That's my message. Thank you.
Thank you very much, Dr. Gupta. An excellent talk, really not showing only that there's an improvement in ambulation, but I'm sure it's a big morale booster for a patient with spinal cord injuries. Thank you again. So our next speaker is going to be Dr. Jun Zhang, is Vice Chairman, Department of Neurosurgery, Zhenhao Hospital, Shanghai Jiaotong University School of Medicine, and has a personal experience of over 4,000 MVDs. And he's going to talk about surgical experience with percutaneous balloon compression of trigeminal nerve. Dr. Zhang, please.
Hi, thanks for having me. So today I'm going to be talking about functional neurosurgery. You know, in Asia, we got more trigeminal neurological cases than other area in the world. So we did a lot of MVD cases. Until later, I thought the trigeminal neurological case because some different with hemifacial spasm. In hemifacial spasm cases, we can almost found the affecting artery in this area. That means exit of the fifth nerve in this area. So it's easy. But for trigeminal neurological case, we got some problem. We can always find the affecting artery And sometimes the catheter can be anywhere around the nerve, cranial nerve, the the fifth cranial nerve. So today I'm talking about other processes besides the MVD. I show you my screen. Okay. Okay, can you see my screen? You got it?
No.
Okay. Okay. So I just talk about my personal experience with
no, we don't see this. We don't see the screen.
You don't see the screen. Okay. No. Try again. Okay. Now, can you see me?
Yes.
Okay. Okay. Let me do it. How about now? It's okay?
Yes, thank you.
All right. So I just share my experience with this minimal invasive process. So first of all, we should know how does the percutaneous balloon compression work. So we should know where's the target of PVC. So people will say just easy. We just puncture the foramen artery and put a balloon inside the max cavity. That's true, but the detail we should targeting the ganglia, the trigeminal ganglia. What's the ganglia? You must know the dorsal root ganglia. So that's for the body. For the facial sense, this is semilunar ganglia. So this is different ganglia. So for the other process, say radio frequency, glycerol-rhizotomy, gamma knife, they all just stop the peripheral nerve. What does that mean, peripheral nerve? The peripheral nerve can repair and regenerate after injury. So they always got the current sooner or later. But we should cut here, block here, the neuron. Neuron do not regenerate. So when we put a balloon in the ganglia, in the semilunar ganglia, that means the power of the trigeminal. I mean the switch off, power off. So that's really working, I think. So why the pair? People always say the pairs, the shape of pair is very important. Why? I'll draw a picture about this max cavern. This is the petrol bond in the middle fossa. This is the posterior fossa. And the palm is here. Trigeminal root, trigeminal rootlets. Here is the ganglia. And this is the branch, V3, V2, V1. And here is the target for MVD. And here is the frequency, radio frequency, just here. And actually, this is the same effect to target here for glycerol-rhizotomy. But this is the PVC target. This is a neural ganglia. Neural is not renewable. So when we put a balloon and inflate it inside the max cavity, it should be like a shape of pear. So a sufficient compression of the trigeminal ganglia cannot achieve until the max cavity is artery filled. When it is the artery filled, it will show a shape of pear. So that's a pear is very important. That means you really put a right position of the balloon. So the balloon should be focused on this area. So anyway, we should have a head. If we saw a head, that means we're inside this area. And some people will show us lots of pictures. We saw there's a bubble. They don't care. They say it's okay, it doesn't matter. It's really doesn't matter. I show you. We get a gas, just a millimeter, a cylinder gas until later it's pushed out. It's very small. How about this? We put a control agent, liquid make a bigger. So if you want to qualify,
there's a lot of noise in the background. Is everybody muted? I hope.
I'm sorry?
No, you're okay. Carry on.
Okay. So where I qualified it, we put the balloon. This is with gas. This is with liquid. When we push the syringe, so slowly, just quickly. So the small balloon, bigger balloon, small one. So this is just the 0.4 milliliter. This is really 1 milliliter. So if you deemed it in this shape, you thought this is totally a 0.9 milliliter. It just 0.6 liquid plus 0.3 gas, but actually that's same 0.6 milliliter, and you just got 0.1 gas, actually just 0.7. So maybe as a matter of fact, just a small area, small volume, even more small, but this area just facing ganglion. So that's more important in this area. So bubbles really doesn't matter. So how to make a standard pair? So I show you some tips. So lots of people just focus on the point, the puncture point. So I don't think that this is important. You should think in your mind the anatomy first instead of the surface of your face. So this is the middle fossa. This is ganglia. Oh, no, I'm sorry. This is the trigeminal V1, V2, V3. So this is the foramen area. When you put this foramen area, when you put a needle like when you follow the textbook, it will tell you this is just 2.5 millimeter beside the mouse. If you put this is the point and put a needle inside the foramen area, that will go in this way, which leads to a picture like this. We got a stuck outside the neck, go out of the neck because the stuck is here, not here. So we should make a good angle, not this angle, like this. Oh, this is good. So the stuck go out from the header. So we should move the stuck here. If you want the tip here, you should put this area is low, much low. Then this B point should be high. So let's make a line from A to B and extend it to the surface. This is the third point. Like we shooting, we should aim 3 points in a straight line. So that's a really exact point we make a puncture to open the skin. The skin, no incision, just a point, a puncture it. So not this area, a bit high. So then you point the ball, the center of the ball, and don't go in a vertical angle. You should go like this, a bit high. So this is the right side should go 11 o'clock. This is in anterior. When you go to the posterior, that's 5 o'clock. So this way, that's exactly go to this side. So when you picture the point, not just with a ruler, with a ruler to measure 2.5, not do that. Like I don't do that in spine surgery, fixation with a screw angle. I just follow the fluoroscopy and the anatomy. That's more important. So first, A point here, just in the ganglia. B, the foramen area, and C in the area on your face. And I never put my finger inside the mouth. It's needed. They don't need it. Because when you push the needle, it's actually already inside the corridor. That means between mandible and the maxilla. It's impossible if it go outside, go into the oral cavity. It's impossible. Don't do that. No finger in mouth. So I close the mouth to how to seal it. Don't make a draw. No point, no line, just feel with my finger So when we go according to textbook, we'll go this way, vertically. If we go vertically, we go outside the max cavern. So that means just the inline of the max cavern. If we go my angle, you see, it totally inside the nerve, So that means the more proper angle. Then we got the penetration. After puncture, we have the penetration go through the ganglia. So if we use a soft cassette tip, it go anyway. We don't know which way, like this, maybe go this. So I would suggest to use make a tunneling. So number one, when we use the needle, the cannula with the obturate, the first step to punctuate. When we go to the inside just to puncture the foramen orb, I withdraw the obturate. Then I put a thinner stylet. That means we can puncture the cavern, the max cavern. Then I'll put a thick stylet. So just to make a tunnel for the cassette entry. So from this area, I just prejudge the future location. That's okay. So then finally, I put the cassette go forward. So that's I make a standing the pair. So if you want to know how long I should keep the inflation, I think that's not important. Not too long. Too long time will make people get a very numbness after surgery. So if you achieve a standard pair with well-rounded, you should focus the pressure against the ganglia area. That means the bottom. So if you got a standard pair, a 100 second compression will be enough. And I think if you make a good pair, the patient can totally pain-free. And after 3 weeks, he adapted the numbness hyperelasticity. He think it's okay, but it's very happy without the inconvenience after the surgery. It's just like MVD, or headache, throat, and embarrassed, something like that. That means easy. And I think this is a simple, easy, and reliable procedures. So our purpose is just a satisfaction to make pain totally pain-free, and we don't need to do a gaudy surgery. So I think the simple, the better, the easy, the better, the less, the better. So that's my philosophy. Thank you so much. Thank you for your attention.
Thank you very much, Dr. John. I'm sure there'll be questions for you. So we have another 2 talks. After that, maybe anybody who wants to make comments or questions, they could do that. Thank you again. So our next speaker is Dr. John Solomon. He's head and associate professor in Department of Physiotherapy, Manipal College of Health Professions in Karnataka, and in charge of neurosurgery physiotherapy in Manipal. And he's going to talk about getting back on feet after neurosurgery. Dr. Solomon, thank you, please.
Thank you, sir. Thank you for the introduction. I will share my screen. Is my screen visible, sir?
Yes.
Thank you. Greetings to one and all. And at the outset, I would like to thank the organizers for giving me this opportunity. It's been a wonderful conference and a lot of good learning experience since yesterday. I congratulate the team on putting up a wonderful program. My talk will be focusing on mobilization post-cranial surgery. Now, we know that independent mobility was one of the key functional outcome after neurological dysfunction. And as for one of the previous speaker had put forth, it is important that rehabilitation starts much early, and not the rehabilitation phase doesn't happen after the acute phase or after the hospitalization, but rather as soon as possible. So it is important to start mobilizing the patients post-cranial surgery at the earliest, so that we can reduce the chances of complication and also improve their motor and functional recovery. Now, I will be giving a brief on generally how we go about mobilizing patients. So when we talk about mobilization, it is in-bed mobilization and out-of-bed mobilization. In-bed mobilization include all that the patient can be made to perform on the bed itself. And when we talk about out-of-bed mobilization, taking them off, bringing the patient to more upright position, which includes wheelchair mobilization, tiltable standing, supported standing, and assisted walking. So often what we can start with is to start getting the patient from the ICU to after the cranial surgery to come onto a wheelchair, keep them fully supported, monitor their blood pressure, and ensure that they are vitally stable and there is no problem in that. And once the patient is more, the vitals are stable, we proceed with patients to sitting, where eventually we help the patient to get a head control and not much support, but we keep talking to the patient and also work on techniques to improve the patient's ability to hold the neck better and look better. And these activities can also further be used for performing activities in sitting. Now, other than this, to bring about in standing, it is important to get the patient to upright position so that it improves the patient's consciousness and also reduces the chances of pressure sores and other bedridden related complications. And hence, it is important we start bringing the patient upright. These are often we continue with patients who are even unconscious. We can do all of this. Once the patient is conscious, we work on the patient's ability to sit. We start with training them, making them sit on a stable surface, get their ability to sit and move further to unstable surfaces, such as making the patient sit on an exercise ball, train them the equilibrium reactions, get their ability to control and maintain their posture despite perturbations. Now, from there, we move ahead to standing training, training them how to stand straight. We give them feedback, align their body, ensure they learn to keep their feet in a proper base of support, and both auditory and visual feedbacks are used while training standing. And eventually, we move to making the patient try reach out in standing by weight shifting, reaching, and also taking a step and learning to step. Once the patient has started initiating some amount of stepping, we start training the patient for walking. Now, so this is the usual gradual progression, and based on patients' consciousness status and cognitive status, patients' motor deficit, we progress differently. Now, in today's this short talk, we are going to focus on when it comes to mobilization criteria related to two major post-surgical procedure. One is chronic subdural hematoma, majorly after post-pole evacuation, and decompressive surgeries after traumatic brain injuries. Now, when there was a very wonderful first session, and the first few talks yesterday was on chronic subdural hematoma, and today also the first session. So basically, when we talk about chronic subdural hematoma, we see that the most often the management involves whole evacuation with a drain in place with closed drain, and often the patient is asked to lie down for at least 48 hours or so. So there is the early mobilization in chronic subdural hematoma is controversial. So the most common practice is to keep the patient in supine lying position for 48 hours and then eventually get the patient to upright position. It is thought that this, if we mobilize patient much earlier, there is chances of interruption to the brain expansion and also chances of rebleed. Literature even shows up to 7 days of delayed mobilization in these cases. But slowly, this trend has been slowly changing, and the early mobilization has been tried. In this particular retrospective study, they looked at patients who were mobilized after 48 hours and those who were mobilized within the first 48 hours, within the first 24 hours, and they found that there was not much of difference in the complications that was there in the early mobilization group. It was almost the same. There was not much of difference. Now, but it was still a retrospective study. But now presently there is an ongoing trial, the Get Up trial. We have the preliminary results of this study where they have shown that out of the 104 randomized patients, 52 patients mobilized for 12 to mobilize the patients within 12 hours post-surgery and 52 after 48 hours. They found that the medical complications occurred in 39% of the controls, while 25% of the patient in the intervention group, and even the infections was little higher in the delayed mobilization compared to the intervention group. Whereas the recurrence rates were almost the same. And when it comes to Glasgow outcome scale, the experimental group people had a higher, better outcome when it comes to Glasgow outcome scale. Now, this seems to show a trend towards starting mobilization post chronic subdural hematoma much earlier than 48 hours. Now, though these are preliminary studies results, we need to wait and really wait for more results to convert it into our practice. Now, the other thing is the decompressive craniotomies. Now, decompressive craniotomy has become a definitive surgical procedure where there is a high increase in the intracranial pressure either due to stroke or traumatic brain injury. And these decompressive surgeries reduces the intracranial pressure and improves the cerebral compliance. Now, in these patients, after craniectomy, there is often a delayed mobilization, and often there is also a lack of consensus when to mobilize these patients. Now, this was a consensus work that we did in our center. We wanted to develop an early mobilization guideline for patients with traumatic brain injury, and also to test whether if we use this guideline, how is the recovery pattern. So in this talk, I'm focusing on the aspects of guideline that were more related to the post-craniectomy TBI patients. But we did it as a Delphi consensus method with 10 experts in the field of traumatic brain injury, with neurosurgeons, neurointensivists, internal medicine expert, and physiotherapist expertise with cardiorespiratory as well as neurophysiotherapy. So we divided it into components that as one based on consciousness, as I described earlier, and the three other things were when we should not mobilize, the red flags for mobilization, and what are the precautions to be taken, and when the mobilization should be stopped. So the red flags were again further divided into cardiovascular, respiratory, musculoskeletal, and neurological system. So when we look at the cardiovascular system, the consensus was that out of bed mobilization. So it's not in bed mobilization we are talking about, getting the patient out of bed upright position and making them more active should be avoided in case of heart rates less than 50 or more than 120, and systolic blood pressure less than 90 or more than 160. And similarly, diastolic blood pressure less than 60 and more than 100. And similarly, a mean arterial blood pressure of 60, less than 60 or more than 110. And along with that, there should not be a recent MI or an unstable ECG rhythm or acute DVT or pulmonary embolism. In that cases, bringing the patient upright or standing or walking should be avoided. Similarly, respiratory condition, in bed mobilization, we even do between 80 to 90%, but out of bed mobilization, the consensus was that they should at least have 90% SpO2 to be mobilized out of the bed. And if we are going to make them sit outside the bed on a wheelchair with a ventilatory support, the patient FiO2 should be not be more than 50%, keep not more than 10 centimeter per water, and spontaneous breaths less than 8 beats per minute, or any irregular breathing pattern, then we should avoid making the patient sit outside with the ventilator support. Similarly, increased ICP or CSF leak and unstable fractures in terms of spinal fractures and lower limb fractures, mobilization should be avoided. Now, when we shift these patients, craniectomy patients with these injuries, and make them sit or stand, there are certain precautions to be taken, especially related to care to the craniectomy defective area. There should be adequate padding, especially when we make the patient sit in a wheelchair or any other support. And also, if needed, when we can mobilize, we can also use a helmet or something that can protect. All the lines has to be carefully monitored, and in case of any recent seizure, it is better not. We have to be careful. We have to ensure that the period of post paralysis is over, and then mobilize the patient. And in case of any other injuries, appropriate supportive devices should be taken. Now, when we should terminate, when we are mobilizing the patient out of the bed, suddenly the patient starts having an abnormal breathing pattern, or shows any signs of increased ICP, vomiting, severe headache, blurring of vision and all, or the heart rate suddenly starts increasing more than 20%, and if there is a drop in blood pressure, we have to terminate the mobilization. And similarly, if the SpO2 drops below 90, or these are criteria that were there in the red flags, that was not noticed earlier, but after mobilizing it occurs, then also you should stop mobilizing the patient. Now, what we did was, earlier the consensus was, once the patient seems to be vitally mobilized without any criteria, there used to be a mobilization. So what we did, the first phase, we looked at patients and their outcomes. They were kept as control period, and then after the next 3 months, we kept the next year 3 months we kept as a experimental period, and we looked at patients admitted in these two phases, 37 patients in the control group and 27 in the experimental group, and we looked at GCS, disability rating scale, Glasgow outcome scale, length of stay, and adverse effects during the mobilization. We found mainly that the disability rating scale, the patients who were mobilized with the criteria recovered but better. And the main thing was that there was a reduction in the length of the hospital stay. We did not see much change when it comes to GCS and also in terms of mainly the GCS, or Glasgow outcome scale. And there was no adverse events that was recorded during using the regular new mobilization technique. So this was our experience with the new mobilization. But in general, when it comes to mobilizing patient post-cranial surgeries, early mobilization can improve or may improve functional outcomes and promote early discharge. But still, there's a need for more studies and the development of so that we can clearly define clinical practice guidelines for early mobilization of cranial surgeries. So with this, I would like to thank again the organizing team, especially Mr. Sinha, and all our team. Thank you very much.
Thank you very much, Dr. Solomon. Very important talk. You chose two very good diseases. Chronic subdural need to be mobilized early because of their old age mostly. And of course, the outcome of decompressive craniectomies will only improve, 6-month outcome only improve if you have got good rehabilitation services. So I think at this, we'll move on to the next speaker, Dr. Sharma, who's going to talk on a very important subject, neurobehavioral disorders of the TBI and its rehabilitation. So Dr. Sharma is a professor of neurosurgery in SMS Medical College, Jaipur, India. Dr. Sharma, please.
Thank you very much. First of all, I would like to thanks the organization. May I audible to everyone?
Yes, yes.
So please
Yeah.
share your screen, sir.
Yeah.
Yes.
Is it okay?
No, not yet.
Tariq sir, can I have a sentence to speak, sir?
Sure.
Achal sir, please switch off your video, sir. Only slide share. Maybe the net is not that making an issue. So please stop your video and then you can share it well.
Okay.
So yeah, we can see it now.
Yeah. Is it okay?
Yes, thank you.
Yeah, thank you very much. First of all, I would like to thank organizer, Professor Dr. Sinha and Dr. Vishochi to give me a chance to speak upon a topic which is most of the time is overlooked as well as undertreated, and it's very important for overall outcome after the traumatic brain injury. As we know, the neurobehavioral sequelae of the TBI is mainly cognitive disorders in which the loss of memory, language disorders, and intelligence, as well as the behavioral disorders in which the mood disorders like depression, anxiety disorders, frontal lobe deficiency or frontal lobe psychiatric problems, and all this makes the personality changes to the patients, which although is all right from the physical point of view, but is a burden to the family as well as the society. Before the start of this topic, I would like to show you a small short video in which we can understand the problem. A patient who had come to our hospital with head injury with thick subdural hematoma and temporal contusion, we have operated upon. Patient was altered sensorium for a month or so, and then he regained the consciousness. He was okay by physically, but when he came to my clinic after 6 months,
कैसे लगी?
Translate for
एक्सीडेंट
you,
था बाइक से
ऑपरेशन भी local language.
21 तारीख की रात को
when I asked about the nature of the problem,
सोते टाइम नींद आती है।
सोना बहुत कम हो गया, बिल्कुल ना के बराबर है। कुछ ना कुछ सोचते रहते हैं, प्लानिंग के बाहर कब भागना है, कैसे भागना है।
कुछ काम करते हैं
in nature, and he was earning before.
जैसे रेलवे का
आप बताओ
ये थे
किसमें
क्या नाम था नहीं तो उसका आगे
उससे बात करो
आप सर वो ऐसा ही था छोटा था इसके 4-5 दिन इसके साथ कर वो इधर ये सब लिख के दे देंगे तो
ये जो इलाज हुआ चोट के बाद अभी तुम सेटिस्फाइड हो इनके ये जो रिकवरी कि हाँ अभी ठीक है मेरे फादर
नहीं सर जब थे बट अभी वापस डलनेस हो गई
not happy by of our treatment. So this is the problem. As the neurobehavioral sequelae of the traumatic brain injuries are maybe major depression, which is the most common, generalized anxiety disorder or post-traumatic stress disorder, obsessive compulsive disorders, substance or drug abuse, various personality changes in which the aggression is important, irritability, impulsivity, and all this makes the verbal outburst and combativeness. There may be some somatic symptoms also in which the post-traumatic headache, dizziness, fatigue, change in sleep habits or insomnia, and the post-traumatic seizures. All of these affect the quality of life of the patient. Various anatomical regions have been described in the literature for causing these problems of psychiatry, but there is no clear-cut demarcation is been set up. Comes to the depression, which is the major issue after the traumatic brain injury, because it has the high incidence after the mild to to moderate head trauma. We know that depression is the burden to the society because it is increasing, and nowadays a second cause of global disease burden, causing significant dysfunction, disability, poor quality of life in sufferer, as well as poses significant burden to the caregivers. You can see the depression is come after the ischemic heart disease, and the various mood disorders after the traumatic brain injury are being controlled by various neurotransmitters, in which the norepinephrine, serotonin, and dopamine, these three are important, which control major mood disorders. To construct the diagnosis of depression, either depressed mood or apathy, one of these is required, which are controlled again by the various neurotransmitter, or other symptoms like change in weight or appetite disorders, sleep disturbances, psychomotor agitations, fatigue, feeling of the guilt, executive dysfunction, and suicidal ideation. The four of this may require to make a diagnosis of depression. It has a high rate of incidence between 25 to 40% after the traumatic brain injury versus the 70% like in general population, where there was no history of the trauma. Depression is a factor of low life satisfaction amongst the survivor of traumatic brain injury patients. It not only prolonged rehabilitation, but also increased the distress to the patient and his family. There are various risk factors identified to develop the depression of the trauma, in which the pre-existing depression or pre-injury personality type and the low socioeconomic status are the important. To recognize the depression, symptoms of depression may be vary amongst the individuals, or sometimes it is associated with the other psychiatric disorder, particularly anxiety disorders. So the diagnosis or identification of depression is challenging, so that we can treat the patient and manage accordingly. Following brain injury, active screening is essential for the recognition and treatment and prevention of the recurrent depression. Patients with the brain injury are at increased risk of depression, as we have seen in earlier slides. Increased prevalence of depression is observed multiple times point of injury. It's not necessary that we are continuing patient after the trauma with the depression. Sometimes the depression occurs immediately after the injury, and sometimes after 6 months or 1 year. So because of the risk of depression after brain injury is high over the extended period of time, continuing screening over the time is necessary. The severity of brain injury has not been established an accurate predictor of depression. So the need for vigilance across all severities of brain injury are required. While evidence exists for the treatment of depression in the general population, studies involving individuals who have sustained TBI are insufficient to guide treatment for this specific problem. Various treatment options are available for the depression in general population, general person, in which the psychotropic medications, various antidepressant drugs, psychotherapy, neuropsychological rehabilitations, community-based rehabilitations, complementary and alternative medication, and neuromodulation therapies are being described, but it is lacking after the post-traumatic injury. After the depression, the important problem is the generalized anxiety disorder. It has also the high incidence of the traumatic injury between 24 to 27 in various literatures versus the between 7 to 20% in general population. Although cerebral contusions have most commonly implicated lesions involving multiple lobes, but we may have the mixed picture. Generalized anxiety disorder patients have a poor quality of life in post brain injury period. Now, another important disorder is the frontal lobe dysfunction. It is also common because as we know that the most of the time with moderate to severe head injury patients suffers from the frontal lobe contusion or injury of the frontal lobe, in which the pseudo-depressed and pseudo-psychopathic two distinct personality patterns have been described, which are reciprocal to each other. Now come to the rehabilitation part after the patient who have the various neuropsychiatric problem. It is an interdisciplinary type of approach in which the neurosurgeon, neurologist, psychiatrist, psychologist, rehabilitation counselors, even the nurse in the ward, family members, all are required for comprehensive and interdisciplinary approach to treat the patient. Now, for the behavioral approaches, there has been successful application for behavioral intervention in 6 categories of target behaviors. One is inappropriate social behavior of the patient, attention and motivation part, unawareness of the deficits, is change in memory or loss of memory, difficulty in language problem, and motor disturbances. All these 6 targets should be hit to favorable outcome. Now, the rehabilitation part, the involvement of the family is very important because it is a long duration therapy or long duration treatment protocol, and patient remains in the hospital for a shorter duration. So we have to take the family members in our treatment protocol. And TBIs equally most affect family functioning because of the presence of cognitive deficits to patient, disorder of communication by the patient. There may be emotional regression, frontal lobe behavior, withdrawal from the social contacts, inappropriate social behavior by the patient, associated depression, and inability to resume pre-morbid role within the family. So, involvement of family is important. We have to train them, teach them how to treat the patient. And for that, the 3 levers of intervention is required. One is the education to the family. Number 2 is the continuous counseling and the support. And number 3, formalized family therapy. In the education part, family members should understand the problem, the nature of injury, what is going to be the outcome according to the site of the injury. In acute setting, education is the frontline strategy for orienting family to policies, procedures, and rehabilitation center. After that, continuous counseling and support is necessary because it is a long duration treatment. Even in the most intelligent and resources families will feel overwhelmed and tired, and they leave the patient for his own, and that's the problem started. The support by the psychological personnel, particularly the clinical psychologists, social workers, rehabilitation counselors, assist time to time for adjustment of the patient. Primary intervention that is often useful in the acute setting involves helping family members, especially spouse or the close relative of the families are required. Third is the formalized family therapy, in which when the patient discharged from the hospital and the support system has been called off by the medical personnel, then family gives the therapy to the patient for his recovery and to achieve the goal for good outcome. In summary, family therapy is necessary and is useful intervention. Education, counseling, supports are effective during inpatient rehabilitation as well as after the discharge of the patient. We have done specific target studies in our center looking to the various neuropsychiatric disorder after the traumatic brain injury, in which these are the few published articles from our center for the depression, associated fatigue, and quality of life to patient after traumatic brain injury, generalized anxiety disorders. And in results, we can see the quality of life is low in all 4 domains according to WHO briefing quality of life parameters. In depression segment, we found that the 42.15 study population suffered from the depression after traumatic brain injury. Again, quality of life was low in all 4 domains. In anxiety, we have seen that our 11.7% of study population suffered from anxiety symptoms. And again, it carries a low quality of life. we found 40.2% of study population had insomnia, and it is very important, and somewhere else it causes again depression after the traumatic brain injury. We found that the high incidence of the insomnia and moderate after the moderate brain injury, but good thing is that with the short duration type 6 months or so, there is steep decline of the insomnia after the traumatic brain injury. Again, association of insomnia and quality of life, we can see there is a low quality of life after the patient suffering by the insomnia. We also done few studies for the treatment part in which we have used the sertraline to treat the various psychiatric disorder, particularly insomnia and depression. And in that study, we took total 80 patients, in which 50% was given the sertraline 50 milligram OD. Other half served as a control. And in the result, we found that there was significant improvement in the mood symptoms in study group, with significant improvement in the quality of life in the study cases. So in the results, we found that all the 4 domains of quality of life improved significantly in sertraline group than the control group without sertraline treatment. Again, a short interview by a patient in which we have given the sertraline. Initially, the patient was very aggressive, irritable, was not controlled by the members.
होश में आने के बाद फिर क्या प्रॉब्लम?
अंदर हम सबको अंदर भेज देते थे, खुद ही अकेला रहना पसंद करते थे।
ट्रीटमेंट चालू किया, दवाइयां दी इस चीज के लिए, अभी क्या महसूस कर रहे हो?
The patient attendant
वगैरह, लेकिन
ask about the
पहले से और बाकी हमसे बात करना पसंद नहीं करते।
तो जैसे अपन इलाज के बाद ऑपरेशन के बाद गए थे, तुम परेशान में थे, उठ के भगते थे, मानते नहीं थे, अब ये काफी शांत है जैसे दिख रहा। अब तो संतुष्ट हो?
ओवरऑल रिजल्ट इज
हाँ, ट्रीटमेंट से संतुष्ट हैं।
They are satisfied by that.
नींद आ जाती है इनको?
In conclusion part, management of TBI should also focus on the treatment associated mood symptoms, which is likely to be associated with poor quality of life in these patients. Sertraline has been found to be effective in the treatment of depression with significant improvement of quality of life in TBI patients. Further research are required carrying a large cohort and long duration, as well as comparison between the control group, as well as also study should be focused upon the various neuropsychiatric rehabilitation to see its role to begin in the treatment protocol in starting, so that most of the patients can achieve their full recovery. Thank you very much. And I also congratulate organizer for a very good conference, virtual congress, and I also wish all of you your safe and good health looking to this pandemic era. Thank you.
Yeah. Thank you very much. A very important topic, which was required because a lot of the head injury patients suffer from these depressions and a lot of problems, and the families are upset by that also. So I think with this we come to the end of this session. So if there are any questions or comments, please, Dr. Jain, maybe you can organize that. Thank you.
Thank you very much, sir. I want to give a big thank you to Professor Andres Rubiano and Professor Tariq Khan for their kind moderation and all the speakers. So there are a few questions for Dr. Sharma, Dr. Achal Sharma. Who should give the indication for NR in your setting and who pays for it?
For this study, we took our psychiatric colleague with us and a separate assessor to find out the various neuropsychiatric disorders. And of course, very important that we should when we understand the problem, we should see the various neurobehavioral disorders from the beginning of the treatment, and we should take this protocol in our usual habits to treat a moderate to severe head injury patients, because it carries a significant disability portion.
Thank you, sir. So there's another question from Professor Massimiliano Visocci to Dr. Jun Zhong. He says,
yeah, thank you very much for the opportunity.
Sir.
I don't know if Jun Zhong is connected anymore, but I was very impressed. I know Jun Zhong since many years. I know that he's a very expert microvascular decompression surgery, and I've learned from his group, Li Shiting, Jun Zhong, Wenchuan Zhang, all the updated technique. And I was a little bit surprised that the school shift from the well-known and accepted worldwide microvascular decompression to the old-fashioned micro balloon compression. This is a very impressive revolution by involution, in the sense that apparently microvascular decompression seems less precise surgical technique, more grossly technique, even from the pathophysiological point of view of its action on pathophysiology of trigeminal neuralgia. And so I wish to ask him, which is the main topic, the main issue, the main reason why they moved from microvascular decompression to microballoon decompression. That's my question.
Can I give comment? So we all know that rehabilitation is in level of infancy in developing and underdeveloped countries. And as per our Westphalia Madon, involvement of neurosurgeon is very, very important factor for rehabilitating our patient. And I thanks to Dr. Joshi, is our colleague in our hospital. With this cooperation, we started neuro rehabilitation unit in my department. And as Dr. Anupam and Dr. John said, that conventional rehabilitation is very important. And if patient get, we can make them good in the rehabilitation, and that make change in the patient outcome. And that we are doing in our place. And in my opinion, not for neuro rehabilitation, overall for rehabilitation, we must start awareness program in our country, especially the developing and underdeveloped countries, like we do the awareness program for prevention of head injury. I think this is my suggestion. Thank you.
Maybe I can just add to this. I still have some problems with my video. I don't know why, but I congratulate you on this development which you have in Jaipur, and very happy to hear. And I've heard this talk some time ago already, and always enjoy it with these excellent results. And wish you all the best. Good luck. Continue like this, because that's essential for our patients, that they get further treatment afterwards. Once we have done excellent surgical procedures, they still have a long way to go before they go back to their normal life. So congratulations, and also for this excellent meeting. Thank you very much. Thank you.
So there's another question regarding any data regarding incidence of head injury in patients with known psychiatric illnesses. I think that's referred to Dr. Sharma only.
Yeah. Which the studies we have done in the individual psychiatric problems rather than the total psychiatric, all the disabilities. So we did till now, we did the studies upon this depression, anxiety, fatigue, and insomnia. We did not do the study of overall psychiatric problems in our this department. But of course, it is necessary. because literature says that it is as high as about 40 to 49% in the cases the patient suffer from the psychiatric illnesses of the post-traumatic illness.
I have a question that what is the future of nanotechnology to cope with the current scenario of COVID? Any inputs regarding that?
Sir, I think Dr. Russell J. Andrew was the person who mentioned about the nanotechnology and something wrapping off the protein and the virus, the lipid membranes. So I think Dr. Russell J. Andrews, are you there?
Oh, from what I've seen, he left the meeting, but we have close cooperation with him since many years, and it's certainly fascinating to see the development of this technique, and we have to be aware of. But it's really it's fascinating, and we have to see in many instances where it can be possible to involve this in spinal cord injury, in brain injury, and technology in the brain-machine interfaces. Certainly also depending on nanotechnologies. And we have to be aware of this as neurosurgeons. So I always like hear him talking, but at the moment, very few clinical applications are really already in the market.
Thank you.
I think. So I again thank the moderators, Professor Tariq Khan sir and Professor Rubiano, and all the speakers for sharing their experience and for the untiring efforts also for doing efforts post-surgery in the physical as well as in the much leftover cognitive and the psychological improvement of the patients. I now request our Professor Massimiliano Visocci, the co-chairman of WFNS committee and also the co-organizer of this virtual meet, which has received a lot of appreciation. Sir, please can you come up the virtual dais and give away the vote of thanks, sir. Professor Massimiliano Visocci, please.
Thank you so much for this opportunity. As a matter of fact, this is an honor that should be tributed entirely to Professor Signa, since he is the true inspirer of this wonderful Congress. And as far as I understand, I think that this is the first example in COVID area of a true worldwide Congress with a big number of attenders, more than 130, 150, and with the largest number of speakers, 50 speakers from ASEAN, Australasian Society, from Europe, from United States. I think that a little bit confused for such outstanding results obtained by this continuous activity and organizing capability of our Professor Signa. This work comes from many weeks. I know that he profused all his energies to organize, to collect such outstanding speaker, and I think that the result is a prize for Signa, for the Neurorehabilitation Reconstructive Committee, and for the entire World Federation. So I really thank Virendra, and I ask Virendra to close this wonderful Congress. Please, Virendra, close the Congress.
No, you have to do a closing remark. I have done this work with your cooperation only, because no single person can do this job. It is a group or combined effort of everyone, and I am very fortunate to have my co-chairman like Dr. Visocci, who always with me, not like 1 and 1, 2, he is always 1 and 1 like 11. So thanks everyone, all the moderator, speaker, Dr. Sir Teasdale, and all the keynote speakers for participating in this meeting. And personal thanks to Dr. Tariq Khan because he supported our meeting, Dr. Dev Pujari for the endoscopy committee who supported our this virtual meeting. So finally, I think we had a good time, good discussion, and I think this will definitely enhance management of our patient at our place and in future. Thank you everyone for joining us.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.